we think that in the COVID situation, how important is the lab and how important are the lab results, and according to that, the treatment is we decide the treatment. So those we were thinking that the diagnostics is a side branch. It is not like that. It is a main branch in the COVID situation, and it was very important to take the decisions and treatment for the COVID. So, and how serious is the patient, and how lightly we have to take, or only isolate, or admit, or in the ICU, or in the hospital. So, it is a theme-based CME, that is lab diagnostics, new challenges and new frontier. So we are going to learn the many new things in the pathology investigations, and according to that we can take the decisions for the treatment. So, and the other programs also we are having. We are having the diary release function, and I welcome first time Dhananjay Kelkar in the IMA platform. Thank you, Dr. Dhananjay, for coming and uh, planning the lecture in this same. So I welcome you all. I will not take much time, and I request Dr. Sanchiti to start the same.
Thank you, madam, for your kind words. So we are starting first lecture on the pandemic pitfalls, pressure, progress, what's happening in COVID by Dr. Madhwanti Abhyankar. I'll introduce Dr. Madhwanti madam. She's a microbiologist of a great repute. She has done her MD microbiology from BJ Medical College. Her expertise in microbiology, mycobacteriology, mycology, molecular diagnostic is unmatched in the city of Pune. She is pioneer in establishing the PCR technique in private lab setup in Pune city. She is a lead assessor with the NABL and is highly respected in our medical field, medical sphere to say. Under her leadership, the microbiology and the molecular diagnostic department at AG Diagnostic is at par with the international standards. Here also I like to mention about the memory of Dr. Ajit Golilkar, under whose I would say leadership we are having this wonderful CME. So over to Dr. Madhuvanti madam, please. Thank you, ma'am. Join.
Good morning, everybody. At the outset, let me thank the organizers for giving me this opportunity to present basically my experiences for actually almost exactly 1 year from where we started testing for SARS-CoV-2 RNA. So let me share my screen. Am I audible, and is my presentation visible?
Yes, madam. Go on, please.
So basically, coronaviruses are not new to us. Many known human and animal pathogens are in the coronavirus family. Alpha, beta, gamma, and delta are the subtypes of coronaviruses. And there is an increasing incidence of outbreaks associated with animal to human transmission, as was seen in this case. So the well-known coronaviruses at the moment are SARS, MERS, and COVID-19. Basically, COVID-19 is a 30 base pair positive sense single-stranded RNA virus. Now, pandemics are not new to us. Since ancient times, there has been record of various pandemics, including in the Greek mythology and history, and also recently the Spanish influenza in the 1900s, and even more recently the H1N1 pandemic, which was in 2009, and where Pune was famously involved as the source of the original case in India. And now, even more recently, since last November 2019, we are experiencing SARS-CoV-2, or the corona as we are calling it. So SARS-CoV-2, or the virus which causes COVID-19 disease, it was in November 2019. identified as a cause of a cluster of pneumonia cases in Wuhan, a city in the Hubei province of China. In February 2020, WHO called the virus as SARS-CoV-2 and the disease as COVID-19, and very soon they declared it as a pandemic. Now, there are various clades of the SARS-CoV-2. As you know, viruses are very prone to mutations, and so the original subtypes have now almost disappeared and have been replaced by several other strains. I think we have all got knowledge of it from the papers, if nothing else. So the global distribution of the clades is mentioned here, as was in probably January, February. And since then, it has obviously changed once again. So what happened was that in H1N1 pandemic in 2009 also, we had designed the PCR for detection of the H1N1 or swine flu virus. And at that time, we did have a molecular department, but the space was restricted and it was randomly situated. And the collection area was open. We didn't have any covered premises. We didn't have any personal protective equipment, and there was no vaccine. So at that time, we had tried to start the PCR, but only state government and local government labs were allowed to do the PCR at that point of time. There were also no kits available. So we had to use a lab developed tests, and only seriously ill and ICU based patients were allowed to be tested. Finally, after trying, we got the testing permission in 2015. By this time, the swine flu virus had become almost endemic. Also, one big difference between 2009 and 19 is there were no social media, no Facebook, no Twitter, no nothing. And WhatsApp also. WhatsApp University was not available at that time. So cut to 2019 and the SARS-CoV-2, as the pandemic was being declared, ICMR took charge and they approved kits for testing for SARS-CoV-2, and private labs were requested to be involved from the beginning, encouraged to start and ramp up testing, and symptomatic people and travelers were to be tested in the beginning. Those were the criteria in the beginning. So on March 25, we got permission to test for SARS-CoV-2 RT-PCR, and we thank the Newberg Group and Dr. Velu's team who helped us in getting the equipments necessary, etc., because we were not geared up for that scale of testing to begin with. So we started testing on 26th March and were the first private lab in Pune to start testing. The most important thing, as far as I was concerned, is there was no positive control, no positive sample was available to me. The kit was there, it had its own positive control, but generally when we start a new test, we get a known positive sample, and that's why we know that the kit, whatever they are claiming, it's correct. So that was really not available to us. So no samples were giving a positive result for almost the first 10 to 12 days. So we sent the first 10 negative samples to NIV, and by chance we got our first positive sample also on that very day. And so we sent all these samples to NIV, and we breathed a sigh of relief once we got that all the samples were concordant 100%. So immediately there was an increased workload and pressure of reporting within 24 hours. Then we had decided to go for home collection, because when the patient has to come to the lab for collection of sample, there is always a chance of dissemination of the disease during the transport of the patient. So we were insistent on going for home collection. The home collection team of technicians had their own anxieties because there was no vaccine available. They were not sure whether the PPE which we had would be sufficient or not. Though we had, our management had organized for the best possible imported PPE which was available at that point of time. So once we started testing, we had a very low workload in March, and subsequently it was increasing, like 2,500 tests in around May and all that. In July onwards, we experienced a spike in the number of cases as well as in the number of positives, which reached a peak in September 2020. So this was the first wave which we experienced, and the corresponding number of increase in the number and positivity of cases, which reached up to 36% at the end of August. Okay, but you can see that actually the peak occurred in June, there was the incidence of positivity was 15%, which suddenly jumped in July to 31%. So the real peak happened over there. And the peak positivity, however, we experienced in August and September. So after that, we have been keeping a track of the testing and the positivity which we saw in the various areas which we are addressing. So we are getting samples from Pune, Pimpri-Chinchwad, Pune rural, and small towns such as Ahmednagar. And these are the graphs which are showing the total number of cases and the total positives. As you can see at the end of the graph, in March, we are experiencing the same number of cases and the same number of positives. So same way for Pimpri-Chinchwad. However, their peak is less as compared to the other areas which we have seen. The percentage of positivity is in the range of 30%. Same with Pune Municipal Corporation. At the moment, we are experiencing in March a positivity of just under 30%. So what are the symptoms? I think you clinicians are more than aware of what the symptoms are. Now every day all clinicians are picking up COVID cases like anything, even more than the laboratory, faster than the laboratory. So a fever of less than 1 week duration, low grade, respiratory symptoms like dry cough, breathlessness, muscle pains, loss of smell and taste, diarrhea, history of international travel, close contact with a known positive case, and so on and so forth. Unusual presentations such as cardiac are known. I don't think I don't want to go into the details of the presentations. What the patient does is take the temperature, pulse rate, and SpO2, because there may be a sudden decrease in the oxygenation and the patient may not be aware of that. So the testing is required by the patient's bedside. And in the beginning, only institutional quarantine was allowed and hospital admission. And later on, the policy has switched to home quarantine. So in the laboratory diagnosis, the chief test is the RT-PCR detection of the viral RNA. There are various RNA sequences which can be detected. Then research lab can also go for culture of the virus on Vero and human hepatoma cell lines. Then detection of antigen rapid tests and detection of antibodies, various like IgG, then total, and against the various proteins of the virus. So ancillary laboratory tests are equally important, like for example, the CRP, D-dimer, ferritin, interleukin-6. Even the common hemogram also gives us some clue about the origin of the disease. So also ancillary radiological tests, for example, like CT scan or HRCT are also done. Then in RNA extraction, because our workload is extremely high, we require magnetic bead-based systems, which can churn up to 96 samples within 1.5 hours. Because currently our capacity or whatever testing we are getting is upwards of 1,000 tests per day. Then the RT-PCR also, we've got newer machines which can address right now 96 wells per run of PCR, and the PCR run takes just under 1.5 hours. So the total result may be available as early as 3 to 3.5 hours. So that is the requirement of the current situation, and we are addressing it in this fashion. So as regards the genes which are used for testing, the E gene is sort of like a screening test because it is given positive by all sarbecoviruses. Confirmatory genes are N gene, RDRP, ORF gene, S gene, depending on the kit which is used by the lab, either the government labs or the private labs. Then any two positives is interpreted as a positive test. Few assays do not use the screening test, they only use two positive interpretatory genes. Few assays are two-step or they contain primers for 3 genes, and also other technologies like isothermal amplification, CRISPR, and next-gen sequencing are available and have been put into place by the various labs. Now, it starts with the simple collection of samples, which we actually are well aware because of H1N1, collection of nasopharyngeal and oropharyngeal swabs. putting them in a single tube of virus transport medium. Virus transport medium may also contain the buffer which can be used to inactivate the virus so as to make the sample non-infectious, so that during transport there is no chance of infection. So other samples which may be used would be bronchial aspirate, BAL, tracheal aspirate, then even stool, tissue, CSF, and blood. Other samples also have been done. But at present, ICMR approved labs are only doing nasopharyngeal, oropharyngeal swabs and respiratory samples. So now there are various questions concerned with PCR. As you know, PCR sensitivity is 70 to 80%. So what happens if there is highly suspected COVID infection and the PCR is negative? The PCR will come positive during the 3rd to 8th day of illness. So we may repeat it in case it is required, and you require to document the infection. Then a positive PCR repeat is not recommended by ICMR, but however, it is mandated for certain occasions, like for pre-employment, for travel, for students who are joining their schools and colleges, and for hospitalization as well. Patients with COVID-19 can have detectable SARS-CoV-2 RNA in the upper respiratory tract for several weeks after the onset of symptoms, though prolonged viral RNA detection does not necessarily indicate infectivity. That is why ICMR doesn't recommend repeating the RT-PCR. So the reason for this is replication competent virus is not isolated after 3 weeks of symptom onset. So that has been seen in some studies. Also, 88 to 95% of high-risk contacts have no infection risk beyond the 6th day. So various studies are available. If you go to the CDC website, you can read pages and pages of various studies and conclusions which they have drawn. I'm going to allude a little bit to it later on. So also the infectivity of the person will depend on the severity of his or her illness and their immune status also. So next we go to antigen testing. Rapid antigen testing is used as a point of care test. It is also used on a swab, that means nasal, nasopharyngeal or oropharyngeal swab for asymptomatic or less symptomatic people, or wherever PCR is unavailable or the results will be available very late, then the rapid antigen test can be used. Then it has a sensitivity of between 40 to 80%, but newer kits are being available constantly. So we should keep in touch of whether better kits are available and we can really use this test or not. So role of the rapid test is before hospital admissions, surgery or procedures, mass screening in containment zones. Then if the frequency of testing is high enough, these tests will be useful, even though they have low sensitivity, which is average 56%. Then we come to serological tests, which have a limited role in diagnosis at this point of time. They are expected to be negative in the first week. The ideal time for testing for IgG is 3 to 4 weeks. Then IDSI guidelines at the moment recommend IgG or total antibody test rather than IgM or IgA because of the accuracy. And the antibody tests are mainly based on nucleocapsid and spike protein tests, the significance of which would be to detect post-infection or post-vaccination. Rapid antibody test is at the moment not recommended, and the positive can be confirmed by a different antibody assay. So regarding reinfection, CDC says that the possibility of reinfection be investigated in patients who have repeat positive RT-PCR more than 90 days after the initial infection, regardless of symptoms. Have a repeat positive NAT within the 90-day period or after 45 days to up to 90 days after the initial infection, and have increased symptoms or reintroduction of symptoms. And the CT value of the RT-PCR should be less than 33. The ancillary lab tests, hemogram, CRP, ferritin, D-dimer, LDH, IL-6, LFT, RFT, and TROP-I also should be used, especially in the management and the prognosis of the patients. Then ancillary radiology tests like HRCT with the CORAD score and chest X-ray in patients who don't require HRCT, and so on and so forth. COVID-19 should be suspected in all patients with influenza-like illness or respiratory symptoms, moreover with a history of travel or history of high-risk contact. And unusual signs and symptoms with unknown or undiagnosed etiology, because we don't know much about the disease at the moment. And if possible, all symptomatic patients should be tested for SARS-CoV-2 by either rapid antigen or PCR tests. So especially healthcare workers, hospitalized patients, and those with risk factors should not be excluded. The factors in nucleic acid amplification tests or PCR, a positive test confirms the diagnosis of SARS-CoV-2 infection, may be or may not be symptomatic. A negative test does not rule out infection, so may be repeated in high index of clinical suspicion. It's difficult to differentiate clinically because the mild symptoms are similar in many viral or even non-infectious or bacterial infections. So rapid antigen test is used as we discussed in major containment zones, etc. Then asymptomatic patients, indications for testing include close contact, then screening in congregate settings like long-term facilities, care facilities, then say jails or detention centers, homeless shelters, so on and so forth. Screening hospitalized patients in high prevalence areas, and post-exposure testing within 5 to 7 days after exposure. Then serological tests at the moment can help identify patients who previously had COVID-19. Detectable antibodies generally take several days to weeks, typically for IgG 3 weeks or so. And so they have a less utility in diagnosis in acute setting. Total antibodies can be detected after the first week, but they have to be clinically correlated and they do not differentiate between disease and post-disease. Serosurveillance is the major use of antibody tests, and 32% of samples referred to us had previously tested to be positive by the antibody test, though I don't have the recent statistics for the same. Also, like spike protein antibodies at the present may be used for detection of antibodies post-vaccination. Also, it has been introduced to our labs. So what are the recommendations by CDC? They are continuously giving recommendations for isolation and special precautions. So most adults with COVID-19 illness, the isolation and precautions can be discontinued 10 days after symptom onset, according to CDC. Though present PMC is still preferring to isolate patients for 14 days. So some adults with severe illness may require more, or they may be having replication competent virus. I may remind you that the RT-PCR does not detect live or whether the virus is viable or non-viable. It just detects the RNA. So the role of viral diagnostic testing to discontinue isolation and precautions is not required normally. Any normal healthy person can just discontinue their quarantine after 10 days according to CDC and after 14 days according to PMC. So, however, in adults who are immunocompromised, they may be subjected to a second test to prove that there is no RNA in their sample any longer. So, for regular basis, it's not required to repeat. So, if the symptoms occur again, then you can go for the testing within 90 days if the symptoms appear again. So for adults who develop new symptoms consistent with COVID-19, as I said, during 90 days period. So role of serological testing as per CDC, again, we have already discussed it. So you can diagnose a previous infection, or in case of total antibodies, waning infection current, and also you can diagnose effectivity of the vaccine. What infection control measures to be used? I think everybody is familiar. Use of isolation of patients for aerosol and fomite spread, testing of contact together. Then we increased the housekeeping, which included cleaning of the door knobs and door handles, etc. Biomedical waste management, which our laboratory team has together practiced and our management has thoroughly implemented. Then our lab is BSL level 2 with level 3 precautions. And we experienced in 2009 and 2015 the H1N1 pandemic. So our lab technicians who are collecting samples are immunized for the flu, vaccine. And now, because the COVID vaccine is available for healthcare professionals, all are immunized with 2 doses or at least 1 dose of the COVID vaccine. So we were giving pep talks and incentives because the technicians really are scared for their family, especially children, on whether they will be affected by their exposure to COVID. So they required special training for sample collection, transport, and wearing and removing PPE, though it was already done with H1N1, and many of them are familiar. So we had in the molecular department 4 technicians, 2 doing extraction, 2 doing PCR. And initially we had so much help from the laboratory because there was no other work other than COVID. And we were really desperate during the lockdown because all sorts of precautions and preventions were there. So we didn't have a experience of this much workload in molecular, even though we have a molecular department since 1998 and a real-time PCR going on since 2003. So all this was helped by teamwork from the whole laboratory. And I am proud to say that nobody from the molecular department has tested positive for SARS-CoV-2 from the laboratory. There was a mountain of documentation and reporting conveying to PMC, state government, central government, that is ICMR. It was helped by the various websites and web pages and Excel sheets and so on. We had to do emails, WhatsApp, then update ICMR immediately, other government sites and authorities, and testing and informing within time was extremely important. And our inventory department and IT department have really supported us magnificently. And we had experienced management and staff, and we could work from lab as well as home. We were continuously connected in spite of attending so many meetings by the local government. And we were doing assessments, remote assessments for other lab which were venturing for COVID testing. And I had an amazing support from the lab and home. And according to me, the most difficult part was the documentation rather than the testing. I thank you very much for your patient hearing. Thanks again for the opportunity for this presentation.
Thank you very much, madam, for your excellent presentation. And congratulations that no one turned positive. All of you have taken great care and all have been safe from AG Diagnostic. Nikhil, hats off to you for the thing that a lot of documentation, a lot of things were ordered by PMC, and you stood firm, I would say, and came out brilliantly. It was a very, I would say, best of best work done by AG Diagnostic. Next, I would like to first introduction of the oration for late Dr. Jayant Abhyankar Memorial Oration, Private Healthcare in COVID Pandemic Beyond Profit and Loss by Dr. Dhananjay Kelkar sir. But first I'd like to introduce Dr. Avanti Golwilkar Mendale madam. She is a postgraduate in pathology from prestigious Vijay Medical College, Pune. She has been working with her father, Dr. Ajit Golwilkar, since 2004. Since then, she has carried forward the legacy, I would say, excellently. It is said that pathology runs in her blood, and this fact is amply proved by her expertise in the field. Histopathology and immunology is her forte. She is instrumental in setting the company's direction through strategic planning, implementation of Golwilkar culture to the practice of highest ethical values. She is dynamic and bold leader, always providing all opportunities to learn, to develop, and to contribute towards the company. Thank you, madam, to join also. And I request you to introduce Dr. Dhananjay Kelkar sir, another stalwart from Dinanath Hospital, who is also a COVID warrior and done his best. So I request you to introduce sir. Sir needs no introduction, but I would request you to introduce sir.
Good morning, everyone. So on behalf of IMA and AG Diagnostics, I welcome you all for this oration. This is 16th oration in memory of late Dr. Jayant Abhyankar, known to most of our staff and many of Dr. colleagues as JRA. I knew Dr. Abhyankar since I was a school-going child, but unfortunately, hardly got a chance to work with him. I joined the laboratory in 2004, and we lost him in November 2004, just within 2 months of my joining, as a result of a tragic road accident. His sudden and untimely death was as much a loss to our organization as was for his family and near and dear ones. He has been my indirect guide or a teacher, as after him, I shouldered the responsibility of histopathology department, which was solely his baby till then. I went through a lot of his notes and old reports and tried to adopt a similar pattern of reporting, which most of our referees then were accustomed to. He was a highly intellectual and hardworking person and had been instrumental in setting up our IT and quality systems. My father used to always mention him as Mr. Dependable, and he had been a helping hand to my father and lab running since his PG days. Dr. Abhyankar was amidst the very few pathologists who could complete their PG terms through our laboratory, even though they were registered to do their MD pathology under BJ Medical College, Pune. Since 2005, we've been organizing these orations, and starting with Dr. Anita Boges, we have had several renowned doctors and dignitaries to deliver this oration. This year too, we have Pune's eminent senior oncosurgeon and medical director of Dinanath Mangeshkar Hospital, Dr. Dhananjay Kelkar, sir, to deliver this oration. As Dr. Sancheti mentioned, Dr. Dhananjay Kelkar sir requires no introduction and is in fact an inspiration to all of us, the entire medical fraternity. After completing his MS General Surgery from BJ Medical College, Pune, he did super specialization in oncosurgery from Tata Memorial Hospital, Mumbai. He has done fellowship in thoracic cancer surgeries from Japan and has special training in laparoscopic surgeries from Tel Aviv University, Israel. He is a PG teacher for over past 20 years, and he is also a visiting professor of head neck cancers at the Royal College of Surgeons, London, since 2014. He is going to deliver the oration on private healthcare in COVID pandemic, beyond profit and loss. Such a relevant topic in the current pandemic scenario, and especially in the middle of this second wave which Pune is facing. Dinanath Mangeshkar, under his able guidance, has been on the forefront in setting up a huge COVID management facility and instrumental in saving hundreds of lives in the city of Pune. Also, currently actively involved in COVID vaccination drive. Kelkar sir, we really thank you for accepting our invitation and being a part of today's CME and delivering this oration. Sir, over to you. Thank you.
I'll just share my screen and start. Okay. So before I start, am I audible properly? If anybody can give me a feedback about.
We can hear you, sir.
Yes, sir, we can hear you.
Please go on.
Okay. So I will start. And so today I'm going to take you on a journey about what happened in Dinanath Mangeshkar Hospital during the past year, that is 2020. And I'm not going to advise you what to do and what not to do, because I have two sons. And for past 28 years or more, I have realized that my sons don't listen to what I'm telling them. Since I am unable to kind of deliver it at home, I have now become wise enough not to kind of deliver any preaching or advice to people even outside my house. So what I'm going to do instead is kind of take you through a journey of what Dinanath Mangeshkar Hospital did during the last year 2020 and coming up to the March 2021. So we will go step by step, and I'm going to go a little fast because there is so much which has happened in the last year. मला ते पुढे मागे करायला फार हे करावं लागतंय. थोडं पुढे घेतोस. Yeah. So we will start with the month of March 2020, when the rumors we, we will start with the month of March 20, when the rumors started flying that there is a new disease in the world and which is crossing the boundaries of China. So the first job for me in Dinanath Mangeshkar Hospital was to anticipate whether this is going to come to India and come to Pune. And for that, we took help for our colleagues in Italy, Paris, and New York, where the disease had already landed. So some of my friends who were working actively in the Milan area told me that there are hundreds of breathless patients lying by the side of the road, and the hospitals are not accepting them because they are full. Similar situation happened in London and New York in a month's time. And as an exercise in anticipation, we created a scenario as to if the same disease comes to India, what will happen in Pune and Mumbai? Because Pune and Mumbai are probably the traveling capitals in India. A Puneri person cannot sit at home. He always goes to a restaurant or he goes abroad. If you can't find a Puneri person in Pune, you will find him in California or San Jose or somewhere else. So we felt that they will surely bring back all these travelers, this new flu to Pune city, and we are going to be probably equally affected as Milan or London or New York was affected at one point of time. So probably the success of Dinanath Mangeshkar COVID fight was based on this anticipation, which then led to two subsequent topics which we took. One was the morale building for the doctors, because doctors are typically a frightened community. They are very brave when they are fighting diseases in the patients, but they are not such great patients when it comes to them. If you have any doctor patient in your life, you will understand what I'm telling you. So to build morale amongst doctors and staff was extremely important in the month of March 2020. And the third important thing was preparation, because you cannot fight a war without preparation. So we focused on 4 points, which you can see. Number one was infrastructure, allocating infrastructure in Mangeshkar Hospital to COVID care, procuring equipments like high flow nasal oxygen, ventilators, RT-PCR facility, and whatever else required for COVID fight in time. So Dinanath was probably the first hospital in the country which had more than 25 HFNOs when COVID started, and probably 80 to 100 ventilators. The last batch of ventilators in India was delivered to Dinanath Mangeshkar Hospital in first week of March. So we were far ahead in our preparation as compared to rest of the country. And we already had few thousand PPEs, N95 and surgical masks and medicines which were required for COVID-19. And the last preparation, of course, was manpower preparation, where morale building.
Excuse me, sir. Sir,
Yeah,
just
yeah.
a minute. The slideshow is not being taken forward. We are on the first slide only as yet.
Slideshow is not going ahead. They are on the first slide. I am speaking on the fourth slide.
Yes, sir.
1 minute.
Thank you, sir. Sorry to interrupt.
नाही, no problem. नाही, मागे जा. मागे पुढे चाललंय. आता ही स्लाइडच त्यांना दिसतेय, पुढच्या स्लाइड दिसत नाही म्हणतात. ते दे मला मग इकडे. Okay, can you tell me which slide you are seeing now? पुढची स्लाइड कशाने येते? बरं, तू लावलंच नाही.
ही पहिली स्लाइड आहे.
Yes, sir, just the first slide.
1 minute.
टोटल मूव.
1 minute. कशाने येते हे? राइट क्लिक, लेफ्ट क्लिक. Okay, now.
Sir, not as yet.
Not yet. त्यांना स्लाइड दिसत नाहीत पुढच्या.
So maybe the person who is helping you, if you just tell him the next slide, and even if he keeps on shifting the next slide every
No,
time,
but
so that would work.
I am seeing the next slide. I am speaking on the third or fourth slide now. So that is the problem. I am changing the slides. I am again resharing my presentation. ठीक. झालंय का? मी बघतो तू काय कर. डाऊन कुठली ही आहे का? Okay, can you see the next slide now?
Yes, sir. Second slide is seen now.
Okay, so I was talking about anticipation. Then I talked about morale building and I talked about infrastructure. So of infrastructure, the most important things were assigning land and building to this COVID care, equipments to be procured, medicines to be kind of kept ready, and manpower to be redeployed for COVID care, which is all what we did during the month of March. So if you can see, we had 3 buildings. The first building, which was the main building of Dinanath Mangeshkar Hospital, was dedicated to COVID care. As compared to swine flu or H1N1, we had kept the middle building, which was our cancer care center for swine flu. So we already had one experience of a minor level pandemic. But this time, looking at the Italian experience and the British experience, we assigned our big building of 450 beds for COVID care. So the main building of Dinanath became a COVID care center. The middle building, cancer building, became an isolation center for staff because we expected a good number of staff also to be affected by COVID during the course of pandemic. And our super specialty building, we allocated for non-COVID patients. So this was how the division of our infrastructure was done. And after that division, we started our campaign against COVID in April 2020. The first thing that we did was we started a campaign of preventing or reducing severity of COVID. So all over the hospital, we started putting up these posters, which I'm going to show, of 5 ways to prevent COVID. Actually, it was kind of mixed between prevention of COVID versus getting mild COVID. The second was simulation training for staff. The third was defining team leaders to fight this COVID war. And the fourth was treatment protocols. So we started with our first preparation, which was 5 ways to prevent COVID. So we started with vitamin D, jalneti, cross ventilation, exercise, and direct sunlight. Of which direct sunlight was very difficult because of the lockdowns and people sitting at home. Exercise became a mainstay of Dinanath Mangeshkar Hospital throughout pandemic. The Build Clinic and the Yoga Center ran throughout 12 months for the staff, not for outside people. And our staff was exercising and doing yoga throughout last 12 months. Jalneti was practiced by about 1,600 people from the 3,500 odd staff that we have. And vitamin D we provided free of charge to most of our staff members who could not afford it. So to all nurses and our MPWs, we provided a monthly dose of vitamin D. And this became a kind of morale booster, a self-belief that we can fight this pandemic, and a way to go forward for entire Mangeshkar Hospital staff. The second thing which we immediately started was simulation training for our staff, which was very important because they would not know or did not know how to handle a COVID patient when he comes to the hospital. So for that, we started this simulation center. On the bed, you see a mannequin. Now this mannequin became a COVID patient and the staff in batches for resident doctors, for consultant doctors, for nurses, for MPWs, for cleaning staff. We took their simulation training as to how to handle COVID patient, what is an adequate PPE, how to intubate a patient, how to start intravenous line, how to do donning and doffing, what part of the mask you should not touch. So all the programs started running end of March and they continued throughout the year. Dr. Vaibhavi Upadhyay, who is in charge of our COVID, not COVID, simulation center, took an active part along with Dr. Prasad Rajahans to do this very important training starting from March 2020. The next important thing we did was to identify team leaders. And they were very important because they were like generals on each front of COVID fight. Starting with emergency room where Dr. Gauri Ranade, she kind of handled the emergency of Dinanath Mangeshkar Hospital throughout the year. It was a very, very difficult job. Generally in the month of August and September at night, 30 to 40 COVID patients who were breathless in ambulances on oxygen would come. And there were some kind of bad days during August and September when I used to come at night to the hospital. There would be 4 or 5 ambulances standing outside the casualty with patients on oxygen, and there was no place to accommodate them, just like what happened in Milan. So Gauri Ranade, starting with emergency room, isolation wards were handled by our infectious disease specialist. COVID ICU was handled by Dr. Samir Zog, who was also the COVID in charge of Dinanath Mangeshkar Hospital. So Dr. Samir Zog single-handedly organized the entire COVID fight against this dreaded disease in 2020. And I personally feel he should have been the person to give this oration for COVID. But kind of, I being the face of the hospital, I'm invited for this lecture. But I feel the 99% credit goes to Dr. Zog and his team. A laboratory support by Dr. Sampada Patwardhan for all the COVID tests that were required. Dr. Vaibhavi Upadhyay for simulation training, our nursing directors Komal and Revati for handling more than 1300 nurses during this COVID care, our housekeeping in charge for handling biomedical waste, disposal of COVID cases, handing over of bodies to COVID patients' relatives, our supplies team led by Vinay Sutke for procuring equipments and probably the medicines that we needed, and coordination with government, which was equally important, was handled by Dr. Madhav Bhatt, our ophthalmologist. So with these team leaders, we started. This was the scene in the month of July in Dinanath Mangeshkar emergency room. Each person you see in front is a COVID patient. Most of them at that time used to come on oxygen support. During the month of May, we started taking stock of economy during COVID times, because in the month of March and April and probably early May, all hospitals across the country, including Dinanath Mangeshkar Hospital and probably all of you, suffered good amount of economic losses depending on what is your fixed expenses. And Dinanath has about 4,000 people working, around 3,500 to 700 on its roll, and around 300 to 400 on the contract basis. So totally 4,000 to 4,100 people with little work, because COVID had almost shut down elective work. So we started our cost cutting strategies. And one of the things we appealed to our staff was to take leave when the less work was there. And this only occurred during the month of May and June, because after June, there was so much work that we had to even call those people who had disappeared. So leave during this month of April, end of April, May, and first part of June helped the hospital in cost cutting. We probably shut down some of our unnecessary expenses, updating our instrumentation during the year 2020. Then the government came out with an order of bed reservation and capping of charges. And I am absolutely glad to say that we never got a notice of bed reservation, because we always kept more bed than what the government demanded. As well as There was no capping of charges in Dinanath because throughout the pandemic, Dinanath never increased charges. In fact, I passed an order in Dinanath Mangeshkar Hospital that during the year 2020 and 2021, there would be no increment of charges for services as well as for doctors. And it was extremely important because a society which has suddenly become poor and restrained expenses, it was difficult to bear these increased charges. So probably it was a very good idea of capping charges ourselves, not by the government, reserving beds ourselves and not being asked by the government, and assigning one building to COVID. At that time, many hospitals in Pune were putting up boards outside their hospitals, especially small hospitals, saying that we do not treat COVID patients. And I thought it was such a shameful thing to do because only vultures can do this. That was my opinion at that time. That means there are hospitals which are fighting COVID war, and some are saying that we don't treat COVID patients, so please non-COVID patients come to us. And that also showed their ignorance because there is no differentiation between COVID care and non-COVID care. And this has been a point I had been always been advocating right since the days of HIV. When the HIV came, many hospitals in Pune and Mumbai were refusing HIV care when Sanjeevan Hospital was providing HIV care and surgeries to all patients who walked through its door. And at that time, I had forwarded this concept that treat all patients as HIV positive, what we call as universal precautions. Similarly, I started a campaign saying that start universal precautions for outpatient department, for ENT OPD, for endoscopy, for theater. So you don't discriminate between COVID and non-COVID care. And in the month of June or end of June, both the buildings of Dinanath Mangeshkar hospitals were filled to its capacity. So the COVID care and non-COVID care in Dinanath was filled to its capacity, while many hospitals in Pune were not willing to accept COVID patients. In the month of June, there was an increment in COVID admissions, and in the month of May, when the admissions were less, only our ID specialists, Dr. Bharat Purandare and Parikshit Prayag, were treating COVID patients. In the month of June, all our physicians, 26 of them, joined this COVID fight. So these 26 physicians were divided into 6 units, 1 unit per day, Sunday by rotating emergency, and these 6 units with 4 physicians each started treating COVID patients in the wards. Our ICU team was divided into non-COVID ICU and COVID ICU, and they started treating our probably 4 COVID ICUs that we started. Our that time ICU bed strength was around 45. We at that time also started home isolation OPD, which was a new concept in Pune. We had to convince the government a lot to accept this home isolation concept because my friends in UK and US were already in home isolation when we were admitting every case of COVID. So with good amount of knowledge exchange and cajoling, the government accepted this proposal. And in the month of June, around second, third week of June, home isolation started in Pune. That eased the load of unnecessary admissions on Dinanath Mangeshkar Hospital. And with that, with increasing workload of oxygenated patients and critical patients, we started reorganizing our manpower. So what we did was we arranged 3 teams of COVID war. First team was of intensivist and ID specialist. Second team was of physicians, anesthetist, emergency room medicine doctors, and the third team was of medical super specialties, which is nephrologist, medical oncologist, cardiologist, neurologist, who also joined COVID care. Then surgeons, orthopedicians, cancer surgeons who joined ancillary COVID care. So we started managing our home isolation OPDs. We started managing documentation for COVID. We started managing waste disposal supervision in COVID and government liaising. So whatever the physicians need not do, the surgeons, orthopedicians, oncosurgeons, and other people started doing. So we reorganized the entire manpower of the hospital. So every person in Dinanath Mangeshkar Hospital, I am proud to say, worked during times of COVID. There was no person who said, I did not do any work for COVID or I was not exposed to COVID. And that was the reason why we did a good job during COVID. This is the photograph of our old canteen. So this canteen was on the basement of the COVID building that you know now. This canteen was converted to home isolation OPD. And for 6 months, starting from June till the month of November end, this canteen worked as home isolation OPD, where around 100 to 150 patients used to come every day to understand what is home isolation, to take the kit for home isolation, to take a WhatsApp number, COVID helpline, and all the things which are necessary for safely isolating. Now, during this pandemic second wave, this canteen is again converted into fever OPD. So from Monday onwards, that is last week Monday, this canteen is now working as a fever clinic because we have started getting again around 150 patients per day in our fever clinic. Then came the nightmarish months of July, August, and September. It was an absolute nightmare for Pune city, similar to Milan, London, and New York probably, where average on a day, I would, in my house, hear 5 to 6 ambulance sirens going below my home. And in Dinanath, the sirens never stopped. It was a very difficult situation because outside our casualty can accommodate around 30-35 patients at a time. But outside our casualty, at least 8 to 10 people would be sitting on wheelchairs, on trolleys, and in ambulances on oxygen. And our doctors would go out, help them in stabilization, and try and shift them to some other hospital when bed was not there. At that time, at the peak time in September, occupancy in Dinanath Mangeshkar Hospital, the highest point was 448. So of the 450 beds that we had kind of allocated to COVID care, at one point of time for many days in September, it was 440 days, 48 patients, and we were absolutely choking up to our neck in terms of staff provisions and arranging the logistics. The staff positivity and 14 days leaves, because any staff who had fever had to take 2 weeks leave. So that was also a major issue at that time. And maintaining morale of the ICU staff, where probably 2 or 3 deaths every day used to occur, and they are not used to this kind of death rate. So I had to take counseling sessions for ICU staff as to how to handle deaths. And in a typical war situation, it is extremely important to understand what you can do and what you cannot do. And what you cannot do, you must live with. And our ICU staff, probably the hardest hit by the COVID pandemic, handled all these 800 odd deaths which occurred in Dinanath during the last year and 3 months. So the credit of this pandemic management goes to them. To give you an idea about how much consumption of patients and oxygen went through Dinanath pre-COVID, that is before the year 2020, our average consumption of oxygen was 22,000 cubic meters per month. Now, 1 cubic meter is equivalent to approximately 1,000 liters. So that would be around 22 lakh liters of oxygen per month. So 22,000 cubic meters was our average consumption. In the month of September 20, it was 97,000 cubic meters. So exactly more than 4 times our regular consumptions when our ICUs, cath labs, and everything is running full flow. In the month of February 21, where the second wave started, it started jumping to 27,000. And in March, now the March is still to end, but we are expecting it would be around 45,000 cubic meters this month. This will give you an idea about what kind of second wave is there and what was happening throughout the last year. I am also proud to say that Dinanath Mangeshkar Hospital never had any oxygen shortage throughout last 12 months. There were a lot of hue and cry about hospitals not getting cylinders and not getting oxygen. But Mangeshkar Hospital, all 365 days of last 2020 had oxygen to the tune of 97,000 cubic meters when it was needed. If there was shortage of oxygen, and I want to thank Praxair, which was the company which is our oxygen supplier, for doing this wonderful job in the hour of need. The staff COVID positivity was also a major issue for us during especially month of August and September. If you can see, in the month of April, there was one COVID staff positive, month of May 15, month of June 12, jumped to July 61 patients, month of August 57 patients, month of September 36 patients. So these are all documented COVID positive patients from our staff, 182, around 300 patients by March 2021 have been infected. Not all have been tested. Around 250 would be tested positive. Around 50 we feel might have been positive, but because of mild or negligible symptoms, they were not tested. So out of 4,000 odd people who work in Dinanath or for Dinanath, 300 finally in 1 month and 3 years got infected, out of which 250 were tested positive till March 21. And especially in these 3 months, it was like 60, 50, 36. So all these people would be taking rest for 2 weeks. So it becomes difficult at times to manage. And to manage this, we took some unique decisions in Dinanath, and I'm going to share you how our decisions were data-driven and not sentiment-driven. And this data-driven decision is something which I wanted actually to share with all my colleagues in IMA and AG Diagnostics, because that was the crux of our fight against COVID. So the first decision was whether to use RT-PCR or a rapid antigen test. And there was fair amount of criticism on whether rapid antigen is good enough. So we took out our own data. We got our rapid antigen kit from South Korea. We accepted none other during this pandemic. Our RT-PCR kit was from France and USA. And CT scan chest, of course, is ours from Siemens. Our sensitivity and specificity for rapid antigen was 60% sensitivity and 100% specificity. This is our data. This is not hypothetical data from all the tests that we have done so far. Our RT-PCR sensitivity was 63% with 100% specificity, and our CT scan sensitivity was 81%. This data helped us that in a way that all patients who were coming to casualty started undergoing rapid antigen test. The result was available in 15 to 20 minutes, and our suspect COVID admission stopped since the 15th of July. Because after second or third week of July, rapid antigen arrived, and the suspect patients who were always upset because they were admitted in COVID building was stopped, because RT-PCR used to take sometimes 6 hours, sometimes 12 hours. And initially in the month of when we were sending to NIV, it even took 1 or 2 days also. So rapid antigen was a game changer in fight against COVID. And based on our data, we are very happy to say that it's a very accurate test. These last 2 months, that means the month of February and March 21, the rapid antigen positivity during the second wave has been 61%, and RT-PCR positivity had been 65%. So still, it's a gold standard. Wherever you are using both the tests, both are good. CT scan chest is extremely valuable because many patients who are RT-PCR negative, that is 35% of patients who are RT-PCR negative and yet have COVID, they are diagnosed by CT chest. And again, we convince the government to accept this as positivity, because for many months, for the month of May, June, and July, we did not receive any reimbursement for patients who were CT chest positive and RT-PCR negative. But finally, government accepted it. We also started this screening CT chest at 2,000 rupees. That was in the month of third week of July. The screening CT chest in 2,000 rupees became so popular that even government adopted this as 2,000 rupees as the cost for CT chest during COVID pandemic. And now we have done more than 2,000 screening CT chest in only rupees 2,000 for our COVID patients. The second unique step which we took was modified PPE and its impact. At that time, in the month of June, when I went to Sassoon General Hospital, even the watchman who was standing outside the building was wearing a PPE. And there was a tunnel there outside Sassoon COVID building where people were sanitized before entering the building. And then I heard that one constable or some policeman's son died because of this sanitation tunnel allergy. This was stopped. Dinanath Mangeshkar never kind of undertake these such practices which were used for Ebola. So I'm going to show you the modified PPE that we are using. This is Dr. Samir Zog, who single-handedly handled the pandemic 2020 and 2021. He did not get infected with COVID during the past 15 months. He has not taken 1 day's medical leave during past 15 months. He has not taken hydroxychloroquine during past 15 months. And he started working with this modified PPE where you can see there is an ordinary cap. There is a face shield kind of goggle like one which we use for scuba. There are two masks, one surgical mask and one N95 mask. The surgical mask is to be discarded probably every 4 hours or so. Then there is a surgical gown, which is a cotton gown, which is changed twice a day during duty. That means they can take a break in between for lunch, for phone calls, and for little relaxation between the duty. No gloves and normal shoes, no kind of gum boots or something like that. This became easy because working in PPE was extremely difficult. And at one time, I visited one hospital which was treating COVID to give suggestions. The doctors told me that if they sit without doing anything wearing a PPE, then they can do the duty properly. If they move around with the PPE, it was very difficult for them. So the bogus PPE or the Ebola suit, as I call it, was removed from Dinanath from the month of July. Interesting, if you want to know, some of our residents did complain to Diplomat National Board, DNB board, that we are not providing them adequate PPEs. So we wrote to the board that from medical director to ICU in charge to casualty in charge to every doctor in Dinanath is using the same modified PPE without discrimination, and our positivity rate is less than that of AIMS, less than that of Sion Hospital, less than that of KM Hospital, Mumbai. So we must be doing something right. So please don't force us to use PPEs. To go forward in some other unique steps that we took was we started new intubation strategies to safeguard doctors. Intubation is probably the most hazardous patients in COVID hazardous procedure for COVID patients. That is the time when people get maximum exposure of COVID viral load. So we designed an acrylic box, which was designed originally in-house by our biomed department, and we would intubate the patients inside this box. We also purchased the CMAX video intubation equipment for our ER and ICU. That means you don't have to take your face near the patient's mouth for intubation. So you do video intubation, you can stand away from the patient's face and intubate looking at the video picture. So for every intubation in Dinanath in COVID times, the video technology was used for intubation. Other few database decisions I wanted to discuss because I see them circulating on WhatsApp University. One of this important thing which circulates on WhatsApp University was value of RT-PCR cycle threshold. So RT-PCR reporting gives you whether the test is positive or not for the 3 antigens, and it gives you a value as to which cycle the test came positive. And this cycle threshold value is misleading. So we removed it from our Dinanath reporting other than when specifically asked for. We only use it now when the patient is to be shifted out to non-COVID ward or when to declare him as non-infective or non-transmissible. But other than that, we don't use it as an indicator of predictor of severity of disease. And I'm going to show you how we reach that conclusion. Now, this first slide shows cycle threshold value more than 30. That is a low viral load RT-PCR. And these are the numbers that you can see. And you can see that 30% were asymptomatic and severe or fatal. That means those who went on ventilator, survived or not, were 7.3%. Whereas when the cycle threshold value was low, that is, there was a high viral load on RT-PCR, 54% were asymptomatic. That means the viral load cannot predict disease severity, because disease severity, there is also fitness of the person, immunity, and many other factors we talked about. So the viral load does not determine, but I would also accept that when the viral load was high, that is less than 20 cycle threshold, the mortality did rise to 20%. So when the viral load is high and patient has comorbidities or his immunity is poor, there is higher mortality. But it cannot predict outcome, especially if you don't consider all other factors together. The second decision was on CT chest screening. So CT score and outcome is something I want to talk about. Now, CT scan has got two things. One is called as a CORAD classification. Now, this CORAD is for radiologist. Please don't read it. It is like our mammographic classification, which we call as BIRAD. Now, BIRAD 0123 means non-breast cancer. Similarly, CORAD also 123 means it is not COVID. But unfortunately, because it looks as if it is a COVID classification, I don't know, because people don't know about it, they feel afraid. So forget about CORAD and concentrate on CT severity score. And CT severity score, this is our data. Now we have done more than 1,000, but this was our decision making in the month of July end and August, that when the CT score was 1 to 8, that means probably less than 5 to 10% of the lung was affected, only 20% needed oxygen and only 3% died. That means when the CT scan shows minimal or mild chest involvement, patients are rarely at risk. When it goes to moderate level, 51% needed oxygen and 6% died. That was the score of 9 to 15. And when the score was more than 15, that means more than 50% of the lung was involved or 60% of lung was involved, almost 56% required oxygen, but 23% people died. So the mortality can be correlated to the severity of CT chest scoring. So we used it as an important predictor of bad outcome. So this is the mortality related to CT severity. Mild cases 3%, moderate cases 6%, severe cases 23%. Another database decision, we did a study with the University of Queensland, Australia on tocilizumab during this period. Because at one time, tocilizumab was being black marketed and there was a cytokine storm, there was a bradykinin storm, and people were going crazy to give tocilizumab. We always resisted this, did this study, and came to the conclusion that tocilizumab does not reduce mortality. It did not bring down deaths. It was indicated in only very few selected cases where patients were non-diabetic, they had a cytokine storm, and probably the indicators like IL-6 and CRP were high. We used tocilizumab in few patients, but in no way did it alter the course of the disease. The second one which we took for study was remdesivir, whether it gives benefit. And from our own data, we came to the conclusion that remdesivir helps in reducing the length of stay in the hospital. So it was useful for patients who were admitted. It should not be given for mild disease, should not be used at home. If you use remdesivir indiscriminately, there will be resistance to remdesivir in future. So it would be like misuse of antibiotics. And unfortunately, India and Pune, I would say, misuse remdesivir right, left, and center. So don't misuse it. Use it only with probably consultation with ID specialists. It has a role in reducing length and severity of the disease, though the mortality was not brought down. It is beneficial in COVID. The thing which really changed course of COVID or brought down mortality was high flow nasal oxygen. And fortunately, Dinanath was well versed with high flow nasal oxygen during swine flu. We had used HFNO and high frequency ventilators and ECMO in swine flu. So we had all the technology needed to treat critical patients in COVID also. And this prone ventilation and HFNO really brought down mortality in COVID, and we used it very abundantly. There are three things which we always said no as a hospital. One was plasma. Plasma became so fashionable that some newspapers and Pimpri Chinchwad Municipal Corporation, even Atlanta and Dallas in USA, started advocating that every patient who gets cured from COVID must donate plasma, and every person who gets admitted to the hospital must receive plasma. And we did not believe in this because plasma gives you only B antibodies. It does not give you T cell immunity. And we felt that this B cell immunity or antibodies are not effective in preventing death, which was proven later on as the pandemic went along. And then ICMR came out in the month of end of September, probably early part of October, with the guideline that plasma is not to be encouraged in COVID. But right from the month of June, Dinanath Mangeshkar Hospital and its blood bank never advocated plasma. To people who insisted on giving plasma, because there were some WhatsApp University professors who were admitted in Dinanath Mangeshkar Hospital, they procured plasma from outside and gave it to the patient, unfortunately, without any benefit of saving lives. The second equally useless thing which started was hydroxychloroquine. And right from the President of United States of America, the hydroxychloroquine was used without sufficient evidence by India and rest of the world. We were always against hydroxychloroquine. In the month of April last week, I was coming for my normal cancer surgeries to the hospital, and in the operation theater, I saw somebody distributing some tablets. So I asked him, what tablets are you distributing? So he said, I'm distributing hydroxychloroquine. I said, why? So he said, one physician in the hospital has said that hydroxychloroquine is very important for prophylaxis during COVID, and all healthcare workers must take it. So I called our team together. We had a meeting on the same afternoon, and I understood that 3,000 people were taking hydroxychloroquine. We immediately stopped this practice. I went in front of all the staff. Dr. Zog went in front of all the staff. Dr. Bharat Purande and Prayag went forward and said that we are not taking hydroxychloroquine. Please don't take hydroxychloroquine. And from 3,000, it came down to 100 hydroxychloroquine users in the month of June. And these 100 slowly dwindled down to 20 at the end of October. And today, I don't know if there is any hydroxychloroquine user in Dinanath Mangeshkar Hospital. Similarly, ivermectin also was used non-judiciously by physicians in our hospital as well as outside. It was started by Bangladesh and probably should have remained in Bangladesh, I feel. It does not save lives in COVID, and unnecessary prescriptions became a mainstay of COVID treatment during July, August, and September. We did a good amount of research during COVID-19. And this good amount of research which we did, I'm going to not share the research because it is in various stages of publication, but I'll give you the gist of what happened. The Jalneti project, where a lot of people did Jalneti in Dinanath, the others who did not do Jalneti Dinanath, and then we analyzed how many got positive, what kind of symptoms they had, and what was the outcome. And the outcome of Jalneti, exercise, and vitamin D together is extremely promising. of Jalnoti alone is promising in terms of reducing the number of infections and making the disease mild. So as of now, at least 600 people, even though the pandemic has ended, continue this Jalneti practice. And all those of you who are doing it, I would urge you to continue. I have not taken 1 day's leave during the last 15 months. I have not cancelled a single surgery during last 15 months. And I don't know, the credit definitely goes to exercise, vitamin D, and above all to Jalneti. Tocilizumab, I have already told you, we found out that it does not save lives. It is to be used in very, very select indications. We published a paper on stroke in COVID patients or understanding the tendency of thrombosis in COVID patients. And this is a very funny tendency, thrombotic tendency, which does not even respond to ecosprin or even sometimes to clopidogrel. So I am still wary of recovered COVID patients and thrombotic tendencies even today. I feel the lot of heart attacks and strokes which have occurred during the year 20 and 21 can be attributed to past COVID infection. Then we undertook a study on demographic, socioeconomic, and psychological impact of COVID on our 3,200 staff members during the past 1 year, of what kind of harassment they faced from the society, economic problems they had during the COVID, family incomes dipping, the fear factors coming in, not wanting to work, handling deaths, everything. All the factors were included by well-designed questionnaires, and this study also is in the probably the stage of publication. And we also wrote a paper on elective surgeries during COVID pandemic. I will discuss this in a little while. We did public education during this pandemic via YouTube. And this is again one lesson which I learned during this pandemic I wanted to share with you. There's newspapers are not the best medium of education because they have a mind of their own, they have a sponsor of their own, and they have an influence of their own. So newspaper is not the best medium for public education because they have their own agenda. Whereas YouTube is a very effective medium for public education. So consciously, I undertook this responsibility of public education on YouTube and became an extremely successful program in terms of understanding COVID, managing COVID, understanding about vaccine. And I would urge all of you, those who are kind of good orators and influence champions in the society, to look at this medium of YouTube for public education. The other thing which we did was proning and yoga exercises for COVID patients. So again, through YouTube, I put out a video of Sukshma Vyayam or yoga exercises for COVID patient, become extremely popular. 15 million people have viewed this and they are doing it daily, on a daily basis. I got calls from all across the country and even from outside India that when they had COVID, they had extreme benefit from these exercises and they wanted to thank me. The third thing which we did was drive for vaccination. So far, like as of today, we have completed 14,000 vaccinations, out of which 9,000 for senior citizens and 5,000 for our own staff members. These 5,000 staff members have completed 2 doses and 9,000 seniors are waiting for their second dose. We also created or helped in creating a PPCR platform, which is called as Pune People's Citizens Response Platform for fight against COVID. You might have heard about this platform from other sources. In COVID times, the non-COVID care got extremely affected. I'm going to tell you one story from US and one story from London for you to understand what happened outside, which are called so-called world leaders. So in the US, a friend of mine, he is about 40 years old. His wife is 38 years old, had breast cancer, and she was diagnosed in the month of April 2020. After diagnosis, her staging was T1N0M0, that is stage 1 of breast cancer. And at that time, the Californian doctors were not willing to operate on her because at that time, the elective surgeries were stopped in US. So she was put on tamoxifen for breast cancer. continued for tamoxifen for 3 months, and then came up for surgery in July, August when the COVID went down. Similarly, my friend in London, near London, who is a very rich Britisher, born Britisher, not of Indian origin, fell from his horse during the month of February 2021, had a fracture of tibia and fibula, and was at home for 10 days because he could not be admitted to the hospital with tibia and fibula fracture. On 11th day, he was admitted in a hospital near London, and on the 12th day, he was operated for tibia fibula fracture. We did far better than Britishers and Americans. Throughout the pandemic, Dinanath Mangeshkar Hospital theaters ran from morning 8 o'clock till night 8 o'clock, except for the month of March and April. From the month of May onwards, we ran full capacity, and the main scare was this paper from China, was that there is 20.5% mortality in post-operative period if patient is infected by COVID, which was far from true, because we have operated now more than 15,000 patients of COVID. This was a paper of, I don't know, 34 operative deaths. We have now more than 15,000 surgeries done, and without any significant mortality. Our mortality always had been less than 1% before and during the pandemic. So what we did was, to understand COVID risk, we made an algorithm. This algorithm, we classified surgeries as to whether they are really needed or not. So urgency of surgery classification. Then we had a 3-step risk assessment: need of surgery, risk of anesthesia, COVID prevalence, and COVID risk. Then we had a committee, and this committee of ID specialists, anesthetists, and independent surgeon would give a label of surgery should be undertaken, can be undertaken, may be undertaken, and best avoided to the patient, and the doctor would then take an appropriate decision. This worked very well, and Dinanath worked full steam throughout last 1 year. We did death analysis of our first 250 deaths, and we tried to find out if there were any predictors of death, out of which the most important predictor was oxygen on presentation. And when the oxygen on presentation was less than 80, or saturation on pulse oximeter, there was 43% mortality. So this is something for all of you to understand and remember, that when patient comes with less than 80% oxygen, half of them almost die. And the media kinds of keeps on shouting as people are dying. The main reason is hypoxia, and the hypoxia on presentation means the viral disease in that individual is very severe. The next was comorbidities, out of which the predictor of death, hypertension in 60%, diabetes in 58%, and multiple comorbidities in 61%. However, absolutely no comorbidity, that means healthy population, 20% of the deaths were from these no comorbidity patients. So don't take COVID lightly, because right now what I'm saying is this: people are taking COVID lightly. About 15 days ago, my friend anesthetist had his son's wedding to my another friend's daughter, and they were after my blood to attend the wedding. I did not attend the wedding as a social responsibility, and took a lot of kind of bad words from them for not attending the wedding. Yesterday, I am told that 65 people from that wedding turned positive for COVID, out of which the most important are the bride and the groom. They both tested positive. So please don't take COVID lightly. They always take it seriously. Whether the BMI was responsible for death. So less than 25 BMI, which is non-obese people, 56% deaths, and more than 25 BMI, that is obese people, 44% deaths. So we felt that BMI is not an independent predictor of death. The most important predictor of death which we found was PF ratio. I don't know whether you know of this PF ratio. It is the ratio which is calculated in the intensive care unit between the oxygen delivered and the oxygen in the blood. And after 2 cycles of prone ventilation, if this PF ratio is less than 200, there is 92% mortality. So we come to know on the second day of ventilation itself whether this patient will survive or not. 10% do come out or 8% do come out, 92% die when the PF ratio is less than 200 after 2 cycles of prone ventilation. So in summary, we did kind of phenomenal work during this COVID pandemic, learned lots of valuable lessons as to how to go about tackling a new disease. We handled 15,000 fever OPD patients during this pandemic. Total admissions in Dinanath under COVID were 8,700. Total home isolation were 6,000. So total 14,700 patients have been treated so far. Total deaths have been 800 till March 21. Staff COVID positivity was 300 out of 3,500. So somewhere around 8% or 10% positivity, I would say. And economics, while we were running in losses in the month of March and April, after cost cutting, improving probably our reach on both COVID and non-COVID building, now we are making a mild to modest profit even during pandemic. So there is no reason to shout that COVID is kind of making us into going into losses. You do your job and money will always come for you to sustain. Even the government money, which has been slowly coming and very kind of irregularly coming from urban poor and MJPJY, even that has not affected economics in Dinanath Mangeshkar Hospital. So I would say that before I end, I wanted to make a small comment on the current wave, which I wanted to share with you because I don't know when I would get this platform to share this knowledge which I'm getting. The current wave is a milder wave as compared to the last wave. From the oxygen consumption, you must have understood that even though the number of positive cases are the same as September 2020 per day in Pune, the oxygen consumption as compared to 97,000 at present is only 45,000. So the wave is milder by 50 to 55% this time. The second thing is more infective because entire families are getting affected, like these 65 people who attended a wedding 15 days ago. So it is more infective for this time. The third thing which is happening is it is affecting younger people, that you must understand that more and more children and younger adults are getting affected as compared to the senior people. And the last good news is that people who were affected during last year are not getting infected during this year. The reinfection rate is 0.6%, 0.6%. So that is good news for all of us. Continue to fight COVID, continue to look at your data, draw your own conclusions. Don't rely solely on WhatsApp University. That's not a good medium. I wanted to thank AG Diagnostics for kind of thinking that I am good enough to give this oration for my good friend Dr. Jayant Abhyankar memory. I wanted to thank IMA Pune for patiently kind of listening with all the colleagues who have joined to understand my views, which are generally not in consonance with views in the rest of the country. And the silver lining of this dark cloud is that society has understood importance of medical profession. So if we kind of work as soldiers and generals during this COVID pandemic, society will understand our value. The attack on doctors will go down. And this had been a great opportunity for us to show that by service, we can win back the prestige that we had lost in last 40 years. Thank you and good day.
Hello.
Good.
Hello.
Yeah.
Thank you, Dr. Dhananjay, having the very nice presentation. So we learned that the not only the soldiers but well trained, well equipped, and well managed protocol is important to fight any situation. Not even the war, but in the medical war also, and that the Dinanath Mangeshkar has proved it that the pandemic management, after thinking of the situation, changing the strategies and changing the management and taking ahead the protocols. It is very good management and results we see from the Dinanath Mangeshkar. And I like to say that in the IMA hospital board of Pune, small hospitals also manage the situation very well up to the ICU situation. If they are not having the ICU, they have shifted the patient to the ICU hospitals. But till the mild and moderate cases, they have managed it very well because we were seeing it very nearly and watching their protocols and treatment management also. So I think they are learning from your experiences and everything. And Bharat Purandare and Dr. Prayag is very helpful in that panic situation. Even immediately they were lifting the phone and advising because our patients were asking us where to go, what to do. This is a test, and what we have to do. Symptoms are not there, so we were advising there to stay at home isolation, and we were taking the advice from the Dr. Bharat and Dr. Prayag. They are very helpful, and I think it is a very well managed teamwork from the Dinanath Mangeshkar. Thank you.
Thank you, madam, for your kind words. So also from my side, I am really thankful and grateful. It is an honor that you are there in a IMA platform. And in this COVID, we do realize the efforts taken by all of the doctors in Pune. I would say Pune was worst hit. And the best thing we have seen also, we were to have a lot of phones that we want place in Dinanath. And I would say it was excellently managed by Dinanath. A lot of patients got saved. I would like to thank all of the team of Dinanath, especially you mentioned Dr. Gauri Ranade, Dr. Samir Jog, Dr. Prayag, Dr. Rajhans, who led the ICU management, Dr. Bharat Purandare. We had also some, I would say, webinar also. Dr. Prasad Sankit. It was a nightmare, but I say that because of all the institutions like Dinanath, Rupi, Noble, Bharti Medical College, Bharti Hospital, all of the stalwarts have done, I would say, excellent job to save all the Punekars. So I am really grateful indeed that IEG Diagnostics has done the best for the investigations also and the team of Dinanath also. So I thank you very much again, Dr. Dhananjay Kelkar sir. Next, I'd request Dr. Avanti to say a few words. Dr. Avanti, madam.
Yes, I think I'm audible, right? Sir, thank you so much for such an enlightening talk. In fact, we are again in the middle of second wave, and this would definitely help entire Pune city and many other hospitals to gear up for this second wave and be much better prepared than the first wave to handle the patients. Your talk kind of was really telling everyone at every step what is to be done and how to go forward. There was really lots and lots to learn in spite of we also being in the forefront and trying to help the society and community from day one. Thank you so much, sir, for accepting our invite and being here for this oration.
Thank you very much, sir. You won't forget your Jalniti also. And I know a lot of practitioners are doing it. And yoga therapy also. In the second wave, definitely all these things will help us all. Testing facility and your tips, I would say. That was a excellent take-home message. Thank you, sir. Thank you.
Vitamin D.
Vitamin D, vitamin C, all things. Thank you, sir. And we'll go for next section. Can we, sir? Dr. Avanti Golwilkar. She would speak on COVID monitoring and the immunity lab aspects. This is more important topic, so I request her to address her topic lecture. Over to Dr. Avanti, madam.
Yes, sir.
Sarda sir, Dr. Sarda sir, welcome.
So before I begin with my talk on laboratory aspects of COVID-19 monitoring and immunity, I would just touch upon a little bit of theory for COVID-19 infection and mainly pathophysiology, because that forms the basis for us to decide what kind of testing protocols are to be followed, in what frequency, and it also gives us an idea of what kind of immune response our body generates, so as to develop and analyze the antibody testing platforms which are available with us today. Dr. Madhuvanti in the morning has touched upon many aspects of laboratory investigations, and the most important, the diagnostic test, that is RT-PCR in the morning. But just to enumerate a few more points and then highlight upon the testing a little more in detail. So as we all know, COVID-19 is an acute respiratory infection caused by SARS-CoV-2, which is severe acute respiratory syndrome coronavirus 2. We have been almost in this pandemic situation for over a year now, because on 11th March 2020, WHO declared COVID-19 as a global pandemic. We all know that it is zoonotic in origin, but now it is transmitted from person to person, mainly primarily by respiratory droplets. SARS-CoV-2 is an enveloped single-stranded RNA virus and has 4 predominant structural proteins, that's the spike, envelope, membrane, and nucleocapsid protein, and 16 non-structural proteins, including the RDRP, that is RNA-dependent RNA polymerase, replicase, and other proteins and enzymes which are required for the viral replication and hence the infection to get transmitted, as well as the person to have more severe kind of infections. Incubation period can vary from as less as 2 days to up to 14 days, but in majority of the patients, we have seen that it is between 3 to 5 days. Coming to pathophysiology, SARS-CoV-2 invades through the functional receptors on the host cells, which are namely the angiotensin converting enzyme 2. It's a transmembrane protein or a transmembrane enzyme. This ACE2 has a very high expression in certain tissues like the lungs, heart, mainly the pericytes, small intestine, mainly the ileum, kidney, bladder, and endothelial cells. I'm highlighting this because this will tell us which organs are going to get affected because of COVID-19 infections. And again, the focus of laboratory testing is around that, and even the clinical presentation are based on the affection of these organs. ACE2 has a higher expression in men than in women and a lower expression in pediatric age group. Again, this helps us to identify why severe diseases are more commonly seen amongst the males and why the disease is less severe in the younger population and pediatric age group or children. The invasion of the host cell happens through 5 processes or 5 stages. Attachment of the virus to the receptor, functional receptor ACE2, then the penetration, biosynthesis, its maturation, and then release and infection of the neighboring cells as well as from one person to another. A pictorial way to tell the same mechanism of SARS-CoV-2 invasion of the host cell. The first step is attachment. So once the virus enters the body and infects a person, it attaches itself to the host receptor ACE2 via the S1 subunit of the spike protein. After its attachment, there is a conformational change which happens in the viral spike protein, which allows for the penetration of virus into the host cell, the pneumocytes, or the ciliated upper respiratory tract epithelial cells. And this happens via the S2 subunit of the spike protein. So either it undergoes fusion with the cell membrane of the host or by endocytosis and enters the host cell. After its entry, it starts replicating itself, and there is biosynthesis of the viral proteins which happens, as a result of which newer viral particles get generated. And finally, after this maturation and formation of new particles within the infected cells, these viral particles are released and they go on and infect the neighboring cells too. So much is thought about the immune response or the host response to the infection. This same host immune response is also responsible for severe infections and what we call as the cytokine storm, which is seen in critically ill patients because of COVID-19 infection. The virus infected apoptotic epithelial cells are phagocytosed by the nearby dendritic cells or the macrophages. These are drained by the lymphatics into the nearby draining lymph nodes, and these antigen-presenting cells then present the viral antigen to the T cells. The CD4 T cells activate the B cells, leading to what is this antibody production. The CD8 T cells are instrumental in killing the viral infected cells. And altogether, once the inflammatory response is generated, it kind of sets in a vicious cycle, more cytokine production, more attraction of inflammatory cells to the area where infection is there. And either that helps in curtailing the infection and very rarely into what the complications are. So just to enumerate once again, majority of the cases, that is in 80% of the cases, the infection gets restricted into the upper respiratory tract, and locally that viral replication and propagation happens initially, but then is limited by the immune response. Containment of infection happens, and so 80% of people recover without any much complications, like a routine common flu presentation. And after their quarantine period, they can resume their activities. But in 1/5 patients, there is progression of this infection from upper respiratory tract to the lower respiratory tract, invasion of type 2 pulmonary alveolar epithelial cells or pneumocytes. And as a result of which, there is a lot of apoptosis and death of or loss of these pneumocytes, resulting into the complication, which is acute respiratory distress syndrome. In few others, because of the initiation of inflammatory response and that being exaggerated, there is what is known as cytokine storm, as a result of which, again, a vicious cycle is set, which also leads to injury to the lung, and multi-organ failure or DIC can be the other effects of the same. Clinical presentation, as I said, is mostly upper respiratory tract related symptoms. So patients usually present with fever, cough, dyspnea, myalgia, body ache, headache, sore throat, and or with or without sputum production in a few of them. Variable symptoms amidst these are seen. And in few cases, the patient may present with gastrointestinal symptoms like anorexia, nausea, vomiting, abdominal pain, and loose motions. The clinical classification based on the severity of the disease ranges from asymptomatic to critical state or severely ill patients. This is important because this again forms a guiding principle of what kind of tests are to be selected and what is the frequency of testing in these cases. So asymptomatic cases are those which are RT-PCR positive, but otherwise have no clinical symptoms as such, and the chest X-ray or other findings are completely normal. Many a times these are detected because they are contacts of known positive patients, or they get themselves investigated for some other reason, like for pre-operative or travel purposes. Then, as I said, 80% of the people would have always a milder infection with mild symptoms, which I just explained. Majority cases with upper respiratory tract infection, and few GI symptoms are also seen. Moderate illness is where the patient has hypoxia and symptoms of pneumonia. Severe infection would be where the SpO2 drops down drastically and there is severe pneumonia. And critical state, of course, is either the acute respiratory distress syndrome or the multi-organ failure and DIC kind of a picture seen as a result of cytokine storm. Role of laboratory starts from diagnosis and up to serosurveillance or epidemiological surveillance. And now with vaccination drive, to see whether the body has mounted immune response post-vaccination. For diagnosis, Dr. Madhuvanti has covered in detail the RT-PCR test. Then monitoring is for the disease severity, prognosis, therapeutic monitoring, serosurveillance, and the post-vaccination immunity. This picture again depicts the same, that at every stage of COVID infection, till recovery and sometimes even post-recovery and post-vaccination, laboratory diagnosis and laboratory testing forms a very important or a critical part. To start with, the most important test and a simple test is also helpful in COVID-19, a complete blood count and a hemogram. In fact, there have been several webinars which have been presented covering only the hemogram or the complete blood count aspects in COVID-19 and how that can help in monitoring as well as prognostication in cases. In many cases, there is lymphocytopenia or decreased lymphocyte count, which is commonly seen with many of the viral infections. There can be decrease in the total WBC count as an effect of the same. In few cases, there is leukocytosis and increase in the neutrophil count. This is predominantly seen in severe cases with superadded bacterial infections. Platelet count can be decreased typically as is seen with other viral infection or even more. High NLR ratio has been much talked about. That is the neutrophil to lymphocyte ratio. So whenever the neutrophil count is high and the lymphocyte count is low, it is an important prognostic marker and it does indicate a bad prognosis in such patients. We have again seen morphology of monocytes and increased monocyte count typically in many of these COVID patients. And it has kind of become addictive in our staff is to when we get a patient suspected of COVID, where we get an hemogram as well as RT-PCR testing to predict whether the RT-PCR would come positive or negative based on the peripheral blood smear and whether abnormal monocyte vacuolations are seen on the peripheral blood smear. So this is one or two pictures of peripheral blood smear we see in our labs and the vacuolation which is seen in these monocytes. The other laboratory tests are C-reactive protein, commonly increased. Only in severe cases, it is increased to a much higher level. It is an important prognostic factor in COVID-19 infection. Ferritin, again, is increased. It is an acute phase reactant and it is increased, but yet we always should remember that ferritin, if it would have been low or very low in an iron deficiency kind of a person, it may not increase above the normal range in certain people and erroneously still remain in within that normal range, even though for that particular person, there has been a rise in the ferritin levels. High ferritin levels have been associated with bad prognosis. Cytokines like interleukin-6 and TNF-alpha, they are increased. It is said that interleukin-6 is one of the earliest interleukin or a cytokine which shows increase maybe. And if we see high levels, it can be an indication of an impending cytokine storm. D-dimer levels are increased. D-dimer levels are also increased in other infection. More so we realize that because in today's scenario, many patients came initially with just hemogram CRP and RT-PCR. And after the RT-PCR, hemogram CRP, D-dimer and all those COVID monitoring panel. And when the RT-PCR turned negative, we did other investigations for those patients like ruling out dengue, malaria, Vidal and other type of causes for fever, and in few of those also D-dimer was found to be slightly on an higher side. So it does increase even without disseminated intravascular coagulation. That is what we should keep in mind. Nonetheless, if it is above 1500, it definitely is important to note because those patients may require some kind of anticoagulant cover, maybe aspirin or even clopidogrel. LDH again is increased predominantly because of pneumocyte damage or even in multi-organ failure. Procalcitonin is tested if at all bacterial superinfection is suspected and the values are higher. Cardiac troponin, CPK-MB are other things which are used in COVID monitoring because as we discussed, as ACE2 levels are there or the receptors are also there in myocardium and the pericytes, there is a possibility that patients may have myocarditis, and if at all something like that or arrhythmias are noted in such patients, these investigations should definitely be carried out. Associated ancillary tests, of course, would be needed, especially based on what kind of comorbidities the patients are suffering from. Say diabetics would require sugar monitoring. If there are any kind of complications that are suspected or cardiac failure, accordingly, the test would need selection. If the patient is on anticoagulant, then definitely PT-INR for monitoring such treatments or other treatments. So laboratory would play a role in those two. So alkaline phosphatase, SGOT, SGPT, of course, for detecting any kind of liver injury. They would also play a role in patients who are on treatment, because many of these drugs or antivirals which are used would also affect liver function. Albumin is decreased because of affection of liver function, and per se is also considered as a prognostic factor. So low albumin in COVID-19 patients is considered as a bad prognostic indicator. Creatinine and urea for the kidney injury, for detecting kidney injury, as we have seen ACE2 receptors being in kidney also can be a target targeted by the infection of SARS-CoV-2. Prothrombin time, complete coagulogram, especially if DIC is suspected, NT-proBNP if cardiac failure is suspected. So this just enumerated the tests which the laboratory is performing, can perform based on the severity of the illness. To touch upon few of the tests which are predominantly used at this moment for monitoring such patients, one of which being C-reactive protein. C-reactive protein is an acute phase reactant. It is synthesized by liver. Levels increase as a result of non-specific response to infection, non-infectious inflammatory processes, and tissue injury. The methods to estimate CRP which we predominantly used immunonephalometry, but the other platform which is available is immunoturbidometry. Heparinized and EDTA plasma as well as serum samples can be used. And as I said, high CRP is indicative of more severe inflammation, and therefore definitely considered as a bad prognostic indicator. The next we come to D-dimer. D-dimer is a fibrin degradation product. Higher levels are indicative of coagulation-related activation or fibrinolysis. It is measured by monoclonal antibodies by a technique called as alpha in our laboratory. Higher levels are indicative of activation of coagulation pathway and hence increased risk of thromboembolic phenomenon. It is used to conclude on the need to initiate anticoagulant treatment in these patients, and again as a prognostic marker. Coming to interleukin-6. Interleukin-6 is a pleiotropic cytokine with wide range of functions. It is considered as an early indicator of acute inflammation. It aids in management of critically ill patients and to decipher about cytokine storm. TNF-alpha is also being used variably, not commonly included as a monitoring panel, but for several clinical trials, we have been performing TNF-alpha for COVID-19 infected patients as well. It is produced by many inflammatory cells, macrophages, CD4 positive T cells, NK cells, and neutrophils. It acts via the TNF-alpha receptor 1 and 2, which are present on all the cell types except the red blood cells. It has wide variety of biological actions, but predominantly with respect to COVID-19, it has a chemotactic activity on neutrophils and proliferative activity on T and B lymphocytes. It is again measured by immunoassay. Both serum and heparinized plasma are suitable for its testing. While doing all these different laboratory tests, we have to see to it that we abide by all the quality assurance process, document that properly, and it is very important or forms the crux of reporting, because the values and the parameters do get affected by several pre-analytical, analytical, post-analytical variables, and their importance or significance to decide on treatment protocols, monitoring protocols, further testing is so much important in COVID-19 that we cannot have any kind of misleading reports. In pre-analytical, which is one of the most important factor, I would say, it is important that we collect all the samples in the right vacutainer, maintaining the order of draw, the temperature monitoring during the transit, and sample storage is important. Many of these tests can also be performed if the sample is immediately centrifuged and the serum or plasma are separated and refrigerated at -20 degrees centigrade immediately. And the test can be performed by thawing that frozen sample even up to 30 days and in few cases up to 6 months. We should avoid testing severely hemolyzed and lipemic samples. Analytical process, of course, it is very easily monitor thing, and documentation over here is stringently followed and is possible. Proper selection of testing platforms. Usually we tend to avoid all the rapid platforms. Always we have to select a robust platform giving us accurate quantitative results. Calibration of the system and the kit needs to be followed as per the protocol, as per your laboratory protocol, that is the SOP, or as per the kit insert. High and low level of controls are run daily or with every batch. And of course, we need to have an external quality assurance program for all these parameters so as to keep us updated that we are doing at our level best and equivalent to whatever would happen anywhere in this world. And then finally, the post-analytical process of analyzing and giving out a comprehensive report, which is going hand in hand and helping in patient monitoring. The next is just an overview of the kind of packages we have. The basic package, what we have designed in our lab, includes a complete blood count, D-dimer, CRP, ferritin, and LDH. Many a times the protocols followed by other doctors, if the person has very mild infection or is a young person, it would be just an hemogram and CRP, and the other tests may not be asked for. Then a little extended package, especially for elderly patients or those having comorbidities, which also includes interleukin-6 along with the basic package. And an advanced package. These kind of advanced packages are predominantly coming in from certain hospitals which do not have in-house laboratory testing all these tests. These are predominantly for hospitalized patients or ICU kind of a setup, which would require addition of, say, TROP-I, CPK, CKMB, and procalcitonin in addition to the extended package. Further, it is very important for us to conclude on when these tests need to be done and how frequently. For the same purpose, I had covered the clinical classification because that decides on to when to start testing and how frequently to test. So a person who would be asymptomatic to mild infection, maybe just a complete blood count and CRP to give a baseline level of inflammatory process within the body would help. And then clinically, the patient can be monitored. And if all goes well, SpO2 is normal. The temperature, once it drops after the first 2 to 3 days of infection, doesn't come back. In those cases, further testing may not be required at all. In the people who would have mild but comorbidities and those who have moderate infection definitely would require what we call as our extended package, where we do monitor D-dimer. So all over 45 years of age group, those who have hypertension, cardiac disease, chemo patients, or any kind of other comorbidity should definitely avail that package as a baseline package, and then to be followed either every 5 days or around 8 days of illness when the possibility of cytokine storm increases is being followed. And of course, critically ill patients or those who are hospitalized, it would all depend upon the daily monitoring panels, every 3 days to daily to every 5 days based on what the baseline parameters are and clinical progress is. From the data in our laboratory, we have studied thousands of patients. As I said, this is a data over 6 months, and every case we may not have the history of the person being COVID positive. It does come in from different hospitals, smaller nursing homes also. But what we have seen is CRP and all these other parameters, especially CRP, ferritin and all are on a higher side in COVID positive patients up to almost 40 to 45% of cases. Obviously, procalcitonin is done in only certain number of cases where superadded bacterial infection was suspected or the patient was having a little more severe symptomatology. And procalcitonin positivity has been found to a much lesser extent. If it is positive, then definitely it mandates starting of antibiotic treatment, as well as, if possible, doing a throat swab or some kind of upper respiratory samples for culture and sensitivity as well. Again, on hemogram findings, as I was mentioning, we have seen all different possibilities, but higher amount of monocyte count and monocyte morphological changes have really interested us, and they are seen in almost 22% of the cases. CRP, as I was mentioning, even though it is higher, in majority of the cases, the CRP has been over the cutoff of 2 to 5, what we say as normal, to up to 10. In very few cases, only up to about, say, 10% of cases, the CRP values have been found higher than 10, and much higher, above 50, above 100 in only critically ill patients. In D-dimer, what we have typically seen is, of course, it is more than 1500 kind of values where it mandates to follow more rigorously and to start anticoagulant therapy has been seen only between 2 to 5% of cases. And that too more so in patients who are elderly, that is over 60 years of age group. Now coming to the immune response, that is the antibodies to SARS-CoV-2 infection. The immune response which is seen, it is not helpful more or less to diagnose an acute infection because it is mounted much later and when probably the person has started recovering. So IgM positivity is known as early as 5 days, but the median or average time when the IgM response is seen is between 10 to 13 days. The IgG response is again seen as early as up to 7 days, but median response between 12 to 14 days of infection. IgA again is seen from anywhere between 3 to 6 days, but it is not a commonly measured parameter. Antibodies are measured either to the nucleocapsid protein or to the spike protein, which are the structural proteins of the SARS-CoV-2 virus. Neutralizing antibodies are formed as early as the 9th day of infection. Several platforms are available. In fact, even in our lab, we have several immunoassay platforms on which we perform the testing. Of course, there are point-of-care tests also which are available for antibodies, which are immunochromatography-based tests, but these are less sensitive, and we have no experience of using point-of-care testing. What we use is predominantly these laboratory immunoassay platforms, which are either ELISA-based or chemiluminescent immunoassay-based platforms. Because the strategy which has been suggested is to maximize the specificity and hence the positive predictive value of picking up the COVID-19 infected cases. Then neutralizing antibody detection in actual sense, in the true sense, these antibody detection tests involve incubating the patient's serum or plasma with a live viral culture. This would determine the functional ability of the antibodies to prevent infection, something similar to the microbial antibiotic sensitivity culture and sensitivity which we perform routinely. So this hasn't been authorized for clinical usage. There are two such tests which are available, the virus neutralization test and the pseudovirus neutralization test. The virus neutralization test uses the SARS-CoV-2 virus itself, its clinical isolate or a recombinant of a recombinant virus. And the technique typically is that plaque reduction neutralization test. It requires biosafety level 3, not used in any of the clinical laboratories. The other is the pseudovirus neutralization test, which uses recombinant pseudoviruses like the vesicular stomatitis virus, VSV. Spike protein of the SARS-CoV-2 is incorporated in these viruses, and these tests would require biosafety level 2. All these antibody platforms have a lot still on a research basis going on, because today we are not very much confident or not completely know about the level of antibodies required for protection. Once these antibodies develop, what is the duration of protection these would put on us, and the kinetics of antibody response. Over and above all, these are all the immune response which is B-cell mediated or antibody production. We also know that COVID-19 has an T-cell immune response and memory T-cells also, which act as protective and which we do not test in the laboratories at the moment. The immunoassay platforms which are available with us in our laboratory are on an architect, which is the CMIA technique, chemiluminescent microparticle immunoassay. It detects the IgG antibodies to nucleocapsid antigen. It is a qualitative assay, not exactly quantitative. It does give an index, so maybe we can call it as a semi-qualitative, and the cutoff being 1.4. And what we have seen is the titer does correlate to a certain extent with the severity of infection. The sample required is serum and EDTA sample, and as I said, even here we can store the sample frozen below -20°C for up to 30 days and retest it. The next is another system to detect, which detects by ECLIA, that is electrochemiluminescence immunoassay, where both we detect the total antibodies, that is IgG plus IgM to nucleocapsid antigen. The cutoff for this test is 1, but again, there has been variable response based on severity, and the index obviously on a higher side in the patients who would have a little severe disease. The titers of these two tests cannot correlate with them one-on-one, because obviously the other one would have a little higher titer as it measures both IgG and IgM levels. The other platform which we started using, because it has detection capacity to the S1 subunit of spike protein and would even pick up vaccine-related immunity, was a chemiluminescent immunoassay on our Access system. Here, the cutoff is such that there is also a range in between, that is between 0.8 to 1, where it can be equivocal, and such patients should be retested after a gap of another 14 days. Again, here we found out that post-vaccination, some of the cases who would develop antibodies predominantly or in higher quantitation to the S2 subunit of spike protein may get missed on this platform. And so finally, we came up with another platform with a completely new equipment in our laboratory, and where it is again a chemiluminescent immunoassay, quantitatively detecting the IgG to both S1 and S2 spike proteins. It gives a rough indication towards the amount of neutralizing IgG antibodies developed in a particular individual, either post-infection or post-vaccination. It detects post-vaccination immune response to all available COVID-19 vaccines. Antibody titers in a convalescent serum in a convalescent person can be used for determining the ideal donors for plasma therapy, if at all this experimental treatment is going to be used on any patient. But as I mentioned earlier, even today we do not know how long this immune response would persist in a particular person post-infection or post-vaccination. A heparinized or an EDTA plasma sample or a serum sample are used for these tests. Again, the interpretation divides the patient into negative immune response, equivocal, and reactive. And ideally, it should be done post 15 days or 2 weeks gap post the exposure or post-infection, or 2 weeks gap post the second or the booster dose of vaccination. All these antibody tests do have limitations. Negative results do not always rule out COVID-19 infections. We have very well seen that we had certain RT-PCR positive cases with very mild infection and high CT values being reported, who did not mount enough immune response so as to be picked up by these available platforms. It cannot be a sole basis for diagnosis, or rather it cannot be the basis for diagnosis of an active infection, because antibodies appear late during the course of disease. Immunocompromised individuals can develop a delayed or insufficient immune response. Interference may be as a result of HAMA or heterophile antibodies, human anti-mouse antibodies, HAMA is, and even sometimes because of very high levels of RA factor. All testing platforms may not pick up post-vaccination immune response, as I have already mentioned earlier. This is a very nice tabulation where we can again decipher based on the tests which are available as to what kind of infection phase we are looking at, or whether the person has already recovered. If a person tests positive for PCR, but the antibody testing is negative, that means the person is in incubation phase to early infection phase. If PCR and IgM are positive, indicates that the patient is again in early infection, but the infection is less than 10 days and probably still infective to others. PCR with both IgM and IgG positivity is probably late infection phase, and the infectivity of this person, or the chances that this person may spread infection to others has definitely decreased. PCR positivity and IgG positivity, again, late phase or sometimes recurrent stage of infection. There have been few cases where PCR remains positive for up to almost 45 days post-infection. It is said that this is because of presence of viral antigens in the respiratory tract, may not be responsible for spread of infection, because many of these patients have been researched well, and it has been proven that on cultures there is no viral culture growth which is seen in these patients. So it may not be an infective case at all. Then there may be a certain case where PCR may be negative and IgM is positive. This may happen because of some patients who would recover very fast and had a very mild infection, so the PCR has become negative. But we should always keep in mind that PCR test may have been false negative for various reasons, or because of sampling error as well, and should definitely be repeated. Or the patient has only IgG antibodies, negative IgM as well as PCR. This is seen in past infection and the patient who has completely recovered. Or it may be IgM, IgG positive with PCR negativity. This is seen in early recovery phase. So this kind of summarizes the entire spectrum of COVID-19 PCR IgM comparison and testing. In our laboratory, our figures of antibody testing in the assays, the IgG assays to nucleocapsid protein, which we've been doing for over 6-8 months now, have shown positivity similar to what has been reported in other serosurveillances and studies, which is somewhere close to 30-31%. In post-vaccination cases, we have reported immune response in 75% of the cases. Probably the 22% cases where that immune response has not been recorded have tested too early post-vaccination and have not given enough time from their second dose till the sample being collected. Or there have been few people who, out of curiosity, did the test after just their first dose and definitely should avail the booster and retest themselves for the immune response. This is our wonderful immunoassay and biochemistry department in our laboratory. Very busy, handling almost 70 to 80% of the workload of the laboratory. And this is the wonderful staff who does all these tests in the laboratory. With this, I would end my talk. Let us all fight this COVID pandemic together. And now with better knowledge, I think after the talk of even the management and how the hospital has been geared up from Dr. Dhananjay Kelkar sir, we are, I think, all geared up, and we should definitely fight the second wave much better. Thank you.
एक second, sir. Thank you very much. It was an excellent presentation, madam. Lot of things we came to know. And first, I'd like to welcome here our MMC President, Dr. Shivkumar Uttare sir is here. I think he should say a few words. I request him, after I welcome him, and he'll say a welcome words for this. I'm welcoming him.
Yeah, I think good morning, and it is always a pleasure to be in IMA Pune branch, because whenever they call me, I myself I learn a lot of things from this branch. And today's whole topic, I've seen the whole program. I think it's an excellent program arranged. And just now I'm seeing almost more than 350 people are online. So that speaks volumes of how the program is held by this branch. And I'm sure that all delegates are going to learn a lot today, and the knowledge is going to increase. We are passing through a very bad phase again, which we thought we would not be facing just a couple of months back. So online is going to be the norm even in the future. And I wish all the best to my branch and all the members. And it's always a pleasure to be in this branch. Thank you.
Thank you, sir. Your kind
A,
words.
a request to everyone, can you please
Can you
mute,
mute all?
can you please mute your, can everyone please mute their
Please,
logins?
those who have
There
joined,
is a lot of
mute yourself.
disturbance.
Thank you.
Please stop.
Okay, okay. Omkar, please mute all. Okay, thank you. Please mute all. Mute from my side.
ऑन मुलं आहे त्याच्याकडे हा घे बंद कर बरं
सांग ओमकारला. So, thank you very much. You have explained, I would say, in a very efficient way, testing facilities. Also, you have covered the immunoassay department of biochemistry. All of these investigations, in nutshell, you have showed PCR, IgM, IgG, and their clinical significance. Will all of you please mute yourself? आवाज बंद करा. Thank you. Thank you. So thank you very much for this excellent presentation, Avanti madam. Are there any question answers? I am just going through. We have inactivated vaccines, adenovirus, vector virus, or mRNA vaccines. Please share opinion on pharmacodynamics and pharmacokinetics of upcoming DNA vaccines. I think we can have one session of this. Can anybody answer about the vaccines? Okay.
You send a mail to the AG and
We-
they will answer.
Hi. You send a mail to IMA Pune, we'll answer the things. Okay. Next, what are lab tests to diagnose DIC?
DIC basically is disseminated intravascular coagulation, also called as consumption coagulopathy, because it basically initiates thrombus formation within the body and uses all the coagulation factors. So typically all tests like prothrombin time, APTT, hemogram should be done because platelet count decreases in consumption coagulopathy, and that is what we call as complete coagulogram. So those tests are done. Obviously, the fibrin split products or the D-dimer levels are also included, and the D-dimer levels rise if there is a DIC. So low platelets, high amount of DIC, increased PT, INR, increased APTT timing is what is typically seen in a DIC, and clinically multi-organ failure also is seen. So ancillary tests like kidney function tests, liver function tests are also done in such patients.
Thank you, madam. Is the fresh sample required for IL-6?
Yes.
Yes, for IL-6, the temperature monitoring, or ideally as soon as the sample being collected, the sample should be centrifuged and serum and plasma should be separated. If this procedure is not followed, then interleukin-6 levels can turn out to be on higher side and be misleading. It is very important to monitor all the pre-analytics for IL-6 especially.
Thank you very much. I think the question and answer sessions we can take later also, and we will go for diary release also now at 11:40 a.m. sharp. And these sessions, after that, we'll have lunch and we'll start from 2 p.m. Some delegates have asked for the certificates. They will receive all the certificates after a week's time. After MMC, another approval is done, then you will get all your certificates. Previous also some have didn't receive 10 January certificate, they will also be issued. So thank you very much for this session. We conclude and go for diary release. Your question answers you can send at imapune@gmail.com. Please send your question answers. Whatever you have queries, we can answer them from the lab diagnostic of PG. IMA of Pune at gmail.com. You have already sent mail. You can send on that.
डायरेक्ट एजीडीला जाऊ द्या ना.
Huh?
डायरेक्ट एजीडीला जाऊ द्या ना.
Or you can send it to EG Diagnostic also. They will support in all way. Already they are supporting us. Thank you. Thank you all of you and join at 11:40. So we are going for diary release program. Thanks all of you. Thank all the faculties to join. They will rejoin at 2 p.m. Thank you.
Asya,
मला एकदम शाळा सुरू नाही काही नाही दिक्कत नाही खाणं बाहेर सोबत झालंय मायग्रेटरी ऑपरेशन खूप आहे काम करणारे कामगार असतात तो असं नाही होत असं तो दलित वगैरे सिनियर का junior? नाही नाही एवढं परवा कुठंच नाही कशा माझी सोनोग्राफी केली काय काय डिस्पेक्शन होता वरती पण होते आपण जायला पाहिजे वैकुंठमध्ये आलो परत सर चार वेळा नाही दोनदा मला ट्रॅव्हल करायचं होतं आणि तसं Oh. ऑडियो चालू
Hello. Okay. Is it okay?
काय ते
Welcome all of you for this prestigious event of our diary release program today. Firstly, I would like to welcome our chief guest, Dr. Kumar Utture, President of MNC. So also guest of honor, Dr. Asmita Tai Jagtap. He is the Executive Director for Bharati Medical Foundation. So also I welcome here our trust board. So also Dr. Dilip Sarda, our MNC representative here, past president, Dr. Shahade sir, our state president, Dr. Avinash Gondwe sir, past president, still we are feeling he is with us. Okay. And our president elect, Dr. B.L. Deshmukh sir, our senior very past president, Dr. Halve sir, immediate past president, Dr. Sanjay Patil, and Dr. Nauranga sir is there also here. Dr. Jay Nauranga sir, Executive Trust Board. So also our special guest also, the chairman of Diary, IMA Diary, Poonawalla Group, Poonawalla Finance. They have finance all of the diary, and they have, I would say, given a lot of efforts also for this diary. So I welcome here Mr. Shashi Shekhar Hiremat and all the delegates who have joined this live program of diary release. I would say really very much happy that we are having this prestigious fundraising program of our diary release. Next, I will request our president, or I would say dynamic Iron Lady president, Dr. Arti Linkar madam, to say a few words to start up this diary release program. After that, so first I request Dr. Meenakshi Deshpande to invite the president and take over this program of diary release in diary secretary. Dr. Meenakshi Deshpande, please take over this program. Thank you.
Thank you and welcome all. I think all the dignitaries have already been welcomed by Secretary Dr. Rajan Sancheti. I will now invite our President Dr. Arti Nimkar to escort our Chief Guest Dr. Shivkumar Utture sir on the dais. Next, I invite President-elect of IMA Pune, Dr. B.L. Deshmukh, to escort our guest of honor, Dr. Mrs. Asmita Tai Jagtap, Madam, on the dais. Now invite and request our Executive Trustee and Co-Chairman, Dr. Jayan Navarange sir, to escort Diary Chairman, Mr. Shashi Shekhar Hiremat, on the dais. Honorary Secretaries Dr. Rajan Sancheti and Dr. Sunil Ingve to be here on the dais. This is a great start to a great day, and we have achieved this on 21st of March 2021. A small function just for the release of a diary of IMA Financial Year Diary 21-22. And we will first begin our program with the felicitations of the chief guest of honor, and the chairman. So I would request our president, Dr. Arti Nimkar, to felicitate our chief guest, Dr. Shivkumar Utture, with a memento and shawl. Now I request her to also felicitate our guest of honor, Dr. Mrs. Asmita Tai Jagtap, and diary chairman, Mr. Shashi Shekhar Hiremat. I also announce the felicitation of the dignitaries who are sitting in the audience. Our past president, Dr. IMA Maharashtra State past president and MMC member, Dr. Dilip Sarda. I would request Dr. Sunil Lingay to do the honors. Our Maharashtra State past president, Dr. Avinash Bhondre, sir.
Sir.
Arundhati Pawar, Board of Operations, Bharati Vidyapeeth Medical Foundation. Our IMA Pune past presidents, Dr. Arun Halve, sir. And Dr. Shahade, sir. Dr. Sanjay Patil, IMA Pune past president, and now he's gone to IMA National with the board of directors of SBI. I now invite all the dignitaries for lamp lighting. I now request our president, Dr. Aarti Nimkar, for her address.
Good afternoon. I welcome you all. कारण आधीच डॉक्टर संचेतीने सगळ्यांची नावं घेतलेली आहेत, त्यामुळे परत रिपीट करण्याची अर्थ नाही. आय वेलकम युअर चीफ गेस्ट डॉक्टर उत्तरे सर, गेस्ट ऑफ ऑनर डॉक्टर जगताप मॅडम, आणि आपले डायरीचे चेअरमन डॉक्टर हिरेमठ, मिस्टर हिरेमठ, ते डॉक्टर फायनान्शियल डॉक्टर आहेत आणि खूप चांगल्या पोस्ट त्यांनी हँडल केल्या आहेत. आणि आता त्यांनी डॉक्टरांसाठी लोनच्या याच्यात ते एंटर झालेले आहेत. तर मेन उद्देश त्यांचा उल्लेख करायचा असा की जवळजवळ संपूर्ण डायरी त्यांनी फायनान्स केलेली आहे थोड्या, आणि ही डायरी त्यामुळे या कोविडच्या काळात एकदम एकरकमी
निदान खर्च तरी निघायला पाहिजे अशा याच्यात आम्ही प्रयत्न करत होतो. तर त्याप्रमाणे त्यांनी एका मीटिंगमध्ये पूर्णच्या पूर्ण रक्कम आणि काही त्यांच्या ऍडव्हर्टाइजमेंट सकट किंवा आर्टिकल सकट असं त्यांनी फायनान्स केलंय. तर त्यामुळे बऱ्यापैकी टेन्शन रिलीज झालंय. म्हणजे हे मेंटल टेन्शन त्याचं थीम पण अशी आहे की स्टेपिंग टुवर्ड्स द टोटल हेल्थ, दॅट इज सोशल, फायनान्शियल, मेंटल आणि फिजिकल. तर ह्या सगळ्या हेल्थच्या ह्याच्याप्रमाणे आमची मेंटल स्ट्रेस खूपच कमी झाली. एक उद्देश तिथे साधला गेला आणि बाकीच्या मग गोष्टी सोप्या होत गेल्या. पण त्या गोष्टी ज्या गोष्टीसाठी अगदी खूप असं डोक्याला त्रास होता की आता कशी आपण फंड्स गोळा करणार. कारण ही डायरी प्रोजेक्ट हा IMA फंड रेझिंग प्रोजेक्ट आहे आणि सगळे डॉक्टर IMA प्रेमापोटी ऍडव्हर्टाइजमेंट देतात. बोलताना म्हणतात की आम्हाला त्यातनं फार फायदा होत नाही, पण IMA प्रेमाखातर आम्ही देत असतो मॅडम. तर पण त्यांना ते नकळत बराच फायदा झालेला असतो हेही त्यांच्या लक्षात येतं आणि म्हणूनच ते दरवर्षी अगदी ठरल्यासारखे बरेचसे ऍडव्हर्टायझर असे आहेत की काही न विचारता हो आमची मागची ऍड कंटिन्यू करा, हा आमचं फुल पेज कलर किंवा कव्हर पेज असे देणारे वर्षानुवर्षाचे ऍडव्हर्टायझर्स आहेत. आणि त्यामुळे हे काम सोपं झालं. बर, खूप लोकांना अडचणी आलेल्याच आहेत. आपण कोविडच्या सिच्युएशन मध्ये बघतो की खूप आपलं फायनान्शियल कंडिशन लोकांची खूप चांगली नाहीये, पण तरी सुद्धा लोकांनी हाफ पेज का होईना दिलं. हाफ पेज कलर नाही तरी हाफ पेज ब्लॅक अँड व्हाईट, म्हणजे 9-10 हजाराची मदत करायला काही हरकत नाही अशा विचारांनी त्यांनी मदत केलेली आहे. आणि हा डायरी प्रोजेक्ट उभा राहिलेला आहे. आणि मीनाक्षी जी आमची डायरी सेक्रेटरी आहे आणि तिने आपल्या डायरी चेअरमन हिरेमठ सरांची आणि डायरी चेअरमन नवरंगे सरांबरोबर खूप कष्ट घेऊन ही डायरी अगदी छान सुबह सिंपल अँड स्वीट अशी एलिगंट दिसणारी डायरी आणलेली आहे. हे 32 वर्ष हे डायरी प्रोजेक्ट चालू आहे आणि प्रत्येक व्हाईस प्रेसिडेंट IMA बाय डिफॉल्ट हा प्रोजेक्ट करत असतो. म्हणजे त्या माणसाला त्याचं नॉलेज येतं आणि त्यातनं तो फंड कसे रेज करायचे हे त्याच्या डोक्यात पक्क बसतं. कारण त्यांनी आधी ट्रेजरची पोस्ट केलेली असते, नंतर व्हाईस प्रेसिडेंट झालेलं असतं. ट्रेजरच्या याच्यात त्याला बऱ्यापैकी गोष्टी कळलेल्या असतात की आपल्याला काय करायचं IMA फंड्स रेज करण्यासाठी. जे काही खर्च होत आहेत ते कसे टॅली करायचे हे तो तिथे शिकतो आणि व्हाईस प्रेसिडेंट झाल्यानंतर अजून फंड कसे रेज करता येते त्याचं त्याला बऱ्यापैकी अनुभव येतो. आणि त्यातनं तो ताऊन सुलाखून बाहेर पडला की प्रेसिडेंट होताना त्याला सगळ्या गोष्टींची कल्पना असते. व्हाईस प्रेसिडेंटचा प्रेसिडेंट इलेक्ट आणि प्रेसिडेंट होताना तर ह्या लॅडर आहेत IMA पोस्टच्या, त्याच्या प्रत्येक पोस्टमध्ये तो शिकत जातो आणि अनुभवाने पुढच्या म्हणजे आपला प्रत्येक प्रोजेक्ट सक्सेसफुल कसा होईल त्याचा विचार करतो. तर अशा प्रकारे ही डायरी आज आणि हे डायरीचं जे प्रिंटिंग आहे यावेळेस आम्ही अगदी नवीन माणसाला डायरी प्रिंटिंग दिलेलं आहे की ज्याला ते डायरी प्रिंटिंग म्हणजे IMA डायरी म्हणजे काय हे काही माहित नव्हतं. पहिल्या गोष्टीपासून त्यांना मला सांगायला लागलं बाबा ही डायरी अशी असते आणि अशा प्रिंट झालेली असायला पाहिजे आणि बाइंडिंग करायला पाहिजे, त्याचं डिस्ट्रीब्युशन करायला लागतं. तर त्यांनी आम्हाला कबूल केलं की तुम्ही अजिबात काळजी करू नका, तुमची डायरी एकदम छान प्रिंट करून देतो आणि मी डिस्ट्रीब्युशन साठी सुद्धा मदत करतो. कारण खूप वेळेला असं होतं की डायऱ्या प्रिंट होऊन येतात पण ते डिस्ट्रीब्यूट होते. कारण मागच्या वर्षी तर कोविडच्या याच्यामुळे डिस्ट्रीब्युशन झालं नाही डायऱ्यांचं. ज्यांनी आपल्या नेल्या त्यांना मिळालं, त्यांना येता आलं नाही किंवा ज्यांनी घाबरून इथपर्यंत पोचले नाही. आणि आमचा जो डिस्ट्रीब्यूट करणारा माणूस आहे तो त्यांच्यापर्यंत पोहोचू शकला नाही. त्यामुळे डिस्ट्रीब्युशन फेल्युअर असं म्हणता येईल आपल्याला. पण त्यातल्या त्यात सुद्धा बऱ्यापैकी लोकांपर्यंत आम्ही डायऱ्या पोहोचवल्या. तर प्रत्येक इथे येणाऱ्या माणसाला, फंक्शनला येणाऱ्या लोकांना आणि या सगळ्यांच्या मदतीने डायरी खूपच छान झालेली आहे. आपण पण वाचा, त्यातले आर्टिकल्स खूप चांगले आहेत. आफ्टर कोविड आपण म्हणण्यापेक्षा आपण अजून कोविड मध्येच आहोत, सेकंड फेज मध्ये. सेकंड फेज मध्ये आफ्टर कोविडच्याच गोष्टी फॉलो करायला पाहिजे असं मला वाटतं. आणि आफ्टर कोविडचा हा भाग परत नव्याने सुरू करायला लागेल. तर मी बाकीचं सगळं मीनाक्षी आणि सर थँक्यू.
Thank you, Aarti Madam, for your most loving words. I will now give a brief idea about how the diary came into the formation and what efforts we took for the diary. So, respected Chief Guest, Dr. Shivkumar Utture sir, Guest of Honor, Dr. Asmita Tai Jagtap Madam, President Dr. Aarti Nimkar, IMA Pune Executive Trustee, Trust Board and Co-Chairman Dr. Naurange sir, President-elect Dr. B.L. Deshmukh, and all secretaries and Dr. Sanjay Patil and Dr. Sarda sir, Dr. Bondwe sir, and esteemed guests of and on the dais. It gives me immense satisfaction to present to you this diary. And at the outset, let me thank our whole IMA Pune team for giving me this opportunity to work as a diary secretary this year. At the right beginning of the year, due to Corona pandemic and prolonged lockdown, leading to loss of businesses and loss of hospital income for many people, we were in a dilemma as to whether we should go in for a diary project this year or not. And this dilemma lasted for about 5 or 6 months. So till August, September end, we were still at a loss whether we should go in for this diary project this year. But then I consider myself very much fortunate that I received a thought of lump sum advertisement proposal. This idea was initiated by Dr. Sharad Agarkhedkar sir, and it was promulgated and supported by our Dr. Avinash Gutkar sir, Dr. Jayan Naurange sir, President Aarti Madam, and all seniors. And this lump sum proposal plan was designed meticulously by Dr. Sanjay Patil. So I'm very much thankful to all of them. I'm indeed grateful also to the next Secretary's efforts, Dr. Rajan Sancheti's efforts, who brought us near to Poonawalla Finance. And with his efforts, we could manage to contact them through his good offices. And they also took up this platinum proposal plan immediately because they got to know about this idea. They got to know how this idea would go to all areas of Pune. And Mr. Shashi Shekhar Hiremat, along with Mr. Abhay Bhutada, that time they had invited us. Actually, we had invited them, but then they invited us. And so it became a quite good relations with them. And then we fell into this platinum proposal scheme. And the chairman designated was Mr. Shashi Shekhar Hiremat, who was the chief business officer. And now he is the institutional head of Poonawalla Finance. So let's give him a big hand. Personal thanks also to the Poonawalla expert team, designer team, who gave us this design of the front page and the theme of stepping towards complete well-being. I think this design and the front page was thought over and designed for nearly 1 month they took. Isn't it, sir?
Yes.
So about for 1 month, they were thinking on what to give the design and how to give it in such a way that it would appeal to all the doctors and all the medical personnel who will be reading this diary after, say, 6 months. Then when we started working on this project, it was again a mammoth and a huge responsibility because, as you know, the Corona pandemic was still affecting. Are ye kyun diary project nikal rahe hai is saal? So that was the beginning of my diary project. So why are you taking out this diary? You will not get any support. You will not get any advertisement. So from a negative field, I tried myself to bring into a positive state of mind, and we have come to this date of diary release on 21st of March. So it was a very challenging era, and it was a very Herculean task. And I thank all our diary committee members, past presidents, stalwarts, and all seniors who have helped me through this project. Dr. Jayan Naurange sir was a much great support and offered his valuable experiences and skills to give us appropriate articles for this diary and also few advertisements which we were unable to get. I also insisted for an article on IMA Pune. So in this year's diary, we have taken lots of efforts to give information about IMA Pune Medical Legal Cell, and also an organ donation by Dr. Arun Halve sir. This year, I have come up with 2 new concepts of giving birthday wishes with photos on a particular day page and sponsored articles of achievements, Corona warriors or special cases and achievements during Corona period. And both have received a very good response. And I'm happy to announce that we have 38 birthday wishes with photo 12 30 birthday wishes without photo, and more than 5 sponsored articles, which has never been, we have not got before in IMA diary anytime before. So this is a new landmark for us, and I hope it continues through the next years to come. We have also incorporated this year in its emergency helplines, ambulance numbers, CPR page, tumor marker page for practice tips, and articles on financial fitness, social, physical, mental fitness, facts and information about IMA, hospital-related issues, and conditions, articles on conditions related to post-COVID well-being. And of course, a beneficial IMA Maharashtra State SSS article is also there, which is given the latest information now. And this has been included for the benefit of all the readers. I am grateful to all the authors and the experts for their contribution to these articles. I am also especially grateful to all past presidents like Dr. Avinash Bhutkar, Dr. Dilip Sarda, Dr. Avinash Bondwe, Dr. Arun Halve, Amrish Shahade, Dr. Padma Iyer, Dr. Prakash Marathe, Dr. Maya Tulpule, Dr. Mohan Joshi, Dr. Hemant Karandikar, Dr. B.M. Dikshit, Dr. Kelkar sir and Dr. Nene sir for giving me their timely inputs and their contacts for advertisements. At the same time, I should not forget to mention our diary committee members like Dr. B.L. Deshmukh, Dr. President-elect, Treasurer Dr. Raju Varyani, Dr. Nandakishore Mantri, Dr. Ravindra Chajed, Dr. Anand Deshpande, and especially Dr. Virendra Oswal and Dr. Prasad Agashe, who have given me lots of inputs this year, and they being the new managing committee members. Dr. Aruna Zafekar and Dr. Diary and other diary committee members have also helped me throughout my tenure as a diary secretary. And most special thanks to Dr. Rajan Sancheti, Dr. Sunil Ingre, and especially Dr. Alka Shivsagar, without whose help this task would have been difficult. IMA diary now cannot be conceived without the advertisers, and I thank all my esteemed advertisers and well-wishers for their timely response and timely advertisements, especially in these tumultuous times and difficult times. Lastly, my thanks also goes to our IMA Pune staff, especially Aniket, Ms. Pooja, Santosh for going around and getting the checks, Ms. Neha and Suparna for maintaining accounts, and AG Diagnostics, who have given us a CME for this diary release function. Last but not the least is a huge thank you to our printers, Mr. Rahul Marulkar, who are senior and experienced more than 40 years in this field, but new to IMA project and IMA diary. But they have cooperated with us in every possible way. And the last, again, a big thank you to my family members who have cooperated with me, and my husband, Dr. Anand Deshpande, who has helped to give me new links and new advertisements for this diary. Finally, I bow down to Almighty, and the grace of God is supreme, who has helped me through the project and also helped our IMA Pune project this year in these tumultuous times. So I thank you all, and I wish all of you a corona-free, healthy, and a happy, prosperous new financial year ahead. Thank you.
मग ती पोरगी नाही ना तिथं मेन पोरगी नाही विचारलं त्या पोरीला विचारलं पॅकेज काय ती म्हटलं आमच्याकडे पॅकेजच नाही मग पहिलं क्वेश्चन विचारलं तुमच्याकडे पॅकेज दाखवा मला म्हटलं आमच्याकडे पॅकेजच नाही मग आता हिला बघितलं हे अजून आले नाहीये तुमचं आलेलं पण काय I medical council.
Before starting the diary, as Dr. Meenakshi said, that I was looking after Poonawalla group for great role in our diary development. And I found the person, a dynamic person, who had started this project. So I'd like to introduce it in a nutshell. Mr. Shashi Shekhar Hiremat spearheads the business development role in Poonawalla Finance as Chief Business Officer responsible for alliances and execution of product and market related strategies of the company. Shashi Shekhar has over 2 decades of experience holding various senior positions in banking in leading Indian private sector banks like ICICI Bank, IDBI Bank, SDFC Bank, Kotak Mahindra Bank, Yes Bank in areas of product development, CRM, and distribution of banking products like liabilities, retail and commercial assets, wealth, and trade services for various customer segments through multiple channels, including bank branches, outbound sales team, relationship team, and other alternate channels. During his stint as business leader for government, PSU, cooperative bank business, Sashi managed to develop excellent relationship with CXO level position in these entities. His MBA and LLB pursuing digital marketing and social media from IIM Calcutta. So I request him to say a few words about the diary. Please come, sir.
Hello, everyone. Respected dignitaries on dais, ladies and gentlemen, welcome Chief Guest, Dr. Shivkumar Utture, President IMA Maharashtra State, and Guest of Honor, Dr. Asmita Tai Jagtap, Executive Director, Bharati Vidyapit Medical Foundation. Being the non-medical person and heading a diary chamber, this is something pretty challenging for me. You know, I feel I'm just like a eyesight driver. Let me share a short story so that at least you can understand what kind of feelings I have to heading the diary chamber. When Einstein won Nobel Prize, he delivered more than 300 lectures across UK, and his driver accompanied him. One day they got an invitation from University of Columbia, and driver suggested Einstein, boss, you are a very slow speaker, and I heard you more than 300 times. So, and good part is that nobody knows you in US. So instead of you, I'm going to give a lecture, and you sit in front of dais or chair, not a dais. Apparently, Einstein agreed. Both went to University of Columbia. Driver is sitting along with Vice Chancellor on dais, and he had given a very flawless, a sentimental, a good speech, and finally he got a standing ovation. Followed that, there was a question and answer session which driver was not aware. It's very difficult for to manage the situation. University of Columbia was full of brilliant students, and meanwhile, one of a student asked a very difficult, a toughest question to driver. He replied, "Young man, this question is very easy. Even my driver sitting in the audience can answer it." So the gist of the story is that whatever the questions you have, you please ask Dr. Nimkar, not to me. Well, I am from finance domain, and I would like to highlight certain aspects about finance and how it is beneficial for the doctors. India has witnessed a high level of economic expansion over the last decade and has emerged as a knowledge-driven economy today. Keeping in mind it's a large domestic market and a demographic advantage, it has emerged as a prime economy. As per the World Economic Forum, India remains one of the world's most promising economy despite the recent slowdown in its growth. The country expanding middle class and a large pool of young entrepreneurs along with professionals, doctors. And definitely it will enhance the scale of economic chart. Finance and health is a key component for the success of any business venture. It is health that is real wealth and not a piece of gold and silver, quoted by Mahatma Gandhi, is a self-explanatory and shown the importance of doctors in day-to-day life. To pay homage and to appreciate Corona warriors, we are introducing a financial diary with the theme of stepping towards complete well-being, which covers financials, social, mental, and physical aspects. Highlighted topics in the diary are financial planning for doctors, how to read your credit information report, top 10 reason why people take an unsecured loan, and take your high cost loan in a 9 easy steps. And finally, financial safety in the digital world. I take this opportunity to thank and appreciate the efforts of Mr. Abhay Buttada, MD and CEO of Poonawalla Finance. His dynamic leadership and deep expertise in the financial domain has helped us come up with this unique association, which should help the entire doctor fraternity. I also must thank Dr. Aarti Nimkar, the president of IMA Pune, for her huge contribution to this project and make it a success. I extend my gratitude to Dr. Jain Navarange, co-chairman, IMA Pune, Diary, for all his efforts. A special mention to Dr. Avinash Bondwe, ex-president of Maharashtra State, IMA, for his valuable inputs. Of course, Dr. Meenakshi Deshpande, our diary secretary, has been phenomenal in her efforts towards the diary project. My sincere thanks to all the office bearers and managing committee members, including Dr. Deshmukh, Dr. Rajan Sancheti, Dr. Sanjay Patil, Dr. Sunil Ingle, and all others for the help extended by them. Yes, IMA diary cannot be conceived, let alone be executed, without our advertisers, and we express our gratitude for the same. Finally, wishing everyone a complete well-being from my side as well as from Einstein Driver. Thank you very much.
Thank you very much, sir. And may I request Dr. Sunil Igwe to felicitate Dr. Ravindra Kute. He has come from Srirampur, and he is also a CGP Vice President of Sir. I request Dr. Meenakshi to take further.
I invite all the dignitaries, I invite the chief guest, Dr. Shivkumar Utture sir, and guest of honor to release our financial diary.
Only for 1 minute. Less than 10 minutes is allowed.
पुढे फ्रंट रो ला येऊया का सगळे इन वन रो नाही नाही ओपन deliver the diary.
Thank you, sir. Thank you, madam. May I request for President Dr. Aarti Nimkar to to felicitate co-chairman Dr. Jay Naurange sir. No big hands, please. Thank you. Dr. Meenakshi Deshpande. Also request to felicitate our printer, Mr. Rahul Marwalkar. Dr. Meenakshi Madam will felicitate Mr. Rahul Marwalkar. Excellent, beautiful diary.
Assistant पण होते पण आता आलेले नाहीये. He was a very active person.
May I request Dr. Meenakshi Deshpande to introduce new age guest of honor, Dr. Mrs.
Asmitatai Jagtap, we are honored to have our guest of honor, Dr. Asmitatai Kadam Jagtap, daughter of the great visionary Dr. Patangrao Kadam, who works on the motto, do more of what makes you and others happy. And for her, it is all about serving humanity. It is all about taking her father's legacy forward and serving her people and her country. She is MBBS of batch 2002. She is diploma in labor laws, DLL, with a postgraduate diploma in medical legal science. She is an MD psychiatry done in 2011, and she is also a PhD in hospital administration. She is the executive director of Bharati Hospital and Research Center, Pune, a patron member of Bharati Vidyapith, a trustee of Bharati Vidyapith and Patangrao Kadam Pratishthan. She is also the trustee of Abhijit Kadam Memorial Foundation. She is the president of the Rotary Club of Purandar. She is a member of Sri Shivaji Shikshan Prasarak Mandar's College of Education, Saswad. And we are very proud to have her as a guest of honor because, as you know, just as you can tell a well-cut diamond from across a room, you can always tell an exceptional woman even after a few minutes of conversation with her. So I invite our diamond guest of honor, Dr. Asmitatai Jagtap, for a speech.
Good afternoon, everybody. Dignitaries on the dais. I really like coming to IMA programs because I get so many compliments which I usually don't really get, and I should really thank ma'am for the same. So I get to know a lot of aspects about me which I really.
Let me start by wishing you everybody a happy anniversary. Now, if you ask me what anniversary is about, I'll say in a day's time we'll be celebrating the lockdown of the COVID. So not many people are very keen to celebrate that anniversary because it really had a lot of financial, emotional, and a lot of implications on a country as such. But as doctors, I believe that we really had to suffer a lot. See, the problems which we had to face last year were quite different from what we are going to be facing in the years together. The last year problems, if you ask me, be it a small clinic or be it small hospitals or even a big institute like us with about 600, 700 beds, were similar. But the losses which we had to face were quite huge. There was shortage of manpower. There was huge retention of nurses, which we could not do. There were no direct directives which were given to us, nor there were any PPE kits were available to us. So these were the lot of issues that a lot of us had to face last year. And this year, the issues are going to be different. When I heard that the digital financial planning, it had an article about how to do financial planning for the doctors, I was really, really impressed with that. Because we really need to start thinking about our finances, especially in a time like pandemic, where we have really had not thought about it. Do we need to do financial quarterly or yearly planning? Do we really need to review our systems? If yes, how do we face it? We know this pandemic is here to stay. We know now the coronavirus is going to be here to stay with us. But till what end? We cannot say that it is going to end in a month's time or 2 months' time or next 6 months' time. So how do we go about it? What are the directives? How is the government going to help us all? We really need to all think of all these problems. How are we going to see the worst thing? What I've always seen is the WhatsApp and the Google University. People come to us, patients come to us. They come to us, they're saying, "Nahi, ma'am, ye medicine to government ne itni कीमत में लगाए, why are you charging us those?" They don't know the problems we have to face. How do we tackle all this? And I've seen a lot of these issues were handled by IMA very brilliantly last year. And like I said, that is one of the only reasons I love coming here, because they do tackle most of the problems. But the main reason for me to come here is we all need to be together. There are a lot of directives coming up. There are a lot of new initiatives coming up. We really need to stay together, where we have to give all our proposals to government, all our proposals to PMC together. We cannot say कि नहीं ये तो big hospital है, इनके तो 1000 बेड है, they must be earning a lot. No, nobody is earning right now. Nobody wants to earn also right now. What we are all doing is a commitment to our society. We small clinics, all of them. But we really need to come together. We really need to be on the same platform if we have to fix this pandemic. It's all right, I'm fine. Sir, when I do a lot of political rallies, which I usually do, trust me, these are a really, really good audience. So the political rally and the counseling which I usually have for the kids, they are a much different crowd. So I'm happy with the crowd over here. So like I said, we all have to be together. Let us all come together. Let us face this pandemic together. As Bharati Vidyapeeth, we are always there for all of you. We have started a lot of new initiatives also for the doctors, their families, and we are doing a lot of new stuff. Please do come to our institute. We have a new super specialty which we are opening up. We have a lot of new 3 physiotherapy colleges opening up. So we have a lot of things going on Bharati Vidyapeeth. Do please come here. I just wish all of you, like ma'am said, a healthy and a COVID-free pandemic for the next year. Thank you. Thank you.
Thank you very much, madam.
We are really proud of you that in Bharti Hospital, we have seen a lot of patients were saved and we have taken a lot of initiatives. Being a Bharti, I really feel proud of all of our Bharti team. We have taken a great initiative in this COVID pandemic. So also here, Dr. Arundhati madam, she was also there for our each and everything we needed in COVID pandemic. It might be admission, it might be the treatment part for all the patients. We are really, I would say, indebted that all of the things were taken care of. Thank you. May I request Dr. Meenakshi Deshpande to invite? Yeah. I request Dr. Jain Naurange sir to say a few words.
I will be speaking half English and half Marathi. And भावाला also बोलून आले. Welcome all of the dignitaries on the dais and off the dais. And indeed, it's my great pleasure to introduce my very good friend, Dr. Shivkumar Utture. Incidentally, I would just say that there are 4 A's today. It's a Sunday. There is Shivkumar, there is Shashi Shekhar, and the things are Shashwat. So, a little background, actually I'm stepping beyond whatever I'm asked to do, is that to tell you a little about this diary project, sir. And this is for the information of my junior colleagues. I have been pretty old in this institute, and we were the few who started this particular project to help always economically ailing IMA that time. And this was started 32 years back, and today is the 33rd diary, and this is for the first time in our history of diary. If I'm right, I think Avinash can correct me or Dr. Sarada can correct me, that we are releasing the diary right 1 week before the 1st of April when it becomes due. And that too in a very crisis situation like this pandemic of COVID, where so many hurdles are there, as all the speakers have mentioned about it. And to our rescue, and this is for the first time that, as what Meenakshi has mentioned, that we had this platinum sponsor. And that is why, because of Mr. Shashi Shekhar only, this diary project has come true in time. Otherwise, we would have hunted for the advertisement still 1st of April and go on printing, and then ultimately the distribution would occur after 10th of April with all the scoldings on us. So I'm very lucky, very happy to have all this teamwork, Shashi Shekhar and people like Asmita Tai and Arundhati Madam. All these are our great supporters also, Mrs. AG Diagnostics and our great friends, and they are always taking part in our diary release program. And Meenakshi has worked relentlessly. Initially, I'm sure she had spent sleepless nights with all the tensions, whether we can come out with a diary project or not. And I'm sure, and I'm very happy to say that this diary project has made a definite success, and this helps. And sir, Shivkumar, I would just like to mention that this particular initiative, when I talked to Y.S. Deshpande, he took it to his heart. Next year, Nagpur bench came out with similar diary, and now it has become a permanent feature for them. I think it's their 33rd or 4th year, and ours is 33rd. So hope IMA Maharashtra State will also take up the issue, because we are always short of funds. And what Shashi Shekhar has said and Asmita Tai said, ultimately the core of any success or anything positive to be done, forget about the economic success or not, you require this seed, which is the money. So ultimately it's easier to say that we should be working for our motto. Ultimately it boils down that any work is possible, at least with meeting the two ends of finances. So this was beyond my scope of talk right now. It gives me immense pleasure to introduce my very good friend, a very humble, very honest, very helpful, ever agile, always a real student, and a very masterly speaker, Dr. Shivkumar Utture. Give him a big hand. So we have chosen few in this audience because of the pandemic situation, which has worsened in the last 2 or 3 weeks, and therefore we were there to invite not more than 30-35 people. But I'm sure, and I have got the figure right now, that more than 350 are listening to whatever is going on in this auditorium, and that's why our people are there. And I'm not exaggerating anything, but he is the academic chief and our real leader of whole Maharashtra state doctors, because he is the president of Maharashtra Medical Council. So Maharashtra Medical Council is the statutory body which governs us, all of us. So whether we are members of IMA or not, whether we are sitting in Pune or anywhere else, we are governed by Maharashtra Medical Council, and we have another eminent Maharashtra Medical Council member with us in the audience, Dr. Dilip Sarda. So these are the chosen people from us who are representing us in the council, who are taking our care, but also governing us with all vigilant eye. And they are not the people who can be bought. These are the people of integrity. These are the people of principle. So we have to follow all the rules. And these are the people, 9 people out of, I think, 21, who are chosen people, elected people from amongst us. And I'm very happy to say that Dr. Shivkumar Uttare is elected twice, and both the times he is the president of Maharashtra Medical Council. Both the time. Oh, sorry. First time it was Tauri, and second, unfortunately, we lost him. And Dr. Uttare is there, currently the president of Maharashtra Medical Council. Secondly, he is also in the National Medical Commission, which is newly formed as per the new law. So he is a member of the National Medical Council, member of the Medical Advisory Council. By profession, he is general surgeon as well as laparoscopic surgeon, a thorough academician, and a professor of surgery and laparoscopy in ZZ Group of Hospitals and Grand Medical College. He is expert in minimal access surgery, a renowned postgraduate surgeon, postgraduate teacher and examiner of MUHS since last 35 years, professor of IMA College of General Practitioners of IMA headquarters, past chairman of A.K.N. Sinha Institute of Medical Education and Research in 2015-16, recipient of Ati Vishishta Paryavaran Mitra Award in the field of medicine and public health, also recipient of IMA National Award for Lifelong Services to IMA in 2015, recipient of Excellence and Ideal Services towards award as teacher in government. This is a very big achievement in my opinion. Recipient of Excellence and Ideal Service Award as teacher in government medical colleges in 2013, and so on and so forth. So also he is instrumental in starting Dr. Shankara. This is unique. Shankara Uttare, that is in the name of his father. He has started a high school in his native area near Belgaum in memory of his father at his native place, imparting free education, books and clothes, and this is a special emphasis on women's education. So with this, I'm really grateful that I got an opportunity to introduce you, sir. You are my idol, a very studious person. You will listen to his scholarly presentation now, a very sober personality and a born teacher and academician. Dr. Shivkumar Uttare, please. Thank you.
Good afternoon, everybody. And thank you, Dr. Naurange, sir. I call him sir because he is truly my sir. I learn a lot from him in IMA and otherwise also. And I think next time in my biodata, I will be adding one more line that I was introduced by Dr. Naurange, sir. That is a privilege. That is a privilege. Respected President, Dr. Nimkar Madam, today's invitees, Dr. Hiremat, guest of honor, Dr. Mrs. Jagtap Madam, secretaries, Dr. Sancheti and Dr. Ingre, and Dr. Sancheti is continuously in contact with me. And of course, Dr. Meenakshi Madam, who seems to be the chief architect of today's whole show. I still call him my president because I was a finance secretary under him, Dr. Sada sir, who is a staunch pillar in the MMC whenever we have any problems over there. So thank you very much, sir. Then Dr. Bolwe, who has also been the president of Maharashtra State. Dr. Patil Sanjay, another person whom I always say the hero of Pune, who is always, well dressed and absolutely physically fit. I think you must be following Dr. Naurange. Then Dr. Shade, Dr. Arbe, Dr. Variani, Dr. Deshmukh sir, and of course my very, very, very close friend, Dr. Kute sir, who is the Vice President of IMA Maharashtra State. And of course many others. I think Pune is such a branch. If I start taking the names of all the main dignitaries, important persons, I think the whole speech will be only mentioning their names. So, it's always a pleasure to be in this branch. And the reason is that though I have been called here n number of times to give a talk, but let me tell you, when I sit in this room, I learn a lot from everybody. And that is, I think, the uniqueness of, this, especially this hall. As they say, Pune is the epicenter of learning, of education. I think this hall also is an epicenter of IMA learning. So thank you very much for having invited me today over here. So release of the financial directory. So before that, I think I must thank, because more than an MMC president or an NMC member, I am an IMA activist. And I must thank Dr. Hiremat for financially helping out in getting this directory, because I know I have been for 9 years as the finance secretary of IMA Maharashtra State. When I took over at that time, I think all of you, especially seniors, know what was the position of IMA Maharashtra State financially. But how difficult it is for IMA to really grow. And of course, another thing I would like to definitely mention over here, which I have already told Dr. Jagtap madam what she said about the unity. I think that is, madam, what is most important for our profession, especially with all the new regulations, rules which are coming in. And we are, as a profession, I think last 1 year, if there is one profession who has really contributed towards this COVID pandemic, it has been the medical profession. And unfortunately, there is always the thali bajao and the flowers and everything which is there when they need us. But when that is over, we know what is happening to the medical profession today. And I think that is the sad part that is happening. So it's high time we do not think in terms of I am a general practitioner, I am a consultant, I am a small nursing home owner, I am a medium scale owner, or I am a big institute owner. I think all of us have to come under one umbrella, because let me tell you, in future also our problems are going to increase. And this why I am saying is because I am there in the center, being a statutory body in the center, and I come to know in advance what is going to hit our profession in the future. I'll just enumerate a few things whenever I talk further. So thank you very much for bringing up that very, very important issue of unity amongst our members. So as far as this finance director is concerned, when I was, they gave me a call and they told me, sir, you have to inaugurate this finance directory. I readily agreed, because last more than a year, hundreds and hundreds of, Zoom meetings I've been attending. So I said, I'll be sitting at my house and residence and inaugurating this. So they said, no. So this is a very important thing. You have to come down to Pune. That is what Dr. Meenakshi madam said. And then, of course, Dr. Naurange phoned me up. And whenever Dr. Naurange requests something in inverted commas, it's a command. So we cannot not obey him. So today here I am in Pune, in front of all of you, but I'm very thankful for having called me over here. But I thought there would be nobody in the audience, but I see the who's who of Pune, they are sitting over here in front of me. मराठीत असं म्हणतात की आपण कुठलंही सोंग आणू शकतो, पण पैशाचं सोंग आणू शकत नाही. So you can project yourself as anything, as an expert in every field, excepting as far as the finances are concerned. And there is a adage in English also which says that money is not everything in life, but without money there is nothing in life. So that is the importance of this finance, and that is the importance of such a huge organization. You see the whole establishment which is over there. Not only that, the number of programs that you have been doing, everything costs money, and what people don't understand is where does this money come from? And therefore, I think I must congratulate Dr. Meenakshi Madam, Dr. Naurangi sir, and of course, President Madam and the whole team over here for not only bringing out a beautiful diary. So when I was presented that diary, the first thing that came out from my mouth was, diary bhari ahe and bhardasta ahe, just like Pune branch. So if you read the topics which are there, those are so practical topics which are there with day-to-day life. Unfortunately, we do not learn this in our formative years. But then what is going to affect you day to day, all those topics I am seeing which are mentioned over there. So this diary is something not for 1 year, I feel this diary is something which you can keep permanently on your desk over there, because every time you can refer to it for all the information that is there in that diary. Not only I am saying education, but even if you see, I think if I'm not mistaken, a lot of contacts and all are also given over there, if wherever we and whenever we require that. So that is the importance of this diary. And therefore, I say this is a Bhardasta diary, and it's a very, very important diary. Now, another thing that I'll take this opportunity to congratulate, because now this year I've been a part and parcel of that is your legal CMEs. I think that is something which IMA have been after everybody to take up, because having been for almost 8 years in the council, sitting over there, I see sometimes my teachers who come to the council against whom there is a case, and then it is so pathetic that from someone whom you have learnt your medicine, that person comes there, sits and says that I have been taught medicine and I have been teaching medicine, but nobody taught me that this was the problem that I have created, or this is the mistake that I have done. And after almost 30-40 years of fantastic practice and name, fame, everything he has gained, but 1 or 2 such cases in their life, and I have seen them collapse. Not only that, I have seen a couple of my friends against whom there have been cases which have been filed. They have given up their medical practice and they have joined something else. So that is how they are affected. And I must congratulate you for having this legal session that you have been continuously having. I was also invited, and I make it a point. Even today I get the links. Whenever I have the time, I do come in and I join and I hear what is said. My only request would be, sir, that out of them, whatever is practical, please take it out. You can either give it to MMC, because in MMC now we have launched our own platform, which will be again accredited, where you get credit points also, but it will be completely controlled by MMC. So we can put it down under the legal heading over there, IMA legal heading, so that people come to know, because you cannot go and teach this to all members. We have almost 160,000 registered practitioners. You cannot show it to everybody. But if you can put it online, we have seen that thousands and thousands of people go online and hear it, and they can hear whatever subject they want. If you can do that, so that, as I say, knowledge should not be kept in a closed room. Knowledge should be for everybody in the society. So I just request you to try to do that. I hope you will be able to do that in the future. Another thing that I would like to talk about is what is going to happen in the future as far as our profession is concerned. See, it is so sad, as I said, that during the COVID times, they gave us bouquets, they gave us flowers and everything. And then suddenly, once the COVID went down, there was a bombshell under the garb of amendments in the Nursing Home Act. And they called it as the Maharashtra Nursing Home Act. And if you read the amendments, it is going to be next to impossible for small nursing homes to really do whatever changes they are asking us to do after almost 30-40 years of running a nursing home. Because they have asked infrastructure changes, they have asked the changes in the staff. Majority of the small nursing homes are run by single or couple doctors who are there in that premises itself. So how do you expect them to have a doctor, qualified doctor, round the clock in 3 shifts, a qualified nurse round the clock in 3 shifts, especially nursing staff? You know how difficult it is, qualified nurse to get. You do not have the infrastructure to create nursing colleges and bring out more nurses. On the other hand, you want to force the nursing homes to have qualified nurses. Where are you going to get these qualified? So there are n number of such things which have come up in that. We are fighting that. We have already created a document, and I am in talks with the Honorable Minister. Of course, he is quite sympathetic, and he has said we will sit down and we'll try to see what is practical and what is not practicable as far as this amendment is concerned. So why I'm mentioning this is because this is going to hit us one after the other in the future also. And the only way we can tackle this is going to be under the banner of IMA. You know, when we were sitting on top and we were discussing about CMEs and this, so and Dr. Sada asked me how many accredited CMEs we get in MMC, because he's in charge of whole Pune region CMEs. We get in hundreds and hundreds per month. And we in IMA, as leaders, have always been saying that we do CMEs as far as IMA is concerned, but the time has come for us as an organization to get away a little bit from the CMEs and concentrate on the problems that are being affecting our members. Because ultimately, all you see, ASI, API, or Foxy, or even the Orthopedic Association, Ophthalmic, all these ultimately come under the umbrella of IMA. And today, even they, when they have their problems, they do come to us because they know the mother body is going to be IMA for the medical fraternity in future also. So if you can do more and more such legal aspect, and sir, go beyond Pune, go to Maharashtra, go to all India level. This is going to definitely help our members. And I think that's what we should achieve as far as IMA, and that is what we are here as far as IMA is concerned. Then of course, I'm going to be very short because of the time factor. I was told to talk something about MMC. Unfortunately, over the years before we as an IMA came as a body onto the MMC, where all the 9 members, even last time, we got elected, and even when before I became the president, all 9 members of IMA got elected on MMC board. Out of 18, 9 are elected. Unfortunately, before that, there was such a bad reputation that any doctor had any case in MMC, he used to get more scared about the case coming in MMC than in any court of law. I think things have changed now. Let me tell you, a stage has come in our medical practice. I have been as a surgeon practicing for almost around 35-40 years, and I've seen the change which has slowly come. And I tell all my juniors that don't get scared of any complaints against you, because in future, just like in the Western countries, complaints are going to be a norm, not an exception. We as a generation were very lucky where very rarely the complaints have ever come for people of our generation. But in the future, complaints, and this basically is happening because I think more education of the patients, and many a times the wrong education because of the Google doctor and the WhatsApp doctor. Where today what is happening is the relatives feel that even if they have brought into an hospital a very, very serious patient, just because they have brought him to an hospital and he's alive, he should go out of that hospital alive. And unfortunately, this has happened because we have been treated as God. Everybody tells us, you are a God figure, you are a this, you are a that as a medical profession. I said that is what has been wrong, and that is what is hitting us today. Because we have been put on a pedestal over there as God figures. So they expect us to do what God does, and that is to save you, which is not possible. Medical science has its own limitations also. So don't worry if you have done nothing wrong and if there is a complaint against you. All you have to do is answer, because it is a statutory body. MMC has got the powers of a civil court. It is there mentioned over there. So these are huge powers with the council. But luckily, let me tell you, because the council is made up of clinical people who are sitting over there from every field of medicine, definitely when we hear a case and the judgments that we give is on a clinical basis also, it is not on purely legal basis. So if you have done nothing wrong, there is nothing to worry. As I said, it's going to be a norm in future that complaints are going to be at least 1 or 2 in your whole life. Please answer NMC. The mistake that our people do is they do not take the notice which is sent very seriously and they do not answer it properly. And again, here is where IMA plays a big role. And I think Pune is doing a fantastic job because you have got your own legal team. And I find more and more of your members every time I come, more and more of them have done LLBs. So take the help of your legal team to answer this properly. And parawise, you answer it. And Dr. Sarda will vouch for what I said is, if your answer is given correctly to the MMC, in the initial phases itself, this case and your file gets closed. It does not go for charge sheeting and does not go for further hearings. Then they ask me many a times, seniors phone me up, so and so I know there's a case against him. Should he get a lawyer? No, it's not necessary. If what you have done is correct, what you have answered is proper, there is absolutely no necessity for you to get in a lawyer. When does the lawyer come into play? A lawyer will come into play when he tries to find out some legal point to get out of that case, not a medical point. So please answer that properly. Attend the hearings whenever you are called for. Even if you have a lawyer who is representing you, it is always better that you also be physically present. And how you choose a lawyer is also very important. If you are going to choose a lawyer who has absolutely no medical background, it is going to be very difficult for him to save you or defend you. But luckily for us, a lot of our members are becoming lawyers. So they understand both the medical aspect also and the law point also. And I think we are the only councils, the Maharashtra Medical Council, which allows you to bring even your friend, your family member, anybody to defend you. He doesn't have to be a lawyer who is, registered under the Bar Council. So that is the advantage that you have. So you can always take the help, and people are taking the help. You can bring them to the council with you whenever the hearings are there. You can take their advice whenever the hearings are there. Having said that, let me also be very, very clear that if you have done anything wrong, the council is going to definitely take action against you, because the council is meant for that. It is a statutory body. It is supposed to be doing good both for you and the patients. Otherwise, we'll lose the whole aspect of sitting there as in the council. So the first thing is, along with your medical studies, what your branch is doing, please also know the legal aspect of what you are supposed to do and what you are not supposed to do when you are practicing. Once you do that, and as I tell everybody, they ask me, how do you define that what I have done is right or wrong? The only thing I tell them is, if something happens to your patient and you have done the best for your patient and you go home and you can go to sleep peacefully, you have not done anything unethical. It is very simple. So I think I have another thing, last thing, sir, which I spoke with you also on top. COVID season, we are coming almost 1 year down the line. and our whole profession is very, very badly hit right from day one. And we have been on the forefront over there. Last couple of months, I'm finding in my colleagues, the way they talk, the way they behave, it is changing. Somehow this is affecting them, though we feel that, it's not going to affect us. Let me tell you, I myself was admitted for 9 days. I know what torture it is to sit in that single room with no one coming there to talk to you. Even the doctors coming who stand 6 feet away from you, no one touches you and just asks you, how are you? Even being a VIP patient over there in an institute in which I am a attached honorary surgeon over there, 9 days over there. So people do get affected. I think even as IMA, it is our duty to try to have some system in place where we can help our members to come out of this mentally, financially, socially, in all aspects. And that I hope that all branches have at least a small group of volunteers who come forward and on whom these members who are being affected can fall back on. So having said that, I think I have gone beyond the time that you have allotted to me. So thank you very much once again for having invited me over here. And as I said, it's always a pleasure coming to this branch, because beyond my talk, I am also a student over here and I learned something more. Thank you very much.
Thank you, Dr. Shivkumar Uttare sir, for an exemplary speech, I must say, and an eye-opener for many of us, and a role model for us you are in MMC also and in IMA also. So thank you very much. I would also request all the delegates who are listening to this to really follow what Dr. Shivkumar Uttare sir has just told you all. And also I would request them to come to IMA to collect their own set of diaries anytime in the office time from 10 a.m. to 6 p.m. and collect for their and their own friends also. And now I hand over the mic to Dr. Rajan Sancheti sir and Dr. Sunil Ingre.
Thank you, madam. Thank you, sir. May I request Dr. Sunil Ingre to give vote of thanks.
Good afternoon. Today I have learned a bit that there is nothing wrong that our financial year diary is becoming a financial diary to help the finances of IMA, and it has got lots of inputs that we can take to improve our financial situation in life. I thank Dr. Utture sir for coming all the way from Mumbai for this function in spite of this scary situation of COVID. I also thank Asmita Kai madam to grace this occasion in spite of her very busy schedule. I also thank Shashi Shekhar Hiremat sir for helping us by becoming a president of this diary project and helping us to come out with an excellent diary. I thank our printer Rahul Marulkar sir for giving us an excellent printing material in this diary. I also thank Meenakshi madam and Naurange sir for taking tremendous efforts to bring up this excellent diary. I thank you all who are physically present as well as present on the online platform to attend this ceremony. I request you all to join us for lunch in the boardroom. Thank you very much. Immediately. आता तुम्हाला आज आता मिळणार. 1 तारखेच्या आत मिळणार सर. 1 एप्रिलच्या आत फायनान्शियल इयर सुरू व्हायच्या आत डायरी सगळ्यांना मिळणार. Yes, it is available in IMA right from today. Thank you. Thank you very much. Please join for lunch. We will start the next session of webinar exactly at 2 o'clock. Post lunch. Thank you. joined okay.
कोणाला ओंकारला सांगायचं का? Piyush Omkar, can you hear me? Hello? Piyush? Piyush Omkar, can you hear me? Hello? फोन कर. Is Omkar there? हो हो. अरे आणि किती का झालं मध्येच का विनंती. Welcome, madam. Should we start up or 3 minutes to go? मॅडम सुरू करायचं आहे. Can't hear you. नको ना ऐकायला नाही. मॅडम अनम्यूट करा, ऐकायला येत नाहीये.
हो चालेल. येस सर, वी कॅन स्टार्ट. वी आर रेडी.
People should not miss. It's a very interesting session and people are excited also. Still 2 minutes to go. Should I start? I am just in dilemma. We start in time also. Wait for 2 minutes. People are taking lunch. So welcome all the faculties. So also welcome all the delegates. Can you hear me properly? Madam, I can hear you.
Yes. Oh, yes.
That's great. So I think I'll start first the introduction. That will be better. So I welcome Dr. Vinanti Golwelkar Patankar Madam. She is. एक मिनिट घे रे, सुन घे. No, हे वेबिनार मध्ये नंतर बोलतो. She would speak on multiple myeloma workup beyond serum protein electrophoresis. This is the topic after post-lunch session, and I hope you had a sumptuous lunch. And Madam will definitely keep you awake because the session is very interesting. So I'll introduce Dr. Vinanti Golwelkar Madam. She has highly meritorious career throughout her school and medical education. Madam chose to follow the footsteps of Sir and her elder sister, completed her MD pathology from the prestigious BJ Medical College. Armed with experience from the world-renowned Tata Memorial Hospital, Mumbai, she returned to her hometown to join Father's laboratory and has been a pillar and strength for Sir and her sister, Avanti. She has been a driving force behind developing new assays and introducing new test technology ever since. Her special interest is in the field of hemopathology and molecular diagnostics. This is, I would say, world, at most, I would say, international laboratory of AG. So I request Madam to take over her topic on multiple myeloma workup. Very interesting topic, and it is beyond serum protein electrophoresis. Please, Madam, take over and continue. Thank you.
Yes. Thank you, sir, for your kind introduction. And you have given me a very important task of keeping everyone awake in a post-lunch session on a Sunday afternoon. So coming to my topic, multiple myeloma workup. Multiple myeloma is a disorder which has a very heterogeneous clinical presentation. And that is why this makes it relevant for all of us. This patient may present to a physician with anemia, fatigue. He may present to an orthopedician with bone pain, to the radiologist with a lytic bony lesion, or to a pathology lab with, again, an anemia workup, or a nephrologist with renal failure. I would be covering this presentation under the following heads as seen in the slide. Coming to the historical aspects of laboratory diagnosis and treatment of plasma cell disorders. Somewhere in 1844, Benz Jones, for the first time, identified urinary immunoglobulin light chains by the heat method in a patient with symptoms and signs of multiple myeloma. Somewhere around 1900, Wright associated plasma cells in the bone marrow to multiple myeloma. But it was in 1950s when bone marrow aspiration and biopsy techniques developed well that the quantitation and morphological characterization of plasma cells began and began to be used for the diagnosis of multiple myeloma. Then came serum protein electrophoresis in 1960s, immunofixation in 1970s, cytogenetics in 1980s, with the specialized fluorescent in situ hybridization technique in cytogenetics in the 90s, pre-light chain assays and multicolor flow cytometry in 2000s. And today in 2020s, we are looking at the genomic and proteomic level characterization of myeloma cells using high density, high throughput array technology. What is interesting about diagnosis in multiple myeloma is these historical aspect, 2 slides cover the diagnostic workup of multiple myeloma even today. All these assays remain relevant, very much relevant even today. So each of them has got added to the armamentarium of testing. None of these have become irrelevant. And you will see when I go through the WHO classification and the criteria for diagnosis and monitoring of multiple myeloma. Similarly, even in treatment, there has been a lot of development. When initially there was no effective systemic therapy available, then came melphalan, then came steroids and autologous stem cell transplant. Today we are looking at thalidomide, bortezomib, carfilzomib, and now monoclonal antibodies like daratumumab. Coming to the epidemiology, the worldwide age standardized rate for incidence of multiple myeloma is 1.4 per lakh against in India of 0.7. So India is said to have a slightly lesser incidence and prevalence. It is slightly more prevalent in males with a male to female ratio of 1.3:1. The median age is 1 to 2 decades lower as compared to West at around 52 to 60 years. Multiple myeloma accounts for around 15% of all hematological malignancies. Coming to the clinical presentation, like I mentioned, the clinical course is heterogeneous. Early detection is challenging owing to the non-specific nature of the presenting symptoms. Bone pain is the most common symptom at presentation, with the lumbar spine being one of the most frequent sites. Common presenting signs and symptoms include bone pain and lytic lesions, including pathologic fractures, anemia, fatigue, infections, weight loss, hypercalcemia, and renal dysfunction. Coming to the classification, which first was given in WHO 2008, plasma cell neoplasms were divided into monoclonal gammopathy of undetermined significance, MGUS, then a plasma cell myeloma, asymptomatic and symptomatic, the variants of non-secretory myeloma and plasma cell leukemia. We had osteosclerotic myeloma associated with the Poem syndrome, plasmacytoma with a solitary plasmacytoma of bone or an extra osseous plasmacytoma, and immunoglobulin deposition diseases, that is primary amyloidosis, systemic light and heavy chain deposition diseases. So coming to the diagnostic criteria for MGUS, it was defined by M protein in serum less than 30 gram per liter or 3 gram per deciliter. With bone marrow clonal plasma cells, here clonal is important, less than 10% with a low level of plasma cell infiltration in a refined biopsy, no lytic bone lesions, and no myeloma-related organ or tissue impairment. No evidence of any other B-cell proliferative disorder. MGUS is considered to be a precursor lesion for multiple myeloma. Multiple myeloma or plasma cell myeloma again has an asymptomatic smoldering myeloma and a symptomatic phase. For the asymptomatic myeloma, the criteria were defined. Again, the M protein in serum at myeloma levels more than 30 gram per liter or 3 gram per deciliter. Now, this M protein quantification is typically done on serum protein electrophoresis. And 10% or more clonal plasma cells in bone marrow. So the level of M protein and plasma cell percentage is differentiating smoldering or asymptomatic myeloma from an MGUS. Here also, we do not have any related organ or tissue impairment or myeloma related symptoms. Coming to symptomatic plasma cell myeloma, what do we have? M protein, they are not giving any specific level, but demonstrating a presence of serum or urine M protein. Bone marrow clonal plasma cells, again, they are not defining a cutoff, but demonstration of presence of clonal plasma cells with a related organ or tissue impairment. As given by the mnemonic CRAB, hypercalcemia, renal insufficiency, anemia, and bone lesions. In 2016 classification, they added one more category. Basically, they changed IgM MGUS as a separate entity and differentiated it from IgG and IgM MGUS, as IgM MGUS is believed to be more closely related to lymphoplasmacytic lymphoma and other B-cell lymphomas than to myeloma. So the typing of an MGUS also became important, which is done by immunofixation electrophoresis. In 2015, the International Myeloma Working Group came up with the definition of active multiple myeloma. They were not satisfied that between smoldering myeloma and symptomatic myeloma, there was no level of M protein or plasma cells defined. And they believe this category of active myeloma was more at risk at progression towards symptomatic multiple myeloma and needed to be managed and treated as such. So this was defined by adding clonal bone marrow plasma cells more than or equal to 10% or biopsy proven bony or extramedullary plasmacytoma with any one or more of the CRAB features or myeloma defining events. So here, for the first time, they brought certain myeloma defining events or biomarkers of malignancy. The CRAB features, as I mentioned, one is hypercalcemia, where serum calcium is more than 1 milligram per deciliter above the upper limit of normal or more than 11 milligram per deciliter. Renal insufficiency as defined by creatinine clearance of less than 40 ml per minute or a serum creatinine of more than 2 milligram per deciliter. Hemoglobin anemia by hemoglobin value of more than 2% below the lower level of normal or an absolute hemoglobin value of less than 10%. And bone lesions is one or more osteolytic lesions on skeletal radiography, CT or PET-CT. Coming to the biomarkers of malignancy or myeloma defining events. Here they call the first one 60% or greater clonal plasma cells on bone marrow examination. So if there are no symptoms, but there are more than 60% clonal plasma cells, you are still going to call it an active multiple myeloma and treat it as such. The new criteria that was incorporated was that of serum-free light chain. So the light chain assays have come into picture with a serum involved to uninvolved free light chain ratio of 100 or greater, provided that the absolute level of the involved light chain is at least 100 milligram per liter. and more than one focal lesion of MRI that is at least 5 millimeters or greater in size. With time, updates have been coming, and this is an update by Dr. Rajkumar from Mayo Clinic on the diagnosis, risk stratification, and management. So if all this was not enough, they did a primary molecular cytogenetic classification of multiple myeloma, wherein they defined 4 subgroups, the ones associated with trisomic multiple myelomas, those associated with IGH translocations involving chromosome 14, combined IGH translocation and trisomic multiple myelomas, and those with the normal cytogenetics, that is, none of these were identified. They did a risk stratification based on this, in which the standard risk was seen in 75% of newly diagnosed patients. Standard risk was trisomies, translocation 1114 and 6, translocation 614. All the others were classified as high risk. And they defined double hit and triple hit with any 2 or 3 high risk factors. Coming to the myeloma staging systems, the first was given or modified from Dury and Salmon in 1975. And this was based on the myeloma cell burden, the tumor cell burden. So it was based on the M protein levels, presence or absence in number of bone lesions, and hemoglobin, serum calcium, and uninvolved immunoglobulin levels, that is non-M protein immunoglobulin levels. Accordingly, stage 1, 2, and 3 were defined and further subclassified based on serum creatinine of less than 2 or more than 2 milligram per deciliter. This has now been mostly replaced by the international staging system, which uses serum beta-2 microglobulin and serum albumin. Stage 1 is serum beta-2 microglobulin less than 3.5 milligram per liter with a serum albumin of more than 3.5 gram per deciliter, and the stage 3 is a serum beta-2 microglobulin more than 5.5 milligram per liter, irrespective of the serum albumin levels. Today, we are looking at the revised international staging system for myeloma, which is incorporated cytogenetics and serum LDH levels. Stage 1 with no high risk cytogenetics and a normal serum LDH level, and the stage 3 with a high risk cytogenetics and or elevated serum LDH levels. So after staging, we come to the response after treatment. So International Myeloma Working Group uniform response criteria defined complete response and other response categories. As you can see, these are based on the 4 investigations: protein electrophoresis, immunofixation, FLC ratio, and bone marrow clonal plasma cells. The bone marrow clonal plasma cells can be defined either on biopsy by immunohistochemistry or on flow cytometry by immunophenotyping. The stringent complete response is the one in which all of this is negative or normal. In complete response, though protein electrophoresis and immunofixation is negative, the FLC ratio may remain abnormal, or bone marrow clonal plasma cells may be still detectable by as minimal residual disease. Very good partial response is one in which protein electrophoresis is now not showing any abnormality. However, immunofixation is still positive, and FLC ratio and clonal plasma cells may be detectable. In a partial response, there is more than 50% reduction of the M protein level, or more than 50% reduction in the difference between involved and uninvolved free light chain, or more than 50% reduction in the bone marrow plasma cells. And stable disease is one not meeting any of these criteria. All these response categories require 2 consecutive assessments made at any time before the institution of any new therapy. All categories also require no known evidence of progressive or new bone lesions if radiographic studies were performed. However, radiographic studies are not required to satisfy these response requirements. So I believe all of you can relate to this gentleman. Do I really need to know all of this? I would say, don't worry, just chill. While this was important for me to set the stage, what I really wanted to highlight is what we had learned long back. Multiple myeloma remains a clinico-patho-radiological diagnosis, and it requires comprehensive workup for its diagnosis and monitoring. The rest can be further managed by a hematologist. What I just want to say is catch it early by doing the right workup at the right time. I'll go to my first case here. This was a 38-year-old gentleman who had come for a routine lab checkup to us. Like I said, in this case, he had come to a pathologist first and we sort of picked it up in a routine checkup. The hemogram showed a hemoglobin of 13.5 gram percent. WBC platelet counts were normal. However, on the peripheral smear, we saw significant rouleau formation. The WBC showed occasional plasmacytoid cell, plasmacytoid lymphocyte, sometimes even seen as reactive lymphocytes in viral infections. But on the liver function test, what we saw was the total serum protein was markedly increased, 13.8 gram percent with a globulin of 7.9 gram percent. The urine routine showed 3+ proteinuria. So we suggested a serum protein electrophoresis in this gentleman. And this is the protein electrophoresis pictures. If you can see, you can see a sharp peak in the gamma region of the protein electrophoresis, which we have called the M band. It is 5.74 gram per deciliter diagnosis. Benzstone's protein in the urine came positive in this patient. When we did the immunoglobulin quantification, obviously IgG was markedly increased. The normal reference range is up to 1600 milligram per deciliter. What we are seeing is 7160 with a reversal of free kappa to lambda ratio. The ratio is 0.01. The normal reference is 0.26 to 1.65 and the lambda is raised. We did the immunofixation and we got crisp bands in IgG and lambda regions. So this was a monoclonal gammopathy seen in IgG and lambda region, stage 2 as per Dury and Salmon staging. This gentleman came to us for a follow-up post-induction chemotherapy. And this was his protein electrophoresis. As you can see, what we have marked as M band, there is a small peak just after beta 2 region in the gamma region. And the immunofixation still shows the IgG lambda at the same location as in the earlier gel. However, the quantitation, IgG and free kappa lambda ratio have come to normal. So this gentleman was in partial response as what we saw in the categories. It was still detectable by both protein electrophoresis and immunofixation. He underwent an autologous stem cell transplant and came to us 15 days post that. Out of his own curiosity, he was not asked to do this test by his hematologist. And what we saw was a slight hump in gamma region where that earlier M band was. And again, faint bands in the immunofixation. The quantitation was all normal. What was this? We just asked him to follow up. So he came back 3 months after autologous stem cell transplant, and this was protein electrophoresis. 3 months after that, which was absolutely clear, immunofixation showed no crisp band. This was clear. and the patient was in stringent complete response. Going over the diagnosis and monitoring lab aspects, already, as I mentioned, history and physical examination will be important. In the routine testing, hemoglobin and peripheral blood smear examination. As shown here, the peripheral blood examination which show a significant rouleau formation or occasional plasmacytoid cells, as you can see to the image to the right. The routine tests, calcium, renal function test, serum creatinine, serum total protein and albumin are required, as I mentioned, part of the diagnostic criteria. And glucose again, because these patients are put on corticosteroid therapy and result in diabetes and its complications to worsen. Coming to the protein analysis. So we have serum and urine protein electrophoresis for the screening and quantification of serum and urine immunoglobulins, serum and urine immunofixation for the characterization of heavy and light chain isotypes and confirmation of complete response, serum and urine free light chain quantification. This is particularly important for the management with non-secretory and oligosecretory myeloma and confirmation of the stringent complete response in cases of light chain gammopathies. Serum immunoglobulin quantifications allow simultaneous quantification of involved and uninvolved immunoglobulins. So coming to the serum protein electrophoresis, to the left is an image of the classic gel electrophoresis. The bright band at the top is albumin. Then we have alpha-1 antitrypsin, alpha-2 globulins, beta-1 and beta-2 globulins, and finally a broad diffuse staining region of gamma globulins. Parallelly to the right is serum protein electrophoresis showing peaks generated on capillary electrophoresis corresponding to those bands as seen on gel electrophoresis. So we are doing protein electrophoresis by the capillary technique. This technique is based on the electrokinetic separation of proteins in a capillary filled with electrolyte buffer. The proteins are separated into 6 fractions that I just mentioned. Proteins are detected automatically by their absorption as they pass the detection window in the cathodic end of the capillary. No staining is required. The results are represented as an electrophoretic curve, the height of the peaks being proportional to the protein concentration. This is an SP of a patient with M band, wherein you see a sharp peak in the beta or gamma regions. This peak can be quantified. So I would say the main purpose of protein electrophoresis is for screening for the presence of M band or a monoclonal immunoglobulin. Secondly, the quantitation of M band. For this, you require accurate determination of the peak and accurate total serum protein measurement, and eventually monitoring of the M band on treatment. Coming to the next technique, that is immunofixation electrophoresis. This technique involves separation of proteins by electrophoresis on agarose gel simultaneously on 6 tracks. Proteins in the first track, which is the reference track, are fixed with a fixator, whereas in the remaining 5 tracks, immunofixation or immunoprecipitation of electrophoresis proteins is done by overlaying with individual antisera against gamma, alpha, IgM, heavy chains, and against free and bound kappa and lambda light chains. The precipitated proteins are then visualized by staining. In the absence of monoclonal component, a normal serum sample shows a light diffuse staining of polyclonal immunoglobulins in all tracks, serving as an internal control for the antisera, as you can see in this image to the right. The image that I just brought in is showing crisp, thick bands in IgG and kappa region with a corresponding band in the reference track. So this is monoclonal gammopathy in IgG and kappa region. Why do we need immunofixation? So we need this for typing of monoclonal immunoglobulin to distinguish different symptomatic gammopathies, evaluate the risk of malignant transformation for MGUS. As I mentioned, 2016 WHO now separates IgM and AIM-MGUS from IgG-MGUS. It separates IgM from IgA or IgG-MGUS. Also, IgG-MGUS is considered to have a better prognosis. IgM or IgA-MGUS have a higher risk of progression to smoldering multiple myeloma, and this is required for myeloma staging. It is required for monitoring response to treatment in patients with monoclonal gammopathy. Again, typing of original pattern of monoclonal protein at diagnosis, which enables comparisons at follow-ups. Second case is 61-year-old female presented with renal failure, creatinine of 4.39 mg%. The serum protein electrophoresis, if you can see a prominent peak in the beta-2 region. But so prominent, you cannot call it M-band. Confidently, the total beta globulin concentration, if you see the concentration in gram per deciliter, it is within normal limits. We did the immunofixation and it showed crisp, thick band in the lambda region corresponding to beta region on the reference track. So are we looking at a lambda light chain gammopathy? Most probably, but we should also consider IgD, Ig lambda monoclonal gammopathy. So the diagnosis of light chain, to make it complete, you have to do urine immunofixation electrophoresis. On quantitation, the free lambda value by free light chain assay came 11,300, and the beta-2 microglobulin was also markedly increased. So we did the urine 24-hour urine immunofixation in this case, and as you can see, there are crisp bands in lambda and free lambda regions on urine electrophoresis. So presence of a benzone in urine is characterized by detection of a monoclonal band with one of the anti-free and bound light chains, and the same monoclonal band detected with the corresponding free light chains, but no reaction with the GAM track. However, we can have a serum paraprotein eliminated urine without Benz-Jones protein. So the Benz-Jones protein is defined as the monoclonal light chain in urine. A paraprotein would be a bound G heavy and light chain protein in the urine. In that case, it is not to be called a Benz-Jones protein. So in that case, you would get a monoclonal band even in the GAM region corresponding with the anti-free and bound light chain band. Coming to the free light chain assays, these use principles of immunonephelometry or immunoturbidimetry, in which in immunonephelometry, the light scattered by the antigen-antibody complex is measured. These assays using polyclonal or monoclonal anti-FLC anti-sera are available on a range of routine chemistry analyzers and can detect FLC down to 1 milligram per liter. The anti-sera for free light chain assays are directed against epitopes that are exposed only when the light chains are free, that is unbound to the heavy chains in the solution. A predictor of response is the FLC ratio, that is a kappa to lambda ratio, which normally is between 0.26 to 1.65. In cases with renal impairment, it is suggested to be 0.37 to 3.1. Coming to the IgGAM quantitation, this is again done by immunonephelometry or immunoturbidimetry. It measures normal as well as monoclonal immunoglobulins. Its utility is largely in diagnosing concomitant hypogammaglobulinemia. It is also useful for monitoring monoclonal proteins that cannot be accurately quantified on SP, such as the IgAs, which typically migrate in the beta regions. And morphologic characterization of plasma cells. This can be seen in the image. Trephine biopsy, particularly indicated for patients with suspected myeloma and low marrow plasmacytosis. Immunohistochemistry by CD138. Immunophenotyping can be done by flow cytometry, which identifies clonal plasma cells by their aberrant phenotypes. This has prognostic implication and is useful in MRD monitoring. Typically, plasma cells, clonal plasma cells are CD19 negative, and they're often positive for CD56 as opposed to normal plasma cells, which are positive for CD19 and negative for CD56. However, CD56 is considered to be a good prognostic marker in a plasma cell neoplasm. Cytogenetics, typically evaluated by FISH on purified plasma cells, has become one of the most important prognostic factors of late, based on which risk groups, favorable and unfavorable, have been classified. Imaging studies again remain important. We have X-ray, which is still considered gold standard. However, MRI or low-dose whole-body CT is now recommended in the workup of smoldering multiple myeloma and solitary plasmacytoma. PET-CT if whole-body low-dose CT is not available. Coming to the ancillary tests, we can do urinary Bence-Jones protein, serum beta-2 microglobulin, LDH, cryoglobulins. Cryoglobulin's are detected in Waldenstrom's macroglobulinemia, that is the IgM monoclonal gammopathies. Cardiac biomarkers like NT-proBNP, BNP in suspected cases of cardiac AL amyloidosis. MAGE showing urinary Bence-Jones protein detection by the Bradshaw's method. When present, it gives a nice ring at the junction of the HCl and urine. The recommended minimum repeat testing frequency in case of MGUS is annual, 6 monthly for smoldering multiple myeloma, and 3 monthly while on treatment. Another case, I have 75 years male with complaints of pain in sternal region since 2 months. MRI revealed a single osteolytic lesion in the sternum. So look at the serum protein electrophoresis. It is absolutely normal. So we did immunofixation and we got these 2 faint bands, if you can see, one in the kappa region and one in the lambda region, corresponding to alpha 2 and beta regions on the reference tract. We did the quantification where free kappa came to be 2410. So this looked like a light chain gammopathy. Plasma cell myeloma was diagnosed with biclonal free light chain gammopathy. He came back after 1 year. In between, he had shown complete response to treatment. However, at 1 year, he had come with the complaints of repeated infections and a lot of fatigue. Serum protein electrophoresis was normal. But what could we say on protein electrophoresis? It was normal even at diagnosis. We did the immunofixation. And now if you see, there is a lambda band, which is at the same site as in the original gel. Kappa band, however, is not seen. So this time when we did the free kappa lambda, we monitored the ratio. The lambda has increased and there is a ratio reversal from diagnosis. This was relapse in a known case of biclonal free light chain gammopathy. Another such case, 69 years male, who was a known case of myeloma on follow-up. Like you can see in the protein electrophoresis, there is a small peak in the gamma region. Anyways, relapse was suspected, but we did an immunofixation, and what we found was there were 2 sets of bands. One band corresponding to IgM kappa, one IgM lambda. Again, in this case, the quantification was not giving us any idea. The free kappa lambda ratio was 3. It was a known case of biclonal gammopathy on treatment. But as such, on SPE, only one peak was seen. And a kappa lambda ratio would not have been useful for monitoring in this case because this was a biclonal gammopathy, having bands both in kappa and lambda region. So this was what I wanted to highlight with these two cases. The importance of the complete workup. Coming to the next case, this was a 68 years male who had come for a comprehensive myeloma panel workup with us. Serum of this patient was viscous gel-like consistency. Serum protein electrophoresis showed some abnormal pattern in the beta region. We did the immunofixation. You can see there is a crisp band in the reference tract, which corresponds to all the other tracts, though IgM and kappa seem to be more prominent. So we did this after incubating the sample at 37 degrees Celsius. Again, IgM kappa, though more prominent, there are point of application bands at all the GA and L regions as well. We reran the sample in dilution, 1 in 10. On quantitation, however, this was clear. IgM was markedly increased. So normal IgM levels are only up to 400 milligrams per deciliter. This was 7,000 with a free kappa of 312. Cryoglobulins were detected in the serum, and this was diagnosed to be a case of Waldenstrom's macroglobulinemia with a monoclonal gammopathy in IgM and kappa region. Just to show such bands are commonly seen in when there is presence of cryoglobulins, and differentiating in the first run on immunofixation may be difficult, and we need to rerun in such cases by treatment with BME or fluidin. The same patient post-induction chemotherapy, the serum protein electrophoresis, immunofixation still showed presence of M kappa, but now cryoglobulins had disappeared and the quantitation was all within normal limits. This was a very good partial response. These are tests done at AG Diagnostics in-house. I'm highlighting the comprehensive myeloma panel, which includes protein electrophoresis, immunofixation, IgG, IgM, IgA, and free light chain quantitation along with beta-2 microglobulin. This is our data over the last 3 years, serum protein electrophoresis. And orange marked areas are those with M bands, varying between 16 to 20% over the last 3 years. This is our data. Over the last 1 year, for serum and urine immunofixation, the kappa lambda light chains, and Benston's qualitative urine. So the take-home message is, if you suspect a plasma cell disorder, screen with a minimum of serum protein electrophoresis, but think beyond serum protein electrophoresis. I have taken help of these consensus guidelines from the Canada Research Network that have come up recently for my points. So I'm quoting them literally, though I completely agree with what they have said. No single test can confidently diagnose or monitor all patients with multiple myeloma. As single test, serum free light chain, protein electrophoresis and IFE can detect 74%, 79%, and 87% of monoclonal immunoglobulins, respectively. But the 3 tests combined can detect 98.6% of monoclonal immunoglobulins. If there is a high index of suspicion for multiple myeloma or a related plasma cell disease, a negative or inconclusive serum protein electrophoresis should be followed by an IFE. Although IFE can determine M protein isotype, it should not be used for its quantitation, and for quantitation, SPE should be used. Approximately 3% of patients have true non-secretory disease with no detectable M protein in serum or urine, and serum FLC levels and biopsy are required for the diagnosis if this is suspected. Serum FLC levels for those with light chain non-secretory myelomas, and biopsy for all the remaining. And screening by Benston's protein, though Multiple myeloma, even today, we associate with Bence-Jones protein, but the traditional methods by Heath and Bradshaw's technique are the only ones which we would not recommend any longer because of very low sensitivity and specificity. This is our hematology lab at AG Diagnostics and the team who is involved in the comprehensive myeloma panel workup. I would like to thank my entire team at AG Diagnostics for helping me put up this presentation. And I would like to thank you all for your patient listening.
Thank you, madam, for a very excellent and lucid presentation. A very complicated topic. Made in, I would say, very simple way. Diagnostic and monitoring of plasma cell gave very nice take-home message also. We have to go for immunofixation for myeloma staging and other things we learned a bit. Previously, we used to do urine Bence-Jones proteins. Now that you said complete no. So we have to go for electrophoresis. That is, I would say, the best of messages. Capda, lambda, and a lot of things we learned also. So thank you. And we will see that the things are made simpler also. And I hope the delegates enjoyed your academic feast. Thanks a lot.
Thank you, sir.
So now we'll move forward for the next topic by Dr. Manisha Patwardhan, madam. This is on allergy and food intolerance. Now in this scenario, COVID, very, I would say, interesting topic. So I'd first introduce Dr. Manisha Patwardhan, MD Path. She is an alumnus of St. GS Medical College KM Hospital. She has worked with Dr. Ajit Golwalkar since 1996 and has an experience of 20 years in diagnostic. She is sincere, hardworking, methodical, extremely systematic. She has driven excellence in technical operations through numerous process flow improvements while maintaining the high standards of ethics and principles. Quality management system, accreditation, and Six Sigma in analytic are her field of expertise. An orator par excellence, she has been at the forefront in teaching training activities of laboratory and the state and national conferences. She has presented a lot of, I would say, papers also. And her talk, I would say, are really appreciated by all the delegates. Please take over, madam, and enlighten us on the topic of allergy and food intolerance. Go ahead, madam, please. Thank you.
Thank you, Dr. Sancheti, and thank you, IMA, for giving us this opportunity to hold the CME, as is our early ritual, actually. This year, it is being held in very different circumstances when we are amidst a pandemic. We are amidst the COVID-19 pandemic, all of us. And here I am talking about food allergy and intolerance, and I'm calling it the new pandemic. The reason is that this has become so common. Slide is not moving. Just give me a minute. I will just. So I'm saying this because the incidence, the prevalence incidence of both food allergy, food intolerance, celiac disease, irritable bowel syndrome. So all these entities in the last 10 to 15 years, the understanding of the pathophysiology of all these has increased. And it is now a very common thing to listen to people in any gathering, in any party, you will listen to people talking about these things. So much so that you start wondering whether the food that is absolutely necessary for your living is actually a friend or foe. Now, many people use the word food hypersensitivity, food allergy, food intolerance, indigestion. All of these terms are used synonymously and they create a big confusion amongst all of us. Actually, food hypersensitivity can be considered as an umbrella term in covering any adverse reaction to food. But going further, we have to classify these to really understand this. So reactions to food can be classified as one, immune mediated, and secondly, non-immune mediated. So in the immune mediated, we have food allergy, which is mediated through the IgE antibodies, and food intolerance, which is mediated through IgG antibody. On the non-immune mediated side, we have the problems which are caused by enzyme deficiencies like lactose, by chemical effects, and by some drugs. So if you see how a food antigen is processed, you can see that there are two mechanisms or two pathways. One will lead to the formation of IgG antibodies and lead to food intolerance. And the lower pathway shows us how the IgE antibodies are made, and through mast cells, B cells, and eosinophils, they lead to food allergy. So we will first discuss food allergy in detail. Allergy and hypersensitivity can affect any age and manifest with problems in a range of organ systems. They do impact the quality of life of patients and families. The understanding of the pathophysiology has increased over the last 20 years. Although once rare, there is presently an epidemic, like I said, of these disorders. In the Western world, in fact, right from kindergarten children, they can talk about peanut allergy, and they are actually carrying adrenaline pens, or the EpiPens as they are called, to school. So allergy is an hypersensitivity reaction initiated by proven or strongly suspected immunological mechanisms. The triggers are substances that the subject has been previously exposed to and sensitized. It can be IgE mediated or non-IgE mediated, as I already said. Now, what is the difference between allergy and atopy? So allergy is when the IgE is produced, and through the mast cells, eosinophils, basophils, like I said, there is a reaction. Whereas atopy is a tendency which makes you produce the IgE antibodies in response to ordinary exposures to allergens, usually proteins, but they do not immediately lead to symptoms. So you are sensitized, you're sitting with that IgE within you, but you have not exactly developed a disease. Atopic disease is development of typical symptoms of, say, asthma, rhinoconjunctivitis, or eczema in atopic patients. Isolated or in combination, and in general, these have a different course throughout life. That's it, has different age groups, in different age groups, or in the same person also, at different stages of his or her life, the manifestations of both atopy and allergy could be different. So there is a difference between sensitization and symptoms. Any individual who is exposed to allergen will get sensitized, but not necessarily get symptoms or disease. That is the third stage. So we will have different combinations. That is, an individual is sensitized, but there are no symptoms. Clinically, allergy may develop in the future. And so action is follow-up of these kind of patients. There could be symptoms without sensitization. However, that will exclude allergy to the specific allergen. And you have to investigate for other causes which may be leading to these kind of symptoms. The third category is symptoms and sensitization. So that confirms IgE-mediated allergy, and the action is treatment, avoidance of the allergen, and follow-up. So why test? Why test for allergy in the first place? Because the symptoms which are seen in allergic patients, are common to many illnesses. Allergic sensitization to domestic allergens, aeroallergens, and exposure to trigger factors appears to be an important risk factor in the association between allergic rhinitis and asthma. Identifying the triggers early is the key to improved patient management and overall quality of life. Panels which we offer for allergy testing are required to map polysensitization as allergens add up to cause symptoms. I will show you a case which shows this polysensitization later. Reducing allergen exposure can also help asthma control. So if there's allergy to dust mite, you can use measures like vacuuming or varnishing these surfaces. If a person is allergic to cat dander or dog dander, then there can be pet-free zones in public areas also where this person can easily visit. Then allergy to molds can be avoided by removing moisture. If there's allergy to pollens, then closed windows, changing clothes, and showering after coming indoors can be certain steps. So if we do the test, and if the person and the clinician is aware that a particular person is allergic to a particular allergen, then many steps can be taken to alleviate the symptoms and improve the quality of life. So what are the common allergens? In children, maximum numbers show allergy to milk, egg, nuts, fish, dust mite, cat, dog, and pollens. In adults, it's usually nuts, shellfish, milk, wheat, citrus, tomato, dust mite, cockroach, pollens, and mold. Now remember one important thing, that the same allergen can actually give different manifestations of the allergy. That is, milk and egg can cause either anaphylaxis or an atopic dermatitis. Peanuts can again cause anaphylaxis or a more chronic dermatitis or an acute urticaria or angioedema. So the same allergen can give rise to different symptoms in the same patient or at different times also in different individuals. So when we have to evaluate a person for food allergy, how do we go about it? We here at AG Diagnostics have made it a point that we take a complete history of the patient, because many a times pinpointing the allergen becomes easy if we have a good history and good symptoms, good symptom diary. So we ask the patient, many times patient actually keeps a diary. He or she can tell us what foods do not agree with that person, or if it's seasonal, because pollen allergy is often seasonal. So they tell us that it occurs usually in spring season. And when they travel to the Western world where the pollen problem is higher. So they give us all this history, and which is very important. Then we can do the food specific IgE. The other modality for diagnosis, which was used through years, is the skin prick test, which I think most of you will be familiar. But what it involves is that the purified allergen is injected, and a person might actually have to take about 100, 150 of these pricks, and which can be definitely very inconvenient. So instead, if we do the food specific IgA, it is just one draw of blood. The other way of diagnosing is an oral food challenge, which is of course very dangerous because it can actually lead to anaphylaxis. So it should be done in a proper setup. Then there are people who avoid a particular food, and then the avoidance, if it relieves their symptoms, that also leads to a diagnosis. So this is the history or symptom diary that we use, where we ask them to give the chief complaints. Then we have enumerated most of the common complaints of allergy. So it's eczema, itchy skin, rashes, hives, nasal congestion, sneezing, runny nose, stomach bloating, abdominal cramping, diarrhea. So if you can see, the first part is related to the skin. So usually there are symptoms of dermatitis. The second group of symptoms points towards a respiratory tract symptoms, and the third are predominantly GI symptoms. Of course, there can be a patient who gives us history of all these complaints together, or some at one time and some at another time with the exposure to the same allergen. Then smoking, whether the symptoms are indoors, outdoors, or both, any reaction around cats, dogs. So we try to elicit all this history to help the patient to select the correct allergen or the correct panel. Now, like I already said, IgE can be tested both in vivo and in vitro. So in vivo would be the allergy skin testing, which detects the wheal and flare response due to histamine release after allergen binds specific IgE affixed to cutaneous mast cells. And in vitro is when we will draw a sample of blood and do the measurement of allergen-specific IgE. So starting with our first case, I will present a few cases which will highlight most of the common allergens and how they present. So the first case is a 6-month-old child who, as soon as, so 6 months is the age when mostly foods are introduced. Even milk, the cow's milk is introduced after say 4 to 6 months. So this child immediately showed symptoms of wheezing, and the clinician suspected both a milk and a wheat allergy. And yes, you can see that the milk allergen specific IgE as well as the wheat allergen specific IgE, both are raised, both are positive. Following this is a case which is a 6-year-old female. So this child was born in Australia, and the first report was done in Australia, where the child was diagnosed as milk and gluten allergy. And they showed me the report. It was positive. The child was put on alternate diet right from that day of diagnosis. So they have avoided milk and dairy products, as well as they have avoided wheat. And then if you see this report, which they wanted a follow-up report to be done here. So if you can see, the milk is also now the reactivity is minimal, and the wheat reactivity is not seen. So if there is an avoidance of the allergen, the IgE reactivity or the antibody levels have gone down here. Milk allergy is a very common phenomenon. In fact, it is as old that it has been described by Hippocrates. Animal milk is consumed since 9,000 years ago. So cow's milk allergy is the commonest allergy, and also it is usually the first food which is introduced to any infant, to a baby. It's a complex disorder because the milk proteins, in the milk proteins, there are multiple allergenic epitopes. So it's not just one particular thing to which a person can get allergic. It is a very complex science, in fact. Milk, wheat, all of these have component proteins, and anybody can be allergic to either one or multiple of these allergenic epitopes. So different allergic individuals react differently to the different milk protein components. Another very common food which causes allergy is shellfish. So here you can see a 65-year-old male who is very highly allergic to crab, shrimp, and lobster. This gentleman came to me with a very sad face because he's a fish lover, and suddenly at the age of about 50, he developed an allergy. But at that time, he didn't know that there was a test. So he had not tested. He had obviously stopped eating shellfish. And he saw our we have put up some information about these tests in our OPD, and he saw that, and he came in and asked me that whether we can test. And he was hoping that if he did not have the allergy, or if it has lessened, then he can resume eating his very loved fish. But unfortunately, no, he has very strong allergy to crab, shrimp, and lobster. He also gave me a history later on that his son, who travels a lot, and especially to the Southeast Asian countries, also has shellfish allergy. And so he's very worried every time that his son travels. I got a phone call for this particular 28-year-old male from a clinician saying that one of my patients has suddenly developed this puffiness around the eyes and is also choking. And he had just had a very sumptuous meal of prawns. and the clinician suspected prawns allergy. So we took a sample immediately, and here you can see that the patient is again positive to crab, shrimp, and lobster. So shellfish, like I said, is one of the commonest causes of food allergy. There's a classification which tells us what comes under crustacea and mollusks, but there is a huge cross-reactivity between most of these food groups. So what we have generally seen is if allergic to one of these, then the patients are mostly allergic to the entire group of clams, oysters, scallops, mussels, squid. And nowadays, a lot of people travel and they tend to eat this. The worst is I have heard of patients who have had this meal on flights and then they are in real trouble. So if the person knows that he has a particular allergy, then it can definitely help him to guide his life choices. This particular patient is a female patient who complained of urticaria off and on, oral tingling and itching after eating certain foods. Now, she was very categorical that her itching occurs only around her mouth area and in her throat. So actually, I was myself not very aware why she is giving this specific symptom. But after testing, what we see is that she was allergic to a multiple of allergens. She was allergic to milk, wheat, shrimp, tomato, lemon, lentils, dog dander, Bermuda grass, etc. On reading up, because this was very early in our allergy journey, she was also allergic to mesquite, ragweed, and saltwort. All these are names of common trees, plants, grasses that we find around us, and they release pollen. And the people can be allergic to it. But what this lady particularly had is an oral allergy syndrome. So where the oral and pharyngeal mucosa is affected, it is usually after eating raw vegetables and fruits. The symptoms are short-lived, and there's a cross-reactivity between many allergens, or rather reaction to many allergens. Now, why does this happen? This happens because many epitopes or proteins are shared across many plant and animal species. So a person, or rather a birch plant and a carrot or a celery will have the same proteins. Why this is important? Because after reading the report, some of the patients say that I never eat zucchini, or I never eat a particular, say, celery, something like that. But they do have allergy they do test positive for allergy to these, because each of these food products has a shared antigen or a shared protein with some other, either food product or plant product. Now, this particular gentleman, 56-year-old, stays very close to the lab, and he had again seen the information which was put up in the lab. And he did the test. And if you can see, he has a very low level of IgE to multiple allergens. It starts from wheat, rice, peanuts, soybean, shrimp, then lemon, then chickpeas, dust mite, cockroach, Bermuda grass, aspergillus, so many of them. But he did not really have symptoms. He had mild symptoms very rarely. So he himself said that somehow he felt he should do an allergy test, but he has never really had a very severe episode of allergy as such. So this is called polysensitization. A person may be sensitized to more than one allergen, may not display symptoms until their combined exposure to severe individual allergens does not cross the symptom threshold. So this is very dangerous again, if you see. That is, a person will have a load of IgE antibody. It is like sitting on a time bomb. One sudden day, it can cross the symptom threshold and they can get a very severe and almost anaphylaxis-like reaction. So this you will see you will hear it very commonly that I have been eating this food. I have been eating prawns for almost 30 years of my life, 40 years of my life. And one fine day, how did I get allergy? So it's actually not one fine day, but it is a manifestation of the atopic tendency that I was talking about. they have an atopic tendency, they have an allergy towards this particular food product, and it is developing over a long period of time and culminates in a symptomatic episode one fine day. So the appearance of symptoms will depend upon the degree of exposure. So more sensitizations, higher likelihood of symptoms, individual reactivity, and the level of IgE antibodies. Now, though this session is more about food allergy and food intolerance, I still thought I will cover 3 or 4 common allergens that we have seen in the lab to complete the allergy topic. So this is a 22-year-old female. She had left for the US when she was 20 years old, and her house was closed for 2 years. She returned back, and when after she opened the house, cleaned it up and started staying, she got very severe runny nose, sneezing, etc. So if you can see, her IgE is very raised. Our normal for adults is up to 100 international units per ml, and hers was at level of 1000. This is the total serum IgE. There's also a Fadia-Top screening IgE value, which you can see above the IgE, which is 93.2, again, very, very high. So a Fadia-Top screening IgE is a cocktail of antigens. The most common allergens are grouped together, and this can be used as a screening test for allergy. So when she gave me these symptoms, I first asked her to do the total serum IgE and Fadia-Top screening IgE, which we found were raised, and then we went ahead with the entire rhinitis panel for her, rhinitis asthma panel. And if you see, she was severely allergic to the dust mite, Dermatophagoides farinae, and also to Aspergillus fumigatus, which is a mold. So dust mites are very common. They are found in every home. They are not really a sign of poor hygiene. It is just that they are ubiquitous. They prefer warm, damp, dark places, and they thrive at a humidity of 70 to 80% and temperatures about 25 degrees. Dust mite allergy can manifest as asthma, conjunctivitis, rhinitis, and atopic dermatitis. Another common allergen is inhalants. So tree pollens, grass pollens, weed pollens, cat dander, dog dander, Aspergillus fumigatus, and Alternaria alternate. All these are again very commonly found around us, and many of us could be allergic to these. This is a 35-year-old female with cough, nasal polyps, and recurrent sinusitis. And if you can see, she is allergic to the grass group. The lower circle shows you that Bermuda grass, meadow grass, Johnson grass. So she was allergic to grass pollens and had these symptoms so much so that she had developed nasal polyps. Patients can also present with skin manifestations. So this is a 46-year-old male. His wife sent me these photographs when he got the allergic reaction. And we tested, we tested him for a Fadia-Top screening IgE first. Now, why this? Because skin conditions are not easy to diagnose, classify. It is not very easy to say that this particular skin manifestation is because of allergy, because you have to differentiate it from so many other skin conditions, contact dermatitis, photosensitivity, eczema due to other causes. So it's very difficult. So here you can use a two-step approach that first we did the Fadia-Top screening IgE. And because that was raised, yes, that means there could be an allergic etiology. And we went ahead with a generalized comprehensive panel, where again, as you can see, the person is allergic to dust mite and cockroaches. So dust mite can give rise to skin symptoms also. Earlier I said that it mostly gives rise to rhinitis or asthma-like symptoms, but it can also give rise to skin symptoms. So history and symptoms can help us decide the choice of panels of choice of allergens, but there is a considerable overlap. Total IgE and Fadia-Top screening IgE may be indicators, and a two-step approach can be adopted. We offer both individual allergens and panels. And if the person is on any medications such as anti-allergics already, it will not affect the testing. Our data from June 18 to Feb 21 shows that of the total 238 adults samples which we tested, about 50. So it's like 20-25% were positive. And in
Bye-bye. Bye-bye.
Could I please request everybody to be on mute? In children, about 12 were positive in the 50 that we tested. So amongst the individual allergens, what I already showed you earlier, that milk, wheat, peanuts, these are very common allergens. There is pigeon also. So pigeon IgG also we do. And what we have seen is the maximum positivity for the dust mite, for cockroaches, for milk, wheat, peanut, soybean, rice, tomato, chickpea, lentils, gluten. So these are the common allergens which we have found in our own data. As was mentioned by most of our colleagues, we are very particular about our quality control, and even the allergy test is subjected to very intense, severe internal quality control as well as an external quality assurance scheme. With this, I will now move on to food intolerance. Abdominal bloating, excess gas, nausea, vomiting, abdominal pain or cramping, and non-bloody diarrhea. Now, this person that I have shown could be any one of us, absolutely any one of us, after overeating either at Pizza Hut or in a wedding. Or there are so many people, you hear it all around you that this kind of food does not agree with me. Or that I had a very heavy meal yesterday, a late party yesterday night, and today I'm having excessive gas, nausea, vomiting, bloating, etc. Now, we actually, all of us in our hearts know that the simple ways to avoid these food-related symptoms are that you eat light to digest foods, seasonal foods are the best, certain kinds of foods are not to be mixed. I mean, we have heard our grandmothers telling us that we should not have curds and fish together, or we should not drink too much of water after eating peanuts, so on and so forth. We have also had her wisdom in telling us that we should eat slowly and calmly. We should not overeat, of course, chew 52 times, drink buttermilk at the end of the meal. Now, I was myself wondering whether food intolerance is a fact or a myth. It is something which traditional wisdom has taught us, or whether modern medicine actually recognizes this entity and understands it. So this is Mayo Clinic, which talks about food allergy and food intolerance as two different entities. And also Harvard, which talks about the leaky gut. So what is a leaky gut and what does it mean? A healthy gut has a very good mucus layer covering the mucosa, and the junctions between the epithelial intestinal cells are very tight. Now, because of this, what should remain in the lumen remains in the lumen. On the other hand, if the gut lining is damaged and there's a leaky intestinal barrier, there's increased intestinal permeability. So what happens is the undigested food particles, the infective organisms, toxins, all these will pass through the intestinal lining into the bloodstream. So the leaky gut leads to food intolerances, it can lead to immune abnormalities, and it can also lead to autoimmune conditions. In fact, in the next case presentation, I'm going to present autoimmune hepatitis. And what I recently read is that autoimmune hepatitis is directly related to the gut microbiome as it is called. Gut microbiome has again become a topic of discussion lately, and we will have something, some little discussion on it a little later. So the causes for leaky gut are actually what we know already: stress, overeating, especially fried foods, fatty foods, infective organisms, antibiotics, which destroy the normal gut flora, toxins of different kinds. So all this can lead to a leaky gut. We've already discussed the IgE-mediated allergy, and now we are discussing the IgG-mediated food intolerance. Like I said, we need to talk to each patient before we go in for testing, because these tests are they are quite expensive, and it does not make sense to do it without understanding the patient properly. So allergy the incidence is actually low and very predictable short-term symptoms, and the patient usually points to the food because he says, I ate this and immediately had these symptoms. Whereas the IgG-mediated food intolerance, the incidence is relatively high, the symptoms are chronic variable, offending food is frequently not suspected, the trigger is immune complexes. So these undigested food particles which have entered the bloodstream cause an IgG response, and the IgG and food complex can cause an inflammatory response, both local as well as systemic. So eating foods you are sensitive to can throw off the gut bacteria and enzymes, causing a vicious cycle of poor digestion, infection, and inflammation. It can cause a variety of symptoms, can affect almost all the systems in the body. Of course, the predominant symptoms are the gastrointestinal symptoms like abdominal pain, constipation, gas, cramps, bloating, diarrhea, heartburn, and vomiting. But the other organs and systems can also be affected. So testing for food intolerance is by the microarray test. So as you can see, there's a slide which has a microchip embedded on the slide. And this particular microchip has a variety of food antigens plated on it. So the after the processing, this particular microchip is scanned in a dedicated scanner, and we get a report. So you can see this particular report, the red, it's a little, I think it's difficult to read. I have a next slide coming up. So what I want to show is a red, yellow, green. So the report very clearly tells us that the foods which are in the red category, you have to stop eating. The ones which are in the yellow category, yes, you can eat in moderation. And the green category, you are absolutely good to go. So this is my own report. And I'm showing intolerance to a variety of nuts, then yeast, egg white, pistachios, cola nut. That is very common flavoring used in most of the cokes or any aerated drinks, in fact. Peas, barley, maize, corn, etc. And borderline intolerant to celery and peanut. Now, this report does not really mean anything because as you can see, I have done the report on the 20th of Jan, but I have not exactly stopped eating any of these because I'm a foodie. I love all these foods. So it basically will give the given guidance to the patient that, okay, these foods are seemingly not agreeing with you. And if the symptoms are too much and you wish to have, if you feel that it necessitates stopping these foods, you can do so or eat them in moderation. Try to avoid for a few days and see if your symptoms are better. So it gives a good guidance to the patient. Depending upon the severity of the symptoms that the patient has, she can decide how to go about it. So we also have a detailed report or a patient guidebook as to which foods are to be avoided and which other foods can be eaten in place of the food that you are intolerant to. In whatever number of samples that we have processed till now at AG, we found that the top 10 common foods to which people are showing intolerance are barley, bean, cashew nut, cola nut, corn, egg white, milk, pea, pistachio, and yeast. So I think most of us will identify with this because pizza is one thing. We always say that because it has both yeast and loads of cheese, so it does cause bloating and abdominal distension, gas, etc. in many people. Again, the grandmother's wisdom comes in because beans, peas, nuts are always known as hard to digest. So this is exactly what we saw during testing. So if a person has a food sensitivity, then it is good if we identify the foods producing the elevated IgG response. We can remove or rotate these foods from diet, give time for the leaky gut to repair itself, then repopulate the gut with beneficial gut flora. So probiotics are given. So like I again said, that is exactly why buttermilk was so recommended at the end of a meal always. Strengthen the immune system and then slowly reintroduce the foods. Most of the patients say that their food sensitivity does improve after this cycle, though of course they can have repeated attacks. So analyze the history, get the test done for the foods that do not suit you, follow the elimination diet, use the diet guide or the patient report guide and see the benefit. Food intolerance or food sensitivities have also been implicated in most of the GI related conditions like IBS, of course, but also IBD. Even in inflammatory bowel disease, an understanding of the associated food intolerances and then correction of those will lead to alleviation of symptoms along with the other treatment modules. This is our team, our technical staff who does the test. On top, you can see the machine which does the allergy testing, and the bottom shows the food intolerance system. Thank you very much. I hope that this has been worth the afternoon siesta that you all have missed. And over to Dr. Sancheti, please.
Thank you, Madam, for a very excellent presentation again and explaining us about food allergy versus food intolerance in a very simple way. And you have emphasized for the test to be done, IG, in vivo and vitro too. Now that ball is in our court whether to test a lot of things: milk, gluten, eggs. Some are, some have a delicacy of fish, lobsters, shrimps, and whatnot. And again, there's a problem about bloating, nausea, vomiting, and other things. So I feel you have a lot of things to offer to our all delegates of testing of IG, credit of screening, and a lot of things. So I thank you to elaborate on the topic of food allergy. And मला असं मराठीत म्हणायचं का खाण्यासाठी जगायचं का जगण्यासाठी खायचं आणि टेस्ट करूनच खायचं हे महत्वाचं. म्हणजे ॲलर्जी होणार नाही, अस्थमा होणार नाही किंवा इतरही काही कॉम्प्लिकेशन्स होणार नाही. जसं तुम्ही दाखवलं गट जे आहे लिकेज होतं आणि लॉट ऑफ थिंग्स हॅपन. सो I request all of the delegates also to have their testing done of their patients. I would say, don't become patient. So I think I should move to next. There are questions, but we'll take it the last. I think, ma'am, will do.
Yes. Fine.
Thank you. So we'll go for next topic. That is, I think, diabetes. Diabetes role of laboratory by Dr. Venkatesh Keralapurkar, sir. So I would like to introduce sir. He is a postgraduate in pathology from KM Hospital, Pune. He has experience of more than 20 years in pathology and diagnostic, particularly with respect to handling the day-to-day work of a large busy laboratory. Is considered as a pillar of biochemistry and immunoassay departments, and is also expert in patient consultation and handling patient queries. That's important. He has handled quality and accreditation in previous association, which has added to the quality of his repertoire. So over to Dr. Venkatesh to enlighten us on topic of diabetes as a laboratory test. Please, sir.
The today's topic is diabetes, the role of laboratory. Diabetes is one of the oldest disease known to the mankind. Just hold on. Now, diabetes is known to the mankind as early as 1500 BC, when actually Egyptians were first to document the case of diabetes. It was in 1674, the sweetness of urine was discovered by Thomas Willis. Later on in 1775, it was the sweet taste of the urine and blood which was discovered by Matthew Dobson. It was in 1841 and 48 that Tromer and Failing actually developed a qualitative test to measure the glucose in urine, which was based upon the reducing property of glucose. How the method evolved. In 1908, the Stanley Biddick was the first person to develop a reagent which was basically based upon the reducing property of glucose. In 1999 and there onwards, Folin and Wu modified the method so many times, which was the common method used in the past, known as modified Folin-Wu. In 1959, orthotolidine was the first person to develop another method for the glucose estimation. In spite of these two methods, there was some need for some different enzymatic methods. Why so? Because the previous two methods were in need of protein precipitation, centrifugation, and boiling, which were time consuming. Secondly, they were not linear, imprecise, and inaccurate. So in general, how the glucose metabolism is there in our body? The intake is mainly in form of starch, glycogen, disaccharides, and monosaccharides. The storage is in the form of glycogen, and distribution and utilization is mainly in the form of free glucose. In the fed state, it is the insulin which dominates. What does that mean? It takes care of increasing glucose oxidation, increase glycogen synthesis, increase fat synthesis, increase protein synthesis. And in the fasting state, the glucagon dominates, the reversal of the insulin. Now, whenever there is increase in the plasma glucose, beta cells of islets of Langerhans, they will release the insulin. Now, this insulin will pass through the liver, where it will increase the glycolysis, glycogenesis, and lipogenesis, and in turn, it will reduce the glucose. The reverse would be when the glucose is low in the peripheral circulation, alpha cells, they will secrete the glucagon, and that will stimulate glycogenolysis, gluconeogenesis, and which will in turn increase the glucose. This is the picture of how diabetes mellitus actually develops in an individual. In type 1 diabetes, with the genetic and environmental factors, there is in future slowly activation of immune cells, which will lead to formation of autoantibodies. Now, these autoantibodies will destroy slowly the beta cells of islet cells of Langerhans, which are actually this secretors for insulin. Now, as the destruction goes on, the insulin and C-peptide will reduce in the peripheral circulation. And in this way, one will develop the type 1 diabetes. In type 2 diabetes, there is genetic predisposition and the constitutional factors, but there is insulin resistance. Due to insulin resistance, in spite of the glucose, the insulin and C-peptide will start to rise. There is beta cell dysregulation in future, which lead to impaired glucose tolerance, and again, the beta cell insufficiency. So this is just the same. So type 1 diabetes is more so ever related to autoimmune process, whereas type 2 diabetes is related to insulin resistance and in future followed by beta cell overwork and destruction. This is the most commonly used method for glucose estimation. This is hexokinase, one of the most commonly used methods in most of the laboratories. This is another method which is commonly used for glucose estimation. This is called as GODPure. Now, why pre-analytical conditions are important when it comes to glucose estimation? It is because it has to diagnose and classify the patient correctly. Secondly, we have to obtain the reliable estimates for the prevalence of diabetes in the epidemiological studies to ensure the biological variation is not overestimated and to prevent pseudo-hypothermia, particularly in neonates, to ensure that the laboratory results are used to assess the glucose meters and to other point of care devices. This is the reason why pre-analytical conditions are important. This is just a reference for pre-analytical aspect. There are so many, just shown one. Which are the pre-analytical factors which actually affect the glucose estimation, starting with the sample type, whether it is a serum or plasma, time of blood sampling during the fasting state and the post-meal state, which type of test tube is being used for glucose estimation, what are the transport conditions, the time required for transportation and the temperature and the centrifugation, the type of meal the patient had, the therapy and the medication the patient is going on and whether he has taken the therapy or not, and adherence to certain instructions. Now, if we compare really the capillary and venous blood glucose, the capillary blood glucose will be more than the venous because the rate of glucose consumption in the tissues. Now, hours of fasting, the patient will say, I am fasting since 8 hours, 10 hours, and 12 hours. Again, the glucose may differ. Hours after the post meal, some patients will give the sample after 1 hour, 1 or 30 minutes, or 1 hour, 30 minutes to 2 hours, or 2 hours, or more than 2 hours. So, again, the glucose value will differ. The type of test tube which is being used for glucose estimation, SST tube or tube with the glycolysis inhibitor. These are the most two common tubes which are being used. The most effective way to inhibit the glycolysis is placing the tube on the eyes after collection and separation of the serum or plasma from the cells within 30 minutes. Now, though this is the most effective way, but practically we know this is the most difficult way to follow. So the glycolysis tubes are the most commonly used tubes for glucose estimation. So which are the glycolysis inhibitors which are practically used in the practice? In the past, it was iodoacetate, D-mannose, citrate buffer. But most commonly used in nowadays is sodium fluoride, because sodium fluoride, it has been used for, it inhibits the enolase enzyme by inhibiting glycolysis. Now the process of inhibition starts within 2 to 3 hours of collection, and glucose will remain stable for up to 72 hours after the collection. And this is the tube which has been used for setting the guidelines by the ADA. So these are the ADA guidelines which are being followed worldwide. In the fasting state, the normal is considered below 100 milligram. The impaired glucose tolerance in the fasting state is between 100 to 125 milligram. And we call it diabetes mellitus in the fasting state if the sugar is more than 126. Similarly, for the postprandial, it is 140, 141 to 199 and more than 200. And for a random plasma sample, it is more than 200 when we call it as a diabetes mellitus. This is just pictorial representation of the glucose tolerance test that is being followed. Now, this is the powder which is advised. Now, see, it is dextrose monohydrase. The ADA guidelines are based upon anhydrous glucose, but it is not possible to give anhydrous glucose because it is not palatable. So, the dextrose monohydrate. So, the content in this, even if it is shown as 82, actual glucose is only 75. Now, the two different GTTs that are done in the pregnant woman are, one is glucose challenge test where fasting is not required. 50 grams of glucose is given and sample is collected after an hour. If the glucose value after an hour is less than 140, it is taken as normal. The second one is IPSI. Here, 75 grams of glucose is given and the sample is collected after the 2 hours. Now, if the 2-hour sugar level is more than 200, it is taken as diabetes. Between 140 to 200, it is gestational diabetes mellitus. And if it is between 120 to 140, it is taken as decreased gestational glucose tolerance. Now, this is the commonly GTT which is being followed, where we give 75 grams of glucose and the sample is taken in the fasting state at 1 hour and 2 hours. The BRI for the same are in the fasting state, it is 92. At 1 hour, it is 180. At 2 hours, it is 153. Similarly, for 100 grams, it is 95, 180, 155, and 140. Now, this is the non-gestational glucose tolerance test for which one has to be given 75 grams of glucose and the sample is taken after the 2 hours. Now, if the glucose value after 2 hours is less than 140, it is normal. Between 140 to 199, it is impaired glucose tolerance, and above 200 is taken as diabetes mellitus. Now, this is a pediatric GTT. What is the recommended is 1.75 gram per kg. Maximum is 75 grams of glucose can be given in the pediatric sample, and sample have to be collected in the fasting state 60 minutes, 90 minutes, and 120 minutes. The biological reference interval for the same is in the fasting state, it should cross 126, and the rest of the samples, it should cross 200 to be called as a diabetic. Whether the fasting plasma glucose can be more than post-meal plasma glucose, yes or no, is a common thought process. Yes, it can be. Why so? Because blood glucose level depends upon so many factors. Type and quantity of food which is taken, physical activity, body's metabolic response, anxiety, pre-analytical factors, hypoglycemic drugs, liver, pancreas, hormones, and like insulin, glucagon, epinephrine, and very rarely the delay in sample processing if the sample is being sent from, say, outside the town and it has to be processed on the day. So it may take a longer time for processing. Now, what are the causes that the fasting plasma glucose is more than post-meal? High glucagon to insulin ratio, which is commonly seen in diabetics. Insulin resistance with normal or high insulin level. High carbohydrate meal at night. Failure to take the anti-diabetic medication or inadequate dose. Rebound hyperglycemia, also known as Dawn phenomenon and Somogy effect. Anti-diabetic medication and strenuous exercise before post-meal sample. And postprandial reactive hypoglycemia due to high insulin sensitivity. Very rare factors include chewing and eating slow can actually reduce reactive glucose surge, which is seen in the post-meal. Gastroparesis may be seen in the diabetic patient, which may lead to fasting more than post-meal. Deliberately eating less or eat less non-carbohydrate diet is a common thing which is done by the patient, which may lead to fasting more than post-meal. And not the least, but seen, which is a patient who is likely to develop the type 2 diabetes may have in the initial part fasting more than post-meal. Now, this is the internal quality control that is being followed at our end with the equipment that is Alinity from the Abbott Diagnostics, where we process 2 levels of controls twice a day. This is the another equipment of the same from Siemens. This is the external quality assessment scheme, actually showing the 2 different areas of assessment. Now, this is the future glucose estimation that we are evident. Many of the watches that we see, it may be from Apple or so many companies, they are now able to show actually what is prevailing glucose level. Non-invasive blood glucose monitors are there, which are being divided into optical methods, microwave methods, and electrochemical method, which are in the process of evolution. Now, whether the glucometer reading and the plasma glucose which is done in the lab should be same, or there could be a difference. And if there could be a difference, what are the possible areas or possible causes for the difference? First is the glucometer strip, whether it is properly stored in a sealed container, whether it has been kept away from the heat, moisture, or humidity, whether while doing the actual test, the area was clean without any alcohol and dirt, whether the coded appropriate strip was being used for the glucometer. So many things have to be taken into consideration before actually concluding upon the correlation between the glucometer and the glucose reading. One protocol that has to be followed is one has to match the glucometer reading with the lab reading, not the lab reading with the glucometer reading. What is the critical value which has been defined, which is said to be critical for glucose for adults if it is less than 45 or more than 500. For neonates, if it is less than 40 or more than 400. This is said to be critical where the consultant and or the patient's relative has to be informed immediately. Now, if we really take into consideration the fasting blood glucose and HbA1c, which has to be taken into consideration for actually diagnosis of diabetes. Now, if we consider the HbA1c, it shows a better index of overall glycemic exposure and risk of complication with an intra-individual variability less than 2%, with the standardized methods with the precision of 2%. So HbA1c appears to be a better indicator to diagnose a case of diabetes. The reference for the same from various say, what is HbA1c? HbA1c is the result of non-enzymatic attachment of the hexose molecule to the N-terminal amino acid of the hemoglobin molecule. Now, which are the methods which are available for estimation of HbA1c? One is a ion exchange, that is HPLC, cation exchange, SPLC, boronate affinity chromographic method, capillary electrophoresis, enzymatic method, and immunoassay. Now, what is the reference interval which is followed as per the ADA guidelines for HbA1c? Normal is taken as between 4 to 5.6%. Increase where patient is likely to develop the diabetes mellitus is taken as between 5.7 to 6.5. And more than 6.5, patient is considered as diabetes mellitus. For the therapeutic goal of glycemic control, it should be less than 7%. Now, this is the methodology with their principle of the same. At our end, we do an exchange HPLC, where it separates hemoglobin species based upon the charges, and simultaneously it detects various hemoglobin variants. Now, this is the picture of chromatogram from one of the equipment that we have. Whether the HbA1c could be falsely elevated and falsely decreased. Yes. So what are the causes of falsely elevated HbA1c? Increase in the lifespan of our bases or decrease in the turnover. For example, any nutritional anemia, iron deficiency anemia, B12 deficiency, folate deficiency, all these have increase in lifespan and decrease in red cell turnover. So this will show falsely elevated HbA1c. Hypertriglyceridemia more than 1750 milligram per deciliter. Hyperbilirubinemia more than 20 and uremia. Lead poisoning, chronic ingestion of alcohol, salicylates and opiates. Vitamin C, rarely taken 1 gram per day, may lead to estimation of A1C more than expected, more so ever if it is done by electrophoresis. Falsely decrease HbA1c. This could be because of decrease in the lifespan of our bases or increase in turnover, which is commonly seen in hemolytic anemias, acute or chronic blood loss, and splenomegaly, end-stage renal disease, therapeutic therapies with vitamin D, ribavirin, and gamma interferon, and not one of the most important factors is variant hemoglobin, more so ever HbS, HbC, HbE, HbD at various percentage as per the equipments. Now let us come to another two analytes which are being used for estimation. These include insulin and C-peptide. Now, insulin, first isolation of insulin was done in 1921. Now, almost after 50 years, the first isolation of C-peptide was done in 1967. Now, insulin and C-peptide, they actually are derived from a molecule called as proinsulin, which undergoes proteolytic cleavage, and the breakdown results in the formation of insulin and C-peptide. Insulin is a 51 amino acid polypeptide released from beta cells of islet cell ganglions with a half-life of only 5 minutes. Now, the hormone which is going to control your glucose has half-life of only 5 minutes. When there is increase in insulin, it is because of increase in glucose, amino acids, or stimulation of parasympathetic system. Decrease in insulin is because of decrease in glucose or sympathetic stimulation. The target organs for insulin action are liver, muscle, and adipose tissue. Brain, kidney, and intestine are not insulin dependent. Now, requirement for insulin is, it could be fasting, post-meal and random. It should be a non-hemolyzed plain sample. Preferably, the sample for insulin should be separated within 2 hours of collection and refrigerated. Now, generally, in type 1 diabetes, the insulin level decreases due to destruction of beta cells. In type 2 diabetes, in the earlier phase, insulin is normal or increased because of the insulin resistance that we see. But later on, as the beta cells of islets are flying around, they go into exhaustion and again the destruction. So again, there is decrease in insulin. The reference interval for this fasting insulin is between 2.5 to 25 microunits per ml. For post-meal insulin is up to 150. C-peptide molecule, which is resulting from the cleavage of initial proinsulin, is a 31 amino acid molecule with a half-life of 30 to 35 minutes. See, the insulin had a half-life of only 5 minutes, whereas C-peptide has a half-life of 30 to 35 minutes. It represents the mid portion of proinsulin molecule. Now, as the C-peptide passes through the portal circulation, where actually insulin is destroyed to certain extent in the form it is being utilized or it is getting adhered to the receptors there, the C-peptide passes through the portal circulation and C-peptide is actually removed only by the kidneys. So it has a half-life of 30 to 35 minutes. What are the causes of low levels of C-peptide? It is type 1 diabetes mellitus, Addison's disease, and liver disease. What are the causes for high levels of C-peptide? Type 2 diabetes mellitus, insulin resistance, Cushing syndrome, pancreatic tumor, that is insulinoma, and kidney disease. The reference interval for C-peptide in the random state it is 0.78 to 5.9. In the fasting state is 1.1 to 4.4. In the post-glucose state, it is 2.5 to 6.5. This is the algorithm which is expected to be followed in the case of hypoglycemia and if the insulin and C-peptide are estimated. Now, if glucose is low with the high insulin and high C-peptide, the possibility of potential insulinoma should be taken into consideration. If glucose is low with the high insulin and low C-peptide, that does mean this insulin is high, but still C-peptide is low, means their insulin, which is administered from the outside, has been estimated by the equipment. This is called cross-reactivity. This is an algorithm which is expected to be followed for the diabetes mellitus diagnosis. First is a fasting plasma glucose more than 126, HbA1c more than 6.5, 2 hours post plasma glucose more than 200, random plasma glucose could be more than 200. Now an estimation of C-peptide and autoantibodies should be done. If an individual is positive for autoantibodies and C-peptide is low, the patient is more likely to have type 1 diabetes mellitus. Now, if antibodies are negative, and in that case, if C-peptide is normal or elevated, it is either a type 2 diabetes mellitus or maturity onset diabetes mellitus. Thank you.
Thank you very much, sir. A very excellent presentation. And delegates have, I would say, really a very good academic feast in case of testing of diabetes, HbA1c, C-peptide, lot of things we learned new also. So about the question answers we'll take at the last. There are some questions. Thanks a lot, sir. Then we can go for the next lecture by Dr. Bhavana Jadhav. Now I would say a very important topic on thalassemia and hemoglobinopathy screening, time to wake up. We have to reduce thalassemia to the testings so that it should be a thalassemia free India, I would say. We can talk of Pune, at least we can have a good type of testing, because I think day before yesterday only I had some thalassemic child, and being a blood banker also, we had to give lot of blood to all these thalassaemic child, and it is very time consuming and becoming day by day difficult. So I request Dr. Bhavna Jadhav madam to take over her topic on thalassemia. Time to wake up, definitely. Please, ma'am, go on. Thank you.
Yeah, good afternoon, everyone. After the wonderful talk on uh, after the wonderful talk on glucose and analyte, am I audible?
Madam, yes, you are audible. Please go on.
Okay. Thank you so much, sir. So after a wonderful talk on glucose and analyte, which keeps varying throughout the day and night time, let's have a look at a parameter which never changes throughout our life unless we undergo a bone marrow transplantation. Yes, that is hemoglobin pattern. And yes, that is hemoglobin pattern. Any abnormality in the synthesis of the hemoglobin will lead to thalassemia and hemoglobinopathy. So today I'll touch upon a brief introduction of hemoglobinopathy and thalassemia, followed by a various laboratory methods available for screening and diagnosis, the burden of hemoglobinopathy and thalassemia, an Indian scenario, and for prevention of that, what important measures we can take. That the cases which we'll explain through HPLC case studies, followed by a focus on screening. So hemoglobin molecule is formed by a 4 O2 binding heme group, which are covalently linked with two parts of unlike globin chains. These globin chains are alpha and beta or beta-like globin chains. Alpha globin chains are located on chromosome 16, while beta globin chains or beta-like globin chains are located on chromosome 11. In adults, almost 95% hemoglobin is hemoglobin A, which is alpha 2 and beta 2 globin chains. HbA2 is alpha 2 and delta 2, which is 2 to 3.5%, and HbF is very minute amount, that is up to 2%. To understand the pathophysiology of thalassemia and hemoglobinopathy, we must understand the proportion of polypeptide chains of hemoglobin in utero and in adult. So in utero, in last trimester, almost 70 to 80% hemoglobin is hemoglobin F. While at birth, after birth, hemoglobin starts increasing, HbF starts decreasing, and HbA starts increasing. So after 1 year of age, HbF is almost less than 2%, while most is HbA, and HbA2 achieves adult level by 6 months of age. When we come to hemoglobin disorders, there can be 2-3 methods. There is quantitative reduction in globin chain synthesis leading to thalassemia, which is autosomal recessive single gene disorder. There can be structural hemoglobin variation due to point mutation of globin chains, shortening or lengthening of globin chains. In some of the situation, normal switch over of uterine hemoglobin F to adult pattern is not possible, leading to hereditary persistence of fetal hemoglobin, and there can be combinations of both thalassemia and hemoglobinopathy, where it can be HB-LAPOR leading to disorder. So hemoglobinopathy and thalassemia, these are two different genetic entities. The clinical presentation varies from clinical presentation is overlapping, which is varying degree of severity of anemia and pathophysiology. The commonest structural hemoglobinopathies are beta chain variant, which are of clinical significance. Though most of these are structural hemoglobinopathy are clinically silent, few of them produce clinically significant manifestations, which depends on their content. Because of modification in beta chain or alpha chain variant amino acid molecule, there can be alteration in the saturation and alteration in the O2 saturation, stability of the hemoglobin, and solubility of the hemoglobin, leading to clinical manifestations. Laboratory plays a vital role in the diagnosis and management screening of thalassemia and hemoglobinopathy. The laboratory test varies from a simple, inexpensive screening test to the advanced technique of proteomics, application of proteomics. The selection criteria for laboratory method is that it should be capable of detecting all common clinically significant hemoglobin variants. In addition to that, there should be accurate HbA2 and HbF measurement, as a diagnosis of thalassemia and hemoglobinopathy on time reduces the mortality and prevents the production of transfusion-dependent conditions. The choice of method depends on the workload available, biological material which we are going to study, whether it is dried blood spots or wet sample, analytical performance of the equipment which we are going to use, the local availability of instrument and personal support, the expertise to interpret the results, because as we go ahead and we'll see the different clinical conditions and the HPLC pattern, we'll come to know that the expertise is at most important in addition to the cost which test bears. So the screening methods can be simple screening method like single tube method, which can be used at primary screening method, and secondary screening can be done by available chromatographic and electrophoretic methods. Although this gives presumptive diagnosis, final diagnosis is dependent on the molecular technique, that is DNA study. This is naked eye single tube red cell osmotic fragility test, which is recommended by Thalassemia and Sickle Cell Disease Prevention Program, National Program. So this is a primary screening where it can be done as a to detect a thalassemia. This is a very simple test where we have to take a 2 test tube. In one test tube, we have to add 2 ml of blood, 2 ml of distilled water, and another tube we have to add 2 ml of 0.36% buffer saline. Keep it at add 2 drops of blood and keep it at room temperature for 30 minutes, which is easy to perform. After 30 minutes, we have to see the turbidity and read the white paper with a black line. If we can read the black line, it is negative test, and if we can't, then it is a positive test for thalassemia. It gives almost 92 to 95% sensitivity and 62 to 87% specificity for thalassemia screening. The another single tube method for the diagnosis of sickle disease is sickle solubility test. Here we add blood in a phosphate buffer solution. Diethionate present in the solution will reduce the oxygen tension, and the hemoglobin, if it is present, will get crystallized and turbidity appears. Here it is a positive test if we can't see the line on a paper, and if we can see if lines, then it is a negative test. Important point for the sickle solubility test is that we should always prepare a fresh reagent every time to avoid false negativity. Positive and negative known sample should be run along with each test. The positive test should be confirmed by either alkaline electrophoresis or HPLC or some confirmatory test, because it does not give the percentage of hemoglobin S, so phenotype is not detected. False negative test can be seen in anemia, severe anemia, infants less than 6 months of age, because there will be less hemoglobin percentage of hemoglobin S. History of recent blood transfusion, which will mask the minute amount of hemoglobin S present in the sample. Positive samples, false positive results can be given by some hemoglobin BARTs, hemoglobin C, Harlem, hemoglobin S, though these are rare. Unstable hemoglobin can give rise to false positive results, in addition to erythrocytosis, marked leukocytosis, and hypergammaglobulinemia. The secondary screening is done by hemoglobin electrophoresis, which is age-old technique. Initially, it was done on cellulose acetate with gel electrophoresis. Now we are doing, it can be hemoglobin electrophoresis can be done with the help of hemolysate, which is applied on a cellulose acetate paper at alkaline pH. Hemoglobin molecule moves from cathode to anode, giving rise to separate bands as A2, S, F, A. And along with A2, there will be C, E, O, Arab. Along with S, there will be band of S and D, D and G Philadelphia. So at times it becomes difficult to understand whether it is hemoglobin S or D or C or E. So in such cases, we need acid electrophoresis to be performed, where HbC gets separated from HbE and HbS gets separated from HbD. The advantages of hemoglobin electrophoresis is very simple, rapid, reliable method. It gives provisional identification of HbA and common structural variant hemoglobins, and HbH is detected as fast moving band. Although it is labor intensive, we can't run the single sample, we have to run the samples in batches, and HbA2 quantitation, which is done after running the gel by densitometry scanning or by spectrophotometry, is imprecise. So we can't use this method for, it is not recommended for thalassemia screening, although we can use this case test for hemoglobinopathy screening. Many variants show similar mobility and do not separate from HbA. Training and expertise is required, which is not always available to interpret the results. Another screening method is capillary electrophoresis. Here a capillary, silica capillary is used, which is a negatively charged, and the buffered hemoglobin fractions separate out at alkaline buffer based on their affinity for the positive and negative pole. Electrophoretogram gets recorded with the location of specific hemoglobins in specific zones, giving rise to 15 different zones with specific hemoglobin moving into the specific zone. This gives very good quantitation of HbA2 and HbF. More advantage is that HbE separates from HbA2. It detects minor variants also very accurately, and HbH and HbBARTs can be readily detected. Although there are limitations because many variants have similar mobility and very fewer similar variant to common structural hemoglobinopathy, and at times it becomes difficult to identify which is the hemoglobin which we are looking at. If HbA is absent in a sample that is in homozygous condition of homozygous sickle cell disease or homozygous E, then the zones will not get separated. In such cases, we have to rerun the sample with mixing this sample with normal sample, and then we can see the separation of zones. There can be false elevated of HbA2 or HbF in different structural hemoglobinopathy. Next is the high performance or high pressure liquid chromatography. This is the most widely used screening method worldwide. Here, there is one stationary phase that is a silica cartridge, where the passage, when here we pass the analyte of interest at high pressure, and then it gets absorbed, hemoglobin molecules, different hemoglobins gets absorbed onto the silica. The column is then perfused by a buffer, which is a mobile phase. Different hemoglobins elute out with the perfusing buffer at different characteristic time points in response to salt gradient. The eluted hemoglobin fractions are detected by photometer. The chromatograph is generated consisting of numerical and graphical data. The run gets completed, analysis gets completed within 6 minutes. The area under the absorption peak approximates the percentage of fraction detected, and each fraction is assigned as a window with a specific retention time. The advantage of HPLC is that it gives precise quantitation of HbA2 and HbF. It has different specific windows for common structural hemoglobinopathies, compact, user-friendly, and the samples can be run singly as well as in batches. Retention time of a variant is in reproducible number. Though it is said that HbH and HbBARTs are difficult to identify, we can always guess HbH looking at a chromatogram, which we can always suspect. Many variants show similar retention time, but yes, looking at a variant, retention time, including incorporating the findings of RBC indices and the percentage of hemoglobin interested in, we can separate and diagnose the variant hemoglobins. And HbA2 cannot be quantitated in the presence of HbE, but when it comes to diagnosis and clinical management, it may not be at times necessary to quantitate HbA2 and HbE separately. Let us see few more cases of HPLC as a useful tool for screening and diagnosis. For interpretation of any thalassemia or hemoglobinopathy study, we should first have a proper clinical history with age, because we have seen that the HbF percentage, HbA2 percentage, adult and pediatric biological reference ranges are different. Age of onset of symptoms. History of blood transfusion is one thing which is very important, because once we transfuse the patient, then the hemoglobin percent and hemoglobin pattern gets changes. Family history of any anemia or transfusion dependent anemia. Examination findings of splenomegaly carries a lot of importance and at times help to come to a conclusion in cases of doubt. With increasing migration, we should always consider ethnicity to come to a conclusion of structural hemoglobinopathy. The data should be always incorporated with the findings of RBC indices and morphology. And then comes the role of HPLC. When it comes to HPLC, there are checkpoints in the calibrator first. So it should have a flat baseline in the calibrator. Their peak profile should be sharp and symmetrical. The order of peak should be followed as F, P2, P3, A0, A2. If it is not followed, then the run may not be valid. Total peak area should be between 1 to 3 million. If it is not, then we have to either dilute the sample. There should be HbA2 and HbF calibration factor should be between 0.7 to 1.3. And HbA2 retention time, which is important factor, because if it moves, then the pattern, the windows will alter and the hemoglobin moving in specific window will change. So retention time is very important. It should be always between 3.65 plus minus 0.05 minutes. Once we pass the calibrator, next comes the role of quality control. That is internal quality control. We can't go ahead as we have seen. We have, after checkpoints of calibrator, we run internal quality control, low and high level quality control. And yes, we do participate in BIRAD ICAS and regularly. Points to check for an individual case interpretation. Always remember that P2 reflects HbA1c, which is acceptable up to 6%. P3 window give up to 6% is acceptable. It can increase in the sample which is degenerated, and more than 15% variant. If it is more than 15%, then variant hemoglobin should be suspected. HbA is a non-glycated fraction of adult hemoglobin. Look at the normal reference ranges of HbA, A2 and F, and always consider the possibility of more than variant hemoglobin being present at the very same time. This is the normal pattern where HbA2 is 2.8, HbA is almost 86%. See, the unknown peaks are there, which give, which are the various fractions of hemoglobin A, which can be summarized, and we'll get 100 total, which is always asked question that here hemoglobin A is 86% and HbA2 is 2.8%. Then what is the next part of hemoglobin which we are having? Yes, but if we do, if we add all the calibrated areas and area percentage, then we'll have 100% total. So this is the normal pattern of hemoglobin, that is A plus A2 pattern, which we see. If this HbA2 is 5.2, next is the HbA2 is 5.2, where the indices are microcytic hypochromic. So the diagnosis is clear that it is heterozygous beta thalassemia. But in HbA2 is increased, or how to interpret HbA2? HbA2 is interpreted in beta thalassemia trait, hyperthyroidism, megaloblastic anemia, sometimes in sickle cell anemia. It is decreased in delta thalassemia, delta beta thalassemia, alpha thalassemia trait, or HbH disease, and severe iron deficiency. With this background, let us go through case studies to understand the importance of screening. Here is the case one, who is a 4-year child, female child, came to us as an anemia workup. Her hemoglobin was 5 with normal RBC indices, but RDW is 36.8%. When we review her PBS, it was showing many targeting, sickle cell, NRBC, and then we did sickle solubility test, which was positive. The sample is subjected to HPLC, and as expected, there was HBS, which is eluted in S window, which was 78% with 15% of HbF and 3.1% of HbA2. So the diagnosis here was very clear that it was homozygous sickle cell disease. Next case is 5-month-old child presented with HB of 7.2 with microhypo-RBC indices and RDW of 29.7. When we look at the RBC histogram, there is wide distribution of RBCs with marked microcytosis, hypochromia, moderate polychromasia, targeting, and 15 to 20 NRBCs per 100 WBC, which we could see on PBS. HPLC run was showing HbA2 of 52.4%, HbF of 40%, and rest is HbA. Now, we know that HbA2 is measured only up to 8%. If it is more than that, then we should always suspect variant hemoglobin. So, to come to a conclusion, we run capillary electrophoresis, and here HbA2 got separated from HbE. HbE was 42.2%, where HbF was 50%. So, this was a case of double heterozygous HbE beta thalassemia. Now, question here is not only a diagnosis. The baby presenting with 5 and 7 HB with marked anisopoikilocytosis with presence of sickle cell, with presence of double heterozygous HbE beta thalassemia, it is a transfusion-dependent anemia. So what does it mean to us and to baby? So it is a burden of hemoglobinopathy. Look at the cost involved. The cost involved is direct cost involved is cost of transfusion, ion chelation therapy, concomitant medication, and frequent hospitalization. The indirect cost which family has to bear is loss of productivity, transportation. One person is continuously engaged with the baby. Apart from this, not only the cost, but the social stigma, the affected child, and everything, this results in a constant agony to child and parents. If we look at the treatment, then almost 90,000 to 1 lakh per child per year for an average weight of 4-year child is required to manage. Not more than 5 to 10% thalassemia major-born child receive optimal treatment. Ultimate cure is the bone marrow transplant, which costs around 16 lakh rupees with the minimum, if we say, and which is obviously out of reach of majority children. If child lives for 50 years, more than 90 lakh only for chelation. So this is burden not only to the family, but to the society. Looking at the prevalence, 1.5% of the world population are carrier of beta thalassemia. 50% incidence is from Southeast Asian population, of which India carries the most. In India, 1 to 17% carrier rate with an average of 3.2%. High prevalence in Punjabi, Sindhi, Gujarati, Bengalis, Luhana, and certain tribal areas of northern, western, and eastern part. As per WHO, 3 to 4.1% carrier frequency. For structural hemoglobinopathy, 1.2 baby per 1,000 live births. So with this high prevalence, if we look at India, then HbS frequency, that is sickle hemoglobin frequency, varies from 0 to 44%, which is predominant seen in central part of India. HbE frequency is very high in prevalent area of northern eastern states. HbD is less than 1% in Punjab, Gujarat, and UP, mainly. So question here is that, can we reduce this national burden? Unlike many other genetic disorders where couple at risk cannot be easily diagnosed, thalassemia and other variant hemoglobins gives us a tremendous opportunity for effective control of birth. The epidemiology of thalassemia is changing during the past few decades in some countries such as Cyprus and Greece. This is mainly due to the successful implementation of prevention program. If we start this, what are the challenges involved in Indian scenario? large and diverse population, limited awareness amongst people, not only in non-medical but even in medical fraternity, large late registration in antenatal clinic, inequality of available services with around 70% population residing in rural areas. What can be the solution? The population education, mass screening of high-risk community, genetic counseling for those who test positive for carrier, and prenatal diagnosis. If we look at the pattern of inheritance, both the parents are carrier who themselves are unaffected, but the affected child, that is the transfusion dependent child frequency is 25%, which may be 100% in each pregnancy. So with this, if we look at case first, in case 1, the mother and father both had a normal RBC indices with normal hemoglobin, and when we run their HPLC, both were positive for sickle HbS around 40%, and the diagnosis was heterozygous sickle cell disorder for both of them. So if we could have catch hold of both of them at this point, then we could have prevented the birth of homozygous sickle child. In second case, the mother was having micro-hypo-RBC indices, and as a routine dictum, it is considered as an iron deficiency anemia. We keep up pushing iron therapy to patient and think that it is iron deficiency. No doubt, in India, iron deficiency is more prevalent than hemoglobinopathy, but that is not the only thing which we should look into. We should always keep the possibility of hemoglobinopathy in mind. When we run HPLC, we got HbA2 of 25.8% in A2 window. So looking at this, I can say that this is hemoglobin E, because hemoglobin A is unstable hemoglobin, and in heterozygous condition, it is usually between 25 to 30%. So this was a clear-cut diagnosis of heterozygous HbE, which can be separated on acid electrophoresis, and on alkaline electrophoresis, it moves with A2 only. Father of this child, who was double heterozygous delta beta thalassemia, was a case of heterozygous beta thalassemia. So hemoglobin E, usually homozygous HbE or double heterozygous HbE beta thalassemia. Homozygous HbE may be mild phenotype, but double heterozygous HbE beta thalassemia may behave as a thalassemia major or intermediate. When we have seen that heterozygous beta thalassemia with high HbA2 more than 4 to 8 and microcytic hypochromic RBC indices, situation is not so easy all the time. This is the study carried out by Dr. Roshan Kolai, where she has studied the parents of known thalassemia major child. And if we look at this data, this clearly shows that with normal MCV and borderline HbA2 between 3.6 to 4%, the parents were having heterozygous beta thalassemia. Now, let us see certain scenario of such cases in our study. Here is the patient, 43-year-old male, who was referred to us by gastroenterologist for jaundice workup. When we did, his hemoglobin was 11.3% with near normal RBC indices, mild anisocytosis, and PBS was showing mild hypochromia as well as ovalocytosis, polychromasia, few target cells, and teardrop cells. On HPLC, it turned out to be heterozygous beta thalassemia with HbA2 of 5.5% and HbF of 7%. Now, whether to label this patient as heterozygous beta thalassemia, we were wondering that whether there is any pre-analytical error involved. But that was not the scene which we cross-checked. And when we did his iron and vitamin B12 study, he was iron and B12 deficient. So because of that, we have to label this patient as most possibly heterozygous beta thalassemia with coexistent iron and vitamin B12 deficiency. In such cases, we have to repeat the workup after adequate iron supplement to see the persistence of micro-hypo indices and any other abnormalities we can do. Family study and DNA study is important in such cases. Next is case 4. Here, the 58-year female came for anemia not responding to hematinics. The hemogram was classic of thalassemia indices, beta thalassemia indices with microhypoblood picture, and INTIBC ferritin was normal. So serum iron study was normal. When we run HPLC, we found that there was hardly 3.8% of A2. But when we looked at P2 window, it was 10.6%. P2 window gives, if it is more than 6%, it gives HbA1c, that is glycated hemoglobin. We have his PSL fasting and PP levels available with us, which was in diabetic range, and we suggested him to do glycated HB, which turned out to be 11.7%. So this high hemoglobin HbA1c percent going into P2 window might have reflected in borderline HbA2 in such condition. That might have contributed for that. So in view of RBC indices and normal serum iron study, it is suggestive of heterozygous beta thalassemia. We have to always listen to what our morphology says. We can't only go by either RBC indices or HPLC pattern. We should always correlate both together. HbA2 interpretation in such borderline conditions is very tricky at times, and DNA study is necessary to decipher the thing. HbA2 can be in borderline conditions in non-beta thalassemia patient with severe iron deficiency, interaction of alpha and beta thalassemia with normal RBC indices, rare beta thalassemia mutation. Here is 1-year female who came for anemia workup. HB was 5.4 with normal RBC indices but wide RDW of 21.5%. When we run HPLC, we found 38.5% of HbF. So what can be the diagnosis? If we go by indices and HPLC, is it hereditary persistence of fetal hemoglobin? No. When we looked at HB, it was 5.4, which is unlikely for HPFH, and the morphology was showing marked anisopoikilocytosis, marked hypochromic microcytic RBCs, and many NRBCs. And look at the small sharp peak of normocyte, which is there sitting in a RBC histogram. So after looking at that, we asked for a history, and there was a history of recent blood transfusion. So pre-transfusion sample we ran where HB was 2.8% and HbF we got as 94.6% with normal HbA2. So this was a case of thalassemia major, where we have to give differential diagnosis as homozygous beta thalassemia, double heterozygous beta thalassemia, double heterozygous delta beta thalassemia. So family and parent study, or if necessary DNA study, is must for definite diagnosis of such conditions. So it's not only RBC indices and HPLC, but we should have proper history. And history of blood transfusion can alter the diagnosis. Let's have few another examples of microcytic hypochromic blood picture, what we see. So here is the 29-year female who came for ANC screening with classic thalassemia indices microhypo pattern, and we got HbF as 16.8% with HbA2 normal. So this was a case of heterozygous delta beta thalassemia. In heterozygous delta beta thalassemia, or while interpreting HbF, high HbF, we should be very sure about the RBC indices, the sample quality, and the percentage of HbF, which is very tricky situation where it is borderline low RBC indices with borderline HbF, because it can be hereditary persistence of fetal hemoglobin. Usually in hereditary persistence of fetal hemoglobin, HbF is up to 40%, while in heterozygous delta beta thalassemia, it is usually up to 5 to 20%. When we did as a family workup of this ANC patient, to our surprise, we got this 63-year lady with similar microhypo RBC indices and almost 96% of HbF without presence of any HbA or HbA2. Yes, so this was a case of homozygous delta beta thalassemia. Look at the phenotype. At 63 age, she is mild phenotype, and the diagnosis is homozygous delta beta thalassemia. Point here to highlight is this sharp peak, which is seen at the early elution, sharp tiny peak, which is of bilirubin. So icterus. So bilirubin was 2.4%, unconjugated was 1.91%. Another case of recurrent anemia in a 26-year male where 5.9 was HB and wild RDW of 43.9%. If you look at the histogram, there were very tiny microcytes sitting in the PBS. There were NRBCs and moderate polychromasia. On HPLC, we could see nice M pattern at the beginning of the elution with low HbA2. So this was a case of HbH disease. So as I said, on HPLC, though we can't quantitate the HbH, we can identify the HbH disease. So significant peak appears in the first minute of elution. HbA2 is usually low and molecular studies are required for the confirmation. On alkaline electrophoresis, it can be seen as fast moving band 1 to 40%. Alpha thalassemia syndrome, hydrops fetalis is incompatible with life and hemoglobin H is present, usually presents as chronic hemolytic anemia. HbH precipitation can be seen by brilliant crystal view on a weight mount. Here is another case of anemia workup and microhypo blood picture. So till now we have seen alpha thalassemia, delta beta thalassemia, and beta thalassemia, homozygous and heterozygous. Now let's see what happens when these thalassemias can coexist with hemoglobinopathy, that is structural variant hemoglobinopathy. So in this, though there were microhypo RBC indices, along with few target cells, sickle cell were present. And when we run the HPLC pattern, we got again 78% of sickle window with 4.2% of HbA2. So the diagnosis was it can be either double heterozygous HbS beta thalassemia or it can be homozygous sickle cell disease associated with alpha thalassemia. To come to a conclusion, sometimes family study and parent study is necessary, and if necessary, we can do DNA study. We have seen that in homozygous sickle cell disease, the indices were normocytic, normochromic. However, if it is coexistent with any kind of thalassemia, the indices will be microcytic, hypochromic. On acid electrophoresis, H gets separated from D and G, and alkaline electrophoresis, there will be band in S region plus F will be present. To understand sickle cell disease, we have to always consider phenotype, which may change depending upon the presence of percent of hemoglobin F. Let's see another case of anemia profile of 25-year female, and we got D window of 85% on HPLC. Just to highlight that HPLC gives all these commonest hemoglobin in separate windows. So we have seen just now S window. Now here is the D window, which is at retention time 4.19, which is very specific for HBD. And hemoglobin D disorder, it is double heterozygous HBD Punjab with beta thalassemia, where HBD was 80 to 90% and HbA2 was increased. Homozygous HBD is usually clinically asymptomatic but present with normal red cell indices. The same is for heterozygous HBD. However, the percentage is 40% around. Here is the 4-year male from Sindhi community. The diagnosis was very clear-cut. It has come for a family screening with mild microhypo RBC indices. Just to highlight that Q India can be seen as an unknown window at 4.70 retention time and 19.6%. So RBC indices are usually normal or marginally reduced. It is an alpha chain variant. On HPLC, retention time is 4.77 plus minus 0.01 and the percentage is usually between 8.7 to 23.3%. So as I have said, looking at RBC indices, the specific retention time and the percentage of hemoglobin of that particular hemoglobin present, we can come to a conclusion what can be the diagnosis of variant hemoglobin, because the biorad also provides the library of this retention time and the specific hemoglobin eluting in that. Another case of ANC screening where there were micro-hypo-RBC indices and we got a P3 window of 32.2%. I have said that P3 window usually is seen in degenerated sample, but if it is more than 15%, then we have to always suspect the variant hemoglobin. So iron TIBC was little, iron was, in this case, the iron was deficient. And when we run the capillary electrophoresis, we got the diagnosis of HBJ. HBJ is an alpha chain variant, fast moving band on alkaline electrophoresis, and usually on HPLC, it gives 15 to 25%. Here is the another case of anemia workup. So P3 window is not only variant hemoglobin. HB was 8.5 with near normal RBC indices, mild anisocytosis. R flag for the WBC, machine has given system flag as aged sample. WBC differential had gone haywire, and on HPLC we got P3 window of 14% with A2 of 4.5%. Now what to do? Whether it is a variant hemoglobin or what else? But when we have RBC indices and morphology in our hand, we can definitely say that this is a degenerated sample. We repeat the sample and did the workup on fresh sample when we got microcytic hypochromic RBC indices and clear-cut HbA2 of 5%, which was a case of heterozygous beta thalassemia. So we have to interpret P3 window with cautious, with looking at RBC indices. Till now, we have seen the cases of the differential diagnosis of micro-hypo RBC indices. Now, let's have a look at normal RBC indices, ANC screening patient, and there was a A2 of 39.8%. In HBE case, we have seen the HbA2 of 25%. Here, the HbA2 is almost 40%. So, this is most probably HBD Iran. HBD Iran is one variant hemoglobin which doesn't get eluted in D window, but it elutes in the HbA2 window. So while interpreting the results, we must note down the HbA2 quantitation. In brief, we have to always remember that any heterozygous condition will have HbA more than 60% and variant hemoglobin is less than 50%, around 40%. Again, normal RBC indices and A2 is showing 17.9%. Looking at the A2 percentage and upward hump in the downward slope, we can say that this is HB Lepore. HB Lepore is another important hemoglobinopathy to diagnose at early stage, and we should aim and focus at diagnosis because in homozygous condition, it gives rise to phenotype of thalassemia major with 85% of HbF and 15% of HB Lepore. So it is always important to screen at early age for such patients. This was a sample received to us for ILC and with normal RBC indices, and we could see a groove on a A2, that is split HbA2, so which was a delta chain variant. So till now we have seen that micro-hypo RBC indices may be due to iron deficiency anemia, heterozygous beta thalassemia or delta beta thalassemia, alpha thalassemia, homozygous HBE or heterozygous HBE disorder. And normal RBC indices can be because just looking at the RBC indices, can we come to a conclusion? No. So that's why we have to have a screening. Now, whom to screening, when to screen? Usually, pre-marriage screening is done of schools and universities where the diseases are structural hemoglobinopathy and thalassemia seems to be highly prevalent, like tribal areas and all. But because of social stigmas, this is not a successful program as yet. Preconception screening can be done. Antenatal screening can be done. In antenatal screening, if one of the partner comes positive, then the spouse should be studied or screened for the thalassemia or hemoglobinopathy. If it is a IVF, then donor or husband screening should be done. The aim of the WHO has decided the aim of prevention of thalassemia and hemoglobinopathy is to give affordable treatment to affected child and to reduce the frequency of and birth of the affected child. So prenatal diagnosis. In prenatal diagnosis, the aim is to diagnose beta thalassemia major, delta beta thalassemia major, hemoglobin S beta thalassemia, double heterozygous HBE beta thalassemia, sickle cell disease, double heterozygous sickle cell D disease, double heterozygous sickle cell E disease, and HB Lepore beta thalassemia. So our aim of screening is always to prevent these conditions. Hence, we have to always do screening for and at least antenatally. Newborn screening. Newborn screening is mainly recommended for sickle cell disorders with highly prevalent areas. Early diagnosis reduces risk of streptococcus pneumoniae infection through penicillin prophylaxis. How can we contribute to this? See, this is our data of AG Diagnostics, where in 2018 we did almost 2,000 cases, more than 2,000 cases, in 19 more than 2,500 cases, and in 2020 we did more than 3,000 cases. If we look at the workup which we have done, our data of ANC screening suggests 68%. So we have done a good job actually, but we being a tertiary referral center, we expect such kind of screening, but such kind of screening, if it is done at tribal level, then yes, it can be prevented. How can we help in this? We can suggest when we see microhypo-RBC indices or suspect thalassemia, looking at a Menzer index, which is calculated as MCV divided by RBC count, and if it is between 9 to 12, we can always suggest that yes, you do hemoglobin electrophoresis workup. We have done we have diagnosed almost 75-year patients like this, and they have done family screening and got their grandson and granddaughter tested for hemoglobin electrophoresis for thalassemia and hemoglobinopathy. So that's how we can contribute to prevention of such child. In family screening, it is hardly 7%, and newborn screening, it is 13%. So in newborn screening, we got almost 11% HBS, HBD Iran, HBD Punjab. So which is according to our Indian data, which is hemoglobinopathy is prevalent in areas. S window is 7.4% in this newborn, who is a most probably case of heterozygous sickle cell disorder, because HbA and HbS is going hand in hand, 60% and 40% proportion. These are the various cases which we could diagnose. The normal pattern out of 3,000 cases which we studied in 27-25, thalassemia major, where 10 babies, that comes to almost 1%. Thalassemia carrier status has come to 5.9%, and structural hemoglobinopathy is 1.9% in our data. So to conclude, screening and diagnosis, we have to consider clinical details, family study, available laboratory data, and skill and experience to interpret the results. While interpreting HPLC chromatogram, always check for baseline, retention time, peak areas, shape, and percentage of hemoglobin. Many hemoglobins often have same retention time. So look at the window, look at the percentage of retention time, and look at the hemoglobin proportion. So to summarize, screening for carrier states help to minimize the incidence of thalassemia and hemoglobinopathy. HPLC quantify HbF and HbA2 precisely and hence play a vital role in the screening and diagnosis of thalassemia. HPLC is the highly recommended method for newborn screening and prenatal diagnosis. Though single method is not sufficient for definitive identification of all hemoglobin variants, with the help of gel or capillary electrophoresis, we can narrow down the differentials. DNA study may require to identify variant hemoglobins and combinations of thalassemia. Family studies often resolve the diagnosis in problematic cases. This is the team which is involved in day-to-day diagnosis of and screening of thalassemia and hemoglobinopathy. Thank you all. So hemoglobinopathy, when you seek, you shall find. So let us start screening. Thank you very much for patient hearing.
Yeah. Thank you, madam. That was an excellent lecture. And I think it touched many aspects of all the diagnostic facilities which you can provide, right from the, I think, pediatric age group to the adult age group. And you have done the case discussions also, I think. So there will not be any case discussions after this, no? Can we take some questions?
Yes.
We still have one more session.
Is there one more session after this? Okay.
Yes.
So we will have some questions at this stage, and then we will have some questions after the case discussions. I'm having one question for madam, for anyone can answer out of your faculties. Why don't we promote adolescent thalassemia screening? I think we should have an adolescent thalassemia screening, and we should really promote that concept through all the laboratories and all the clinics, so that we don't go to the antenatal thalassemia detection.
Yes, madam, it is actually a very nice suggestion, and which is in fact one of the screening program which is implemented. But as we can see, there is a social stigma, and if someone turns out to be positive for thalassemia heterozygous or for heterozygous hemoglobinopathy, then the family might get exempted from the marriage, and people usually avoid to go for that. So that's the thing, that's the social stigma which still patients are having. So it is not as strongly done as we are thinking.
Oh, that is a very bad this thing, but it should not be a social stigma actually.
Yes, yes, but that's the problem.
We should have such social groups or NGOs who should promote
Yes,
like this concepts of having any girl or any boy who is having a persistent anemia. I think we should go in for an hemoglobin electrophoresis as soon as possible.
Yes, actually we have done such a small exercise and found, but there are many iron deficient patients as well as the patient of as well as we could get carrier females, and we have done that study, but it is too small and too early to say anything about that.
Okay, okay.
Yeah.
Any questions, anybody? Can you take? Question Dr. Ravi Raj, I think he has asked, how do you know just by counting plasma cells in bone marrow aspirate or biopsy that they are clonal or not?
Yes, it's not only just counting plasma cell percentage on bone marrow aspirate or biopsy. It's not possible to conclude whether it is clonal or not, polyclonal or monoclonal. We have to prove monoclonality by doing either immunofixation or immunoflow cytometry, immunophenotyping.
Okay. So any other questions in, let us see some chat. No. Okay. So there was one question about credit points. So that Dr. Sancheti.
That is frequently asked question, I suppose.
Yes, I think.
Yeah. Yes, so few.
Nothing specific. We have to wait until the MMC formalities are done. You'll get the certificate within a week, or sometimes what happens, there's a huge crowd. You might have heard in the before, I think we were having a diary release program that time. Dr. Uttareswar also told more than 100 CMEs per month or maybe more. So it takes time also to approve, and after the approval we give all the certificates. So please bear We are doing our best for that, and you will receive the certificate.
Online, you will receive the certificates online.
You can see it on
10 to 15 days.
MMC also. You'll see your credit points are added there, so don't worry. So, okay.
Yeah.
So, madam, please, we can go for, next session, guest
Yes.
presentation. Please.
Yes.
Just give us 1 minute, please. We are getting the presentation ready. So we are at the absolute fag end of the day, and I hope the participants, which I can see here, the entire number is still awake. We have a set of 3 cases where the common thread amongst them is autoimmunity, but the organs involved or the systems involved are completely, totally different. So autoimmune disease, the immune response in autoimmune disease is directed against self-antigens. It could be either localized within a specific organ, say, such as the thyroid. That is the most common prototype of autoimmune disease, in fact, is Graves' disease and Hashimoto's thyroiditis. Or in brain, multiple sclerosis, as in multiple sclerosis. Or then it could be a general inflammatory condition involving more than one systems, for example, in systemic lupus erythematosus or SLE. Autoimmune diseases are mostly marked by a relapsing and remitting course. If we use the presence of autoantibodies as an indicator for autoimmunity, we will find that there are many types of autoantibodies directed against many different self-antigens. And if we were to test the serum broadly enough, we would find some antibodies in most healthy individuals. So does it mean that only the presence of antibodies is an indicator of autoimmune disease? No. What happens is when you actually get an autoimmune disease, it is an interplay of various factors. There is a genetic predisposition. So superimposed on the genetic and epigenetics, you have the environmental triggers. Many a times it could be an infective agent, lifestyle factors, and then the immune balance. So it is only when all of these factors together lead to immune dysregulation that we would see the manifestations of an autoimmune disease. This is the prototype. I've shown type 1 diabetes in this, where if you can see that there is a genetic susceptibility, the environmental triggers will act at a certain point of time, and slowly, gradually, the immune dysregulation occurs over time, and you will get overt clinical disease. So this is broadly applicable to most of the autoimmune diseases. Now, if we thought that autoimmunity and autoimmune disease was uncommon, no. There are almost about 100 diseases which are classified as autoimmune diseases, and autoantibodies have been identified for each of these. We will be presenting here 3 cases: autoimmune hepatitis. Then my 2 colleagues, Dr. Parag and Dr. Girish, will be presenting autoimmune hemolytic anemia and celiac disease. So beginning with case 1, a 59-year-old female patient. So who was she? Actually, my husband has grown up in Chembur, Mumbai, in the BARC area. And this particular person used to stay in our society. I had seen her somewhere in 94, 95, I guess, after which I shifted to Pune, and I had absolutely no contact as such with her. I was very surprised to see her then in our AG Diagnostics main lab at Bhandarkar Road one fine day. In fact, I almost didn't recognize her, but she had traced me out from some common contacts and had come to us. She came with complaints of weakness, fever, yellow discoloration of sclera, which I could pick up right when she walked in, and deep yellow urine since a month. Now, despite, as most of the patients do, when she herself realized that she has jaundice, she had gone to an Ayurvedic practitioner and she was taking some Ayurvedic treatment for about 2 weeks. But there was no improvement. And so she had decided to approach me because she had shifted to Pune just recently. And I was probably the only doctor she knew in town. So obviously the first thing we did was an LFT on her in the lab. We did a hemogram, LFT, PTINR, urine routine. And because she gave a history of diabetes, we did blood sugar. After seeing the reports, the bilirubin was raised. Total bilirubin was 18.25 milligrams per DL. Direct was 17.80 milligrams. Raised SGPT, SGOT. I asked her to consult a physician who asked her to get admitted immediately in a nearby hospital. The other investigations were SGPT, SGOT were raised. Like I said, gamma GT was raised. The prothrombin time was 19 with an INR of 1.54. Urine routine, the color was deep yellow and there was bile pigment positive. So the possibilities here would be infective hepatitis, a drug-induced liver injury or DILI, autoimmune hepatitis, and then the other causes of hepatitis like Wilson's, alpha-1 antitrypsin, etc., which are a little rare. So I have put these down as other investigations. Some of them were done in our lab. Some of them were done in the hospital where she was admitted. So her hepatitis markers were negative. So the first impression that this could be infective hepatitis, more particularly the physician had thought of hepatitis E, was ruled out. Her IgG was raised, immunoglobulin G, ammonia was normal, and after radiological investigations were not contributory. And after this, her autoimmune workup was done. So her ANA by immunofluorescence was positive. Liver kidney microsomal antibody by IF negative. And the smooth muscle antibody asthma by immunofluorescence method was positive. So the diagnosis here was autoimmune hepatitis. Like I said, she was admitted on the 9th of July 2019. And look at her bilirubin. So her bilirubin had risen from 18 to 22 on the 11th. And it was consistently in that range. After the diagnosis of autoimmune hepatitis, she was started on steroids. Prednisolone was started on 16/7. And you can see the marked decrease. By 22/7, her total bilirubin was 10. She was discharged with oral steroids. Otherwise, she had been given only supportive treatment. So this is the comprehensive chart showing her journey. On the 9th of July, she had a bilirubin of 18.25, like I said, and she's regularly following up with us. Her steroids continued till Jan 20, and by then her bilirubin had dropped to 0.6 total. SGPT was 14, so absolutely within normal limits. The next 3 follow-ups were a little spaced out because of the lockdown. So she came in June 20, August 20, and now in January 21. And if you see, her liver function test has been maintained within normal limits. So autoimmune liver disease, the spectrum is autoimmune hepatitis, primary biliary cholangitis, primary sclerosing cholangitis, and IgG4 related disease, which is a slightly new entity which has been described. Autoimmune hepatitis is characterized by interface hepatitis, hypergammaglobulinemia, autoantibodies. Subclinical and asymptomatic disease is common. Therefore, it needs to be considered in the differential diagnosis of all patients with elevated liver enzymes. So there are many a times in routine practice that we see an LFT where the bilirubin, protein, everything is normal, but the SGOT, SGPT are increased. And if you see this happening on 2 or 3 occasions, the commonest causes, of course, are chronic hepatitis, drugs, and the third could be autoimmune hepatitis. So please do think of it when you see elevated liver enzymes in LFT. So AIH or autoimmune hepatitis classically is in 2 types, type 1 and type 2. Our patient fitted perfectly in the type 1 group, where the characteristic autoantibodies which we see are anti-smooth muscle antibodies, ANA and PNCA. The age of onset, it is bimodal. There's a peak at 10 to 20 and another peak at 45 to 70, where my patient fitted in. And there is 78% female preponderance. IgG is increased, like it was in this case. There is no IgA decrease in type 1. Of course, we cannot check the association with the HLA haplotypes so easily, and it is not really required for routine clinical practice. Type 2 AIH, on the other hand, shows presence of the anti-LKM antibodies. So AIH-associated antibodies can be grouped into type 1 and type 2. For type 1 AIH, we have ANA, asthma, and anti-SLA-LP or soluble liver antigen, liver pancreas antigen. Type 2 shows anti-LKM, anti-LC1 or liver cytosolic antigen type 1, and anti-SLA-LP. We're showing a picture here of how the anti-smooth muscle antibody looks on immunofluorescence. Here, I would really like to share that the immunofluorescence images that we see, we do a variety of tests by the immunofluorescence technique, and they are really very nice to see. I'm sorry that I'm saying that about a disease condition or something which is not a very happy scenario for the patient. But what I'm saying, immunofluorescence really brings out very strongly the interpretation or identification of these antibodies. So immunofluorescence is the method of choice for detecting most autoantibodies in most autoimmune disorders. So here for autoimmune hepatitis, we offer these 2 profiles by the blot technique also. So we can use a variety of techniques for detection of autoantibodies. It could be immunofluorescence, it could be ELISA, it could be the blot technique. And we have to use a combination of all these techniques depending upon the disease in question. So this is an algorithm which shows that if there's a liver disease of unknown origin, that is, you've already ruled out the infective hepatitis or the drug-induced, then do resort to the autoantibody test. And if the ANA, SMA, LKM, and SLA-LP are positive, you have to consider autoimmune hepatitis. Of course, the final diagnosis comes on a liver biopsy. And if these tests are negative, you could still think of an autoantibody negative AIH. And then repeat testing in specialty labs for the further autoantibodies, and again consider AIH as your diagnosis. With this, I will hand over to Dr. Parag Ratnakar, my colleague, for his case presentation. Just give us a minute for the switch, please.
Good afternoon, all of you. I will be starting with the case number 2, but actually it's a combination of 3 cases. So case 1 was a 16-year-old male child who presented with complaints of weight loss, anemia, and failure to grow. Pediatrician did his clinical examination and couple of tests, and he was referred to us for finally for TTG and endomysial antibody IgA with suspicion of certain diagnosis he was expecting. So we performed those tests, and we were, getting very strong results. I mean, TTG IgA was positive, more than 200 was the titer, and endomysial antibody IgA was also positive. It was by immunofluorescence. There was case B, which was 35-year-old male who also presented to gastroenterology clinic with complaints of discomfort, bloating, distension, and almost a weight loss of 7 to 8 kgs in 4 months, which was a significant weight loss. Upon detailed clinical examination, he advised and he was referred to us for following investigations, again the TTG and endomysial IgA. And we performed those tests and we got similar results. I mean, the TTG was positive and endomysial IgA was also positive. The third case we decided to include just yesterday because I happened to talk to her personally, because we do have a habit of calling our patients, taking detailed clinical history telephonically, which we did. And we got a very interesting history in this particular case. So we decided and we included this in today's discussion. She was 66-year-old female patient with abdominal complaints since many years of distension, bloating, hyperacidity, occasional episodes of nausea, vomiting. Didn't consult regularly as she thought and blamed it on hereditary causes, because incidentally her mother also had similar symptoms and never had a lasting relief. Finally, once I think her family physician told her to seek help from gastroenterologist, and she did meet one gastroenterology clinic. On detailed history, finally she was referred to us for hemogram, LFT, urine, and TTG IgA, which was a strong suspicion from the doctor. Now her other results were non-contributory. I mean, she had a mild anemia, probably iron deficiency anemia, but her TTG level, the titer came as 27.7, where the cutoff is 20. So these are the couple of results of the first case where the TTG was, which was done by ELISA method, which was positive, more than 200 was the titer. And we got confirmation in the same case. We had done immunofluorescence, as we just discussed, that immunofluorescence give beautiful images. This was the nice honeycombing, which is seen in case of anti-endomysial antibody, which we did was by immunofluorescence. So these were the confirmatory tests. So just on this confirmation, the celiac disease, the diagnosis was confirmed by the clinicians, gastroenterologist, and the treatment was started. So let us discuss in brief what is celiac disease. The word celiac comes from the Greek word meaning suffering in the bowels. The celiac disease basically is an immune-mediated disorder which is elicited by wheat gluten and related prolamins, which is from rye or barley, in mind you, genetically susceptible individual. Not everyone is getting these kind of diseases. Now, what are prolamins? Prolamins are the proteins which are rich in proline and glutamine, and they are soluble in alcohol but insoluble in water. And they actually, what they basically do is disrupt the tight junctions between enterocytes, which allow large amino acids to enter circulation and thereby stimulating the immune response. Now, genetic predisposition is seen in HLA DQ2 and DQ8 is, sensitivity and specificity, which is shown in figures, basically. Now, as coming to pathogenesis of a celiac disease, the three factors which play a major role from the point of view of disease causation is environmental factors, of course, by eating gluten containing food, which is majorly seen in barley, rye, and wheat. Immunological factors, which is presence of autoantibodies, anti-endomysial, anti-TTG, and anti-gliadin, three major autoantibodies which are blamed in this. And of course, the genetic factors, which are HLA, DQ2, and DQ8 alleles. Now, the gliadin is the glycoprotein extract from the gluten, is the major culprit which causes actually the entire disease. It is directly toxic to the enterocytes of genetically predisposed individuals. It causes overexpression of IL-15, and it becomes ultimately eventually cytotoxic, which is killing enterocytes on disease progression. Now, gliadin upregulates this hormone on the stress molecules, and thereby causing changes in the receptors and the cells, in the entry of cells into the lymphocytic entry into the villi, which is causing the loss of villi and villus atrophy, which is seen as confirmed by the histopathology. Now, loss of villi and this atrophy actually leads to malabsorption of nutrients, and which leads to malabsorption syndrome features, diarrhea, steatorrhea, and other nutritional deficiencies. Now, this activated lymphocytes eventually stimulate B cells or plasma cells to secrete autoantibodies, which we detect by simple serological techniques. That is the anti-endomysial antibodies, anti-TTG, and anti-gliadin antibodies. Now, what are the clinical presentations? Clinical presentations, there are two groups which are significantly seen, the pediatric group and the adult group. In pediatric cases, classical symptoms vary from irritability, abdominal distension, diarrhea, failure to thrive, and weight loss. Most cases, they generally present between say 6 to 24 months of age with the history of introduction of gluten in diet. Few cases does present with dermatitis herpetiformis, which is a characteristic pruritic papillovesicular lesions on shoulders and arms and cheeks on these children. Adult cases presents with iron deficiency anemia or nutritional deficiency anemia, diarrhea, again bloating, fatigue and weight loss. And generally these cases present between 30 to 60 years of age group. Now, there are associated health conditions. I mean, whenever you come across these patients, you should ideally also look for celiac disease. There is an association of type 1 diabetes in almost 12% cases, autoimmune liver diseases, autoimmune thyroid diseases, IgA deficiency, Down, Turner's, Williams syndrome is classically associated, with celiac disease. First degree relatives of celiac disease, we should also look for celiac disease in other relatives. There is a significant up to 20% of prevalence which is seen in these cases. And there are other conditions like dermatitis herpetiformis, irritable bowel syndrome, endocrinopathies, short statures, delayed puberties, unexplained iron deficiency anemia, which is around 1 to 2% of disease association. Now, there's a beautiful picture which I got, which explains the celiac disease in a nutshell. Actually, what happens is as soon as the gluten is introduced, there are, the immune response which is generated, which can be seen by these autoantibodies on the left side, which you see anti-endomysial, anti-gliadin, anti-tissue transglutaminase antibodies. Which further leads to the destruction of villi and the celiac disease, which actually when it is confirmed by the small intestinal biopsy, which gives the classical findings of celiac disease. And ultimately, on the right side, which you see the associated diseases like diabetes, IgA deficiencies, and the treatment, of course, I will be coming to that point. Which includes gluten-free diet and the follow-up of these patients should be done. So I will just discuss that in a brief. So this is the algorithm which generally followed. You perform serological testing, which is quite cheap and easy to perform without troubling. You just take the serum sample and process it. So you do this TTG IgA, which is tissue transglutaminase IgA in the first settings. When it is positive, you can confirm by the anti-endomysial antibody, anti-gliadin antibody, and then the confirmatory, of course, done by the small bowel biopsies. So multiple punch biopsies are taken from ileal and jejunal loops, and then the confirmation is done. There are classical histopathology features which are, indicative of celiac disease. If positive, of course, you need to have a treatment and monitoring. And if negative, you should consider other diseases which mimic celiac disease. Now, there is a diagnostic algorithm which is coming up with recent advances and which says that along with these antibodies, there is one more antibody, anti-DGP, deamidated gliadin peptide antibody. This also should be followed up. Now, lab diagnosis, as I told you, is based on clinical symptoms and should be confirmed by serological testing and the small bowel biopsies. In serology, we are doing this test regularly in for all our patients or for our prescribers or doctors who are associated with us. Now, this includes IgA antibodies to tissue transglutaminase, IgA IgG antibodies to deamidated gliadin, and anti-endomysial antibodies, which are highly specific. Now, as I told you, the small intestinal biopsy, which becomes, the confirmatory test or hallmark of all this to conclude the diagnosis and to confirm the diagnosis of celiac disease. And biopsy specimens should be taken from duodenal or proximal jejunal loops, which are actually exposed to highest concentrations of gluten. And what it reveals is, the increased number of T lymphocytes, which I, discussed in the beginning at the pathogenesis of the celiac disease. With intraepithelial lymphocytosis, there is a crypt hyperplasia and villus atrophy or blunting of villi, which is seen. Now, serological markers are both, used to initially screen the patients and, of course, to monitor the follow-up. So basically, these are the tests which we regularly perform with their sensitivities and specificities on the right side. TTG is done by ELISA, which has a very good sensitivity and specificity to almost 90 to 100%. And the endomysial antibody, which is done by immunofluorescence technique, which gives very high eye sensitivity in children as well as in adult, almost again 90 to 100%. Anti-gliadin is less sensitive and as compared to anti-endomysial, that's the reason people choose TTG IgA anti-endomysial antibody for the confirmation of the diagnosis. As come to treatment, there is lifelong strict adherence once the diagnosis is confirmed to gluten-free diet. Prudent to exclude oats also, as there is contamination with gluten while harvesting, milling, and shipping. The threshold should be set to less than 50 milligrams per day, although the individual variability makes it difficult for a universal threshold. Monitoring with periodic visits for assessment of symptoms, growth, physical examination, and adherence, and periodic measurements of antibody levels where the lab pitches in with the follow-up serology testing. Now, these markers are used to monitor compliance with the gluten-free diet. Antibody levels return to normal generally within 3 to 12 months of starting gluten-free diet, but may take up to 2.5 years if the titers are very high. And repeat biopsy in 3 to 4 months of starting a gluten-free diet is not necessary if the patient is responding well to therapy and your serological markers are coming back to normal. I mean, there is an indication that everything is settling down. But if patient does not respond as expected despite the adherence, then other disease that mimic celiac disease should also be considered. Now, there is a term what is called as refractory disease, which may be because of, this disease has been present for a longer time, and may not be easily under control with the diet alone. The patient is maybe not adhering to the diet as well because they are consuming foods that are inadvertently contaminated with gluten. That's the another possibility. And in this case, steroids and immunosuppression should be considered, and the follow-up should be done at a later date. Thank you for patient listening. I will hand over to my colleague, Dr. Girish, for case number 3.
Good afternoon, everyone. I'm presenting case of 11 years boy came for anemia workup. This is his hemogram finding. Hemogram was processed on DXH 900 Beckman Coulter. WBC count was 11,800 and platelet count was 2,79,000. So nothing significant in those parameters, but his HB was low. HB was 8.4. And look at his MCV. MCV is 102, so it is slightly on higher side. And if you see his RBC histogram, there is wide distribution of RBC, indicating mixed population of RBCs. Now let's see what are those mixed population of RBCs in PBS. So in PBS, there are microcytes, normocytes, and some large cells. Those are polygramatophils. And scattered RBCs are some hyperchromatic RBCs. Those are round cells. These are called spirocytes. So based on these findings, what would be your differential? So spirocytes are particularly seen in 2 major diseases. First is immune hemolytic anemia, and another cause for spherocytosis is hereditary spherocytosis. So to confirm this or to rule out these diseases, we need to do some basic investigations. So these investigations are direct Coombs test, osmotic fragility test, reticulocyte count, and serum bilirubin. So the last 3 tests are increased in both. And osmotic fragility is also increased in both immunohemolytic anemia and hereditary spherocytosis. But direct Coombs test, it is specifically positive in immune hemolytic anemia. So DCT is main differentiating between these 2 causes of spherocytosis. So along with hemogram, his blood group is also asked. So it showed some very interesting findings. So to understand this, we need to look at some normal blood groups, how they appear on jail cards. So this is the jail card. This is for one patient only. So it has 6 columns, and first 3 columns are for forward grouping. Here we need to add patient cells. And the first column is for anti-A, second is anti-B, and third is anti-D. So positive reaction is considered when RBC remains at the top, and negative reaction is considered when RBC settles at the bottom. And last two columns are for reverse grouping, and these two columns are used for determination of antibodies present in the patient serum. So patient serum is required for last two columns. And fourth column is for control. I will tell you about control column at the last. So the second card, this is a normal blood group. This is not patient blood group. So second card is B positive. So there is reaction in anti-B column and reaction in anti-D. So the forward group is B positive, and in reverse, the opposite antibody is present. So antibody is present in reverse. There is antibody present in A1 cells. So this is AB positive blood group, and corresponding antibodies are absent. This is O positive blood group. The corresponding antibodies A and B both are present. And this is A negative blood group. There is a reaction 0 in anti-D column. So this is A negative blood group. So look at this, all 5 cards. There is no reaction in the control column. If there is any reaction in control column, it means there is some abnormality, whether it can be due to atypical antibody, or it can be due to some rouleau formation, or there is some error while doing processing. Now coming to that 11 years boy patient blood group, now look at his card. In forward grouping, means in first 3 columns, the reaction is present in anti-A, anti-B, and anti-D. So if all reactions are present, this means this blood group is AB positive. But now look at his last 2 columns, like in reverse group, the reaction is present in A1 cells, means this is discrepant blood group, means forward blood group and reverse blood group, there is discrepancy. So now to confirm this, we do tube agglutination also. In tube agglutination also, we saw there is discrepancy, means forward and reverse grouping is not matching. So we come to the conclusion, we release this report as undetermined because forward and reverse grouping was not matching. And we release this blood group with the interpretation, like in view of PBS morphology and blood group finding, possibility of atypical antibody interference or immunohemolytic anemia can be considered. And we advise some tests in the patient report. So these are direct Coombs test, atypical antibody screen, and a repeat blood group after completion of hemolytic anemia. So how to approach such blood group? So there is elution method, but this elution method is available only in advanced blood banks. It is not available routinely. So what it does is it removes antibodies, and we can determine the patient's blood group. But in case of emergency blood transfusion, if at all blood transfusion is required, we have to cross match with multiple donor units and transfuse with best compatible blood. We received his direct Coombs test also, and it was positive for IgG and or C3D. So we use polyspecific Coombs reagent. It does not discriminate between whether it is only IgG or only C3D. So it was polyspecific. So and the DAT is positive in both by column agglutination and tube agglutination also. So diagnosis was made DCT positive autohemolytic anemia. So some brief about immunohemolytic anemia. It can be of 3 types: autoimmune, autoimmune, and drug-induced. And autoimmune hemolytic anemia can be of 3 types: warm antibody-induced, cold antibody-induced, and paroxysmal cold hemoglobinuria. So warm type, it can be primary or idiopathic. It can be due to secondary lymphoproliferative disease, or it can be due to other autoimmune diseases like SLE or other causes of autoimmune. Cold antibody also, it can be primary or idiopathic, secondary to mycoplasma infection, secondary to EBV infection or infectious mononucleosis, and it can be due to secondary to lymphoproliferative disease. And this PCH, means paroxysmal cold hemoglobin, it is very rare and it usually occurs in children. 40 to 70% of autohemolytic anemia are of warm type, and 15 to 25% of AIHA are cold antibody type. So how to approach this AIHA? First question needs to be answered, is there hemolysis? So if hemolysis is present, then following test needs to be done to rule out hemolysis. So on peripheral smear, you will see spirocytes, agglutination, and polychromasia, and there is increase in unconjugated bilirubin. Reticulocyte count will be increased. LDH is also increased. Haptoglobin, it is decreased in hemolysis. So it is more severe. It is markedly decreased in intravascular hemolysis and only mild decrease or normal in extravascular hemolysis. And there is presence of hemoglobin, free hemoglobin in the urine. So there are multiple causes of hemolysis. It can be hereditary or acquired. So hereditary causes due to RBC membrane disorders like hereditary spherocytosis, hereditary electrocytosis, some enzyme disorders in RBC, G6PD deficiency and pyruvate kinase deficiency, hemoglobinopathies or thalassemias. Acquired causes can be immune and non-immune. So immune I already discussed. Non-immune causes can be DIC, infections, PNH, severe burns, and TTP or HUS. The immune origin can be deciphered with the help of DAT or direct Coombs test. So it will be positive for IgG or C3d. So what type of AIHA is present? So we can determine with the help of DAT. So in that we can use monospecific DAT. In warm type of AIHA, that is positive for IgG or C3. In cold type, that is positive for C3. In mixed type, it is positive for both IgG and C3. And in PCH, it is positive for C3. In PBS, in warm type, spirocytes are prominent, and in cold AIHA type, RBC agglutination is more prominent. So treatment of warm AIHA, the first line of treatment would be corticosteroids, and 80% of patient responds to warm AIHA. And if patient doesn't respond to corticosteroid, then second line and third line treatments can be used. And treatment of cold agglutinated disease, cold agglutinated disease are less responsive to corticosteroids compared to warm autoimmune disease. After few days, we received his autoimmune profile, and it was positive for ANA and dsDNA. And final diagnosis was made autoimmune hemolytic anemia secondary to SLE. And in SLE, there are in SLE 85% of patients show hematologic manifestation, and hemolytic anemia can be seen in 10% of patients in SLE. Thank you.
Thank you, Dr. Parag and Dr. Girish, for those wonderful case presentations. So as we have seen, we have tried to cover at least 3 cases out of the entire autoimmune disease spectrum. Like I already mentioned, there are almost about 100 diseases listed as autoimmune disorders. And there is a role for the lab in screening and diagnosis of these conditions, monitoring the course, and to detect relapses and recurrences. So we have a variety of techniques in our armament: immunofluorescence, on which we do ANA, dsDNA, anti-MuSK antibodies, endomysial antibodies, MOG, NMO antibodies for neuromyelitis optica, anti-smooth muscle antibodies. Then we use the ELISA technique for ANCA, anti-GAD65 for diabetes, gliadin antibodies, acetylcholine receptor antibodies for myasthenia gravis. The blot technique for ANA blot. We also now offer an ANA blot 17 antigen test, which is for another upcoming area of interest, that is myositis. So this ANA blot includes antigens for myositis. Then the liver blot, which I already mentioned when I discussed the autoimmune hepatitis case. The CMI method is used for thyroid antibodies, one of the commonest autoantibody testing that we do. So this is our data in the year 19 and 20, where if you can see our maximum workload is in the for ANA and dsDNA, because this test is basically used as a screening test for the presence of autoimmune disease, it could be present along with the specific antibodies in the other groups. That is, autoimmune hepatitis will have its own set of autoantibodies as well as antibodies from the ANA group. So we, like I said, our highest workload is by ANA by IF, because ANA by IF is the recommended gold standard screening test for anti-nuclear antibody. We also do anti-GAD65, anti-acetylcholine receptor, anti-MuSK antibodies, MOG, NMO, NMO. And again, like you see, the thyroid antibody testing forms a large section or large proportion of our autoantibody work. So what we have tried to do today is that we have tried to present a variety of topics from protein electrophoresis to hemoglobin electrophoresis, autoimmunity, allergy, intolerance, and of course, the topic of the time, COVID-19. In fact, learning for doctors is an continuous process. That is why we keep holding these CMEs, and AG Diagnostic team tries every year to put up a CME along with IMA for the last so many years, where we try to put in our effort and showcase the variety of tests that are required from us, from a lab today. And I hope that it has been an interesting session. I thank the entire IMA team from on behalf of AG Diagnostics. Thank you so much, and over to Dr. Sanjeti.
Thank you very much, Dr. Avanti Madam, Vedanti Madam, and Dr. Manisha Patwardhan Madam, and all the team of AG Diagnostic. I would say this was really a great day in the history, because we have one of the best of academic feast today. Now I request our Vice President, Dr. Meenakshi Deshpande. I think we have to do virtual felicitations. I don't know how, but we'll try our best. So first,
we'll call out the names. So you can just ask those. We'll first felicitate these two stalwarts.
Yeah.
Dr. Manisha, Avanti Golwilkar.
Dr. Avanti Golwilkar. So this
Madam,
is our special
this is our
Upparne.
special Upparne for you.
We'll do it personally, but this is virtually today in front of the delegates.
That is perfectly fine. Thank you so much. In fact, we have partnered for this CME, and I think this actually formality may not be required at all.
Yeah, so, at least once we will do, because, and we thank the whole team of AG Diagnostics for giving such a wonderful CME, and it was a wonderful discussion which we had and which we followed by case discussions all throughout, and I think they must have been quite informative and eye-openers to all the attending delegates, who should attend not only for MMC points but also for the knowledge that you people give. Thank you. Dr. Manisha Patwardhan, I think again an Upparna for you.
Thank you so much.
IMA Pune.
Can I say one thing? We have been asking the entire IMA team to visit AG Diagnostics. So I would love to arrange that sometime in the next 2 weeks, and you could please come over.
Yes, we will surely do it.
Most interested to go for it. And actually, I was suggesting the same thing. Maybe you can invite some delegates also, one by one, as and when they have time, they should visit. There are about, I think now, to 14 delegates attending. Being Sunday, all of the delegates, I am really surprised that they are listening, enjoying.
I hope they are.
Yeah.
Sir, and all the delegates are welcome. If at all they wish to visit the lab, they can inform even your team, and we'll organize once we get the contact details.
Okay, madam. Thanks a lot.
Thank you.
And I think after 3 months, after a bit of, when
COVID is little bit decreased, we will plan that visit.
We can plan the visit also, and I request we can have another webinar session because this was a really excellent session, excellent presentation by all. So after 3 months, we can see also post-COVID, some, I would say, some discussions should be there, because a lot of people are asking for antibody test after vaccine लिया है, और वैक्सीन के बाद अभी क्या यानी उसमें एंटीबॉडीज है नहीं है, और we just want to know exactly what the situation is. So we can have such sessions also, maybe after a month or so. You just let us know what to do exactly. Patosa madam, let us know. Huh?
Yes, yes,
What to do
definitely we
exactly.
will
We will do
organize.
it accordingly. Thanks a lot. So should we conclude?
Yes.
From IMA Pune. So I thank all the faculties who have joined also, and all the delegates who were, complete throughout the session, right from 9 to now it is 5:30 p.m. Okay, thank you.
Thank you. Bye-bye.
Thank you, everyone. Thanks a lot.
Yeah, bye.
Thank you.
And thank you all other faculties also.
Yes.
Thank you.
Yeah.